भाई चाय आधा कप और दे दोगे क्या? चाय चाय पोहा तो कहाँ से बनेगा अभी। हाँ दे चाय दे दो।
Hello, check. Hello, test. Hello.
Oh. No. Mm. Doing. Huh? That's why that's good. Hi Rishabh. Hello, hello.
Hello, yes sir.
Hi Rishabh.
Hello sir, yes.
Okay, so
वो लगा दो, कैमरा लगा दो, ये लो, लाइव कर दो, इसको एडजस्ट कर दो. हेलो.
Hello.
morning boss.
Good morning. Can you hear me?
Very well.
हैं?
Very well, very well.
So, आपाधापी में now we are here at the beginning
करते हैं.
with so much of improvisations and everything.
No, no, good. So Rishabh, have you got my presentation? वैसे मैं अपनी तरफ से ही प्रेजेंट करूंगा, लेकिन गूगल ड्राइव मिल गया था लिंक.
मिल गया है.
ओके, एक बार मैं ओपन करके लगा. So I think initially जैसा प्लान किया था कि this initial 3 part you were going to be a live surgery, वो तो नहीं हो पा रहा है. So what I've done कि live surgery में we could have discussed one case and then possible case scenario in different patients. So I've tried to compile a number of patients, mainly उनकी जो angiographic findings हैं वो, and then we'll discuss one by one. Good thing. Good morning, sir.
Good morning, everyone.
Good morning,
So-
sir.
Good morning. Am I audible?
Very well,
You
sir.
are audible, sir.
Audible and visible.
Oh, that's nice.
Good morning, sir. Good morning, everybody.
Good morning, Dr. Tejinder.
Good morning.
Nice to see you all.
Welcome. Welcome, Dr. Tejinder, to our Venkan.
Good morning. It's my honor.
वैसे सर परसेंटेज कैलकुलेट कर सकते हैं कि अभी जितने लोग दिख रहे हैं हाउ मच ऑफ देम आर गेटिंग गॉट अफेक्टेड विद कोविड इन लास्ट 10 days.
अभी as of now.
Hello.
Dr. Shivshankar Sharma is there, I think.
Hey, Dr. Sir.
Welcome, Dr. Sharma.
Yes, sir. It's so nice to see you all, guys.
Yes.
Same here. We are delighted to see you.
जी sir.
Sharma ji, after a long time I'm seeing you.
Yes, sir. Same here. Same.
I think वो BHU की मीट्स और वेन कॉन के बाद शायद पहली बार बात.
Yes, sir. पहली बार ही हो रहा है.
डॉक्टर शिवशंकर, हम आपकी डिसेंट पर्सनालिटी को मिस करते हैं यार. वी नेवर वांटेड कि यू लीव बनारस.
Sir. So kind of you, sir. So generous.
नहीं, दिस इज रियली ट्रू. कई बार हम लोग वाराणसी नेफ्रोलॉजी सोसाइटी में आपकी और डॉक्टर प्रेम शंकर दोनों लोगों की बात करते हैं. बहुत एक्टिव लड़के थे दोनों, एंड वी मिस दोस पीपल.
Dr. Amin Singh, he has been equally required there in Indore. You should not forget.
सर पहले तो मैं जैसे इनने लड़के बोला मैं उसी के ऊपर खुश हो गया.
हमको अपने को भी तो उसी में काउंट करना है.
हाँ, माने he has to show himself young.
Yes, sir.
Maybe I'm the only person who is falls in the category of senior persons.
सर हम लड़के हैं, आप experienced हो.
Rest, yes, rest of the persons.
सर
सर
आपका
मेडिकल
एनर्जी लेवल तो अभी हम लोगों से कहीं ज्यादा है सर.
डेफिनेटली आई टोटली एग्री सर. आपके कारण ही कई सारी चीजें चालू हुई है.
I just try to keep pace with all the young ones who are in my vicinity, and I'm surrounded by them, and that's the energy which I get from everyone, and that keeps me young, and despite being at the age of 60. Okay.
Yes sir.
True.
I'm
So a little update.
I'm happy that you all are around me every time, and you all come forward and come up like anything.
It's a pleasure for us also, sir.
No words to express.
Sir, in fact, I was looking forward to coming to Banaras for this conference. But शायद अच्छा ही हुआ क्योंकि ठंड यहाँ पर ही जब इतनी ज्यादा पड़ रही तो वहाँ क्या हो रहा होगा?
Not just because of Corona, we planned to it to be a hybrid one, but somehow we thought that a month back we decided to go for only a virtual meet, because we were expecting that the Corona surge will be there. The third wave is bound to come, and
Yes,
that has
sir.
already come up like anything.
In fact,
Fortunately, everybody getting affected. Even I'm thankful to Dr. Himanshu. He is our hero, and he also got affected. But because this time the Corona has not been so serious, and he has come out of that crisis. Maybe almost few other members are also affected, and they are here, and they are going to make this conference a successful one. I hope so.
सर इंडिया ने कोरोना के साथ इतने जोक कर लिए कि अब कोरोना हमारे साथ जोकर जैसे ही व्यवहार कर रहा है, बिल्कुल हल्का फुल्का सा. या मतलब इस बार की तो सर 20 days back there were no cases in Indore and now there are 1800 cases yesterday. So और लेकिन हॉस्पिटल्स पूरे खाली हैं.
No, in the hospital, the admission is not required, oxygen is not needed, and ventilatory support and ICU admission is not at all considered.
नहीं सर कुछ एक तो अब सर हो क्या रहा है, अब अलग कहानी हो गई. अब हर पेशेंट का कर रहे हैं. पेशेंट रोड ट्रैफिक एक्सीडेंट का है, उसका भी कोविड कर रहे हैं, 2 पॉजिटिव आ गया.
वो तो जब
अब वो
स्क्रीन
कहानी
करोगे
अलग
तो you are bound to get good high
Yes,
number.
sir. मतलब कहीं ना कहीं गवर्नमेंट को जाके शायद वो करना पड़ेगा कि दे शुड स्टॉप टेस्टिंग एसिम्प्टोमेटिक कोविड्स.
I welcome Professor Tiwari. He is also seen, although he has muted himself. Professor Tiwari, you are welcome to our this Venkan meet. And,
Yeah, good morning.
he's-
Good morning. Congratulations to arranging such a nice meeting.
Thanks for your words. And Dr.
Yeah.
Sen, Dr.
Yeah,
Rajesh
morning,
Garsa, everybody is seen, and
Good morning,
everybody
sir.
is welcome on this platform. And we have to see to it that it becomes a nice academic feast for everyone, and with grand success.
So, sir, should we start, sir?
Yes,
Yes,
I
sir.
think so. It's already 9:04, and
Himanshu.
sir. So
So, just a few words from Varanasi Nephrologist, from the side of Varanasi Nephrology Society, the organizing committee. From behalf of Varanasi Nephrology Society, I welcome you all for this academic feast, that is VeinCon 2022. This is the 4th chapter of VeinCon, VeinCon 2022. And the people who are there from the beginning with us very well know that we always like to go with live audio, visual and interactive sessions, because interaction is the key for any academic event. However, because of the limitations of COVID and many of our patients, our organizing team members and our operators and their family members repeatedly falling ill by COVID, limited us and forced us for this last moment improvisation, where we have converted our 3 live sessions into recorded videos with interactive sessions. As we know that a lot of people nowadays are involved in vascular access formation, care and salvage process. It includes obviously the vascular surgeons, the plastic surgeons, the urologists, general surgeons, nephrologists and radiologists. So the main purpose of this conference is to bring all of them on one single platform with on a particular level of understanding, so that the patient care is not affected. And in any medical care or in any continuous chronic medical care, it is always important that the operating or the forming team should be in direct contact or in coherence with the usage team. Similarly, in vascular access, the AV fistula formation team has to be there in direct coherence with the nephrology or the dialysis team, so that the proper functioning of fistula can and proper functioning, salvage, and follow-up of fistula can take place. Doing this conference this time was definitely not easy, as the people who are there with us all know the problems that we faced. But in spite of that, we will try to make it a proper knowledge sharing platform, and we'll try to do the justice with the topics as much as possible. And with these words, I will again like to invite all you people for this academic feast. Over to you, Himanshu ji.
Thanks a lot, Dr. Mayan. So, and thank you, Varanasi Nephrology Society, for keeping this on for this year also. We were deprived of having Wayne for almost 2 years, and I think it's a very great start. The most importantly, this is going to be a totally recorded session, and whatever discussions we are going to have, although and this is the plus point of the digital platform, that a lot of things which we have discussed during Wayne 1, 2, and 3 were although recorded, but that needed video participation and editing and post processing. So only some of those videos were there, but luckily this time all this will be going to be available online, and we are going to rectify and make them in smaller videos, so that they can be used for further references also.
So the chairpersons of the first session, the topic of the first session is central venogram, and definitely first of all, I will like the presenter to inform us about the central venogram, that what is a central venogram, when it is needed, how to do it, and what are the indications, and whether it can help us in improving the central catheter and this AVF care. So the chairpersons for this first session are Dr. Shiv Shankar Sharma, who is a known nephrologist, and he is professor of medicine and nephrology at Mahatma Gandhi Memorial Medical College, Indore, and CHL Hospital, Indore. Next chairperson for this session is Dr. Rajesh Garsa. Dr. Rajesh Garsa, have you joined?
Yes, sir.
Yes, he's already there.
So Dr. Rajesh Garsa is Senior Consultant of Nephrology in Fortis Hospital, Jaipur. And he has immense interest in this vascular access thing. Another chairperson is Dr. Shyam Bihari Bansal sir, who is Associate Director of Medanta Medicity Hospital. I am not sure whether sir has joined or not. So with all these things, all the chairpersons know their responsibility, that they have, since it is an interactive session, so you can stop the presenter anywhere in between, or you can pop up with the questions in between also. So over to you, Himanshu.
Thank you, Dr. Mayan. So my screen visible? So small announcement, Dr. Unfortunately, although I'm just recovered, today is day 7 of COVID, Dr. Aman, and I'm sure a lot of you might have had people around you with COVID. My co-presenter, Dr. Achinte Sharma, had to take his father to hospital last night, and he's in hospital right now. He had some issues, but he's presently stable. So he's, although logged in, and as possible, he will be on and off with us. Thanks, Dr. Achintya. I'm sure your father will get well very soon. So, this time we decided, let's go full endovascular. Let's start with very basic. And first thing comes any imaging. Before you, if you want to intervene anything, you have to look for the imaging. And what better than central venogram? First topic as an opening, we'll be going to discuss about indications and methodology. Although I think we'll keep a lot more than this. Okay, next. So central venogram, if we look at the torso, so basically this is visualization of axillary vein, subclavian vein, innominate vein, superior vena cava, iliac veins, and inferior vena cava. So basically your center of your body. So visualizing these in an angiogram, we can collectively call as a central venogram. And what we have to look for, we have to look for any stenosis, we have to look for any occlusion. There is a total cutoff of the contrast. If there is any thrombus, the SVC syndrome is not only CKD, but in malignancies as well. But what specifically is the use of central venography in CKD patients? So I can classify this use into three principal forms. Number one, where we are going to assess the outflow in AVF planning. So as we know, AV fistula has got three parts: the inflow, that's from the artery, then the conduit, so the part of vein which is going to be used, or a graft or a basilic vein, so that is a conduit, and then it's an outflow, so where the flow from the fistula is going to be. So the purpose of central venography in CKD patient is, one of the purpose could be to assess the outflow in AVF planning. Sorry, there's a spelling mistake of planning, but it's a planning. Now, second is a patient who come with a symptomatic central venous hypertension. So patient who had say like running fistula, and now they're coming with the arm swelling, or somebody who was on permacath for very long. Now patient is coming with the facial swelling. So second is the symptomatic central venous hypertension, and third is where patient is coming who has had a dialysis line, and we want to diagnose the flow issues in dialysis line. What is happening? So all these are the some or other way at the central venography we will have to look. Now the big question is, before we jump into central venography, and this is a question to audience, that what do you think what will happen if patient had central venous occlusion, say radiocephalic fistula, cephalic vein, radial artery was all good. So what will happen to fistula in a hand if you create a stenosis? Okay, will it? How many of you think that this has got very high risk for the occlusion? Sir, anyone? Dr. Mahendra? I think a lot of mics are muted. So, hello.
Hello, can you repeat the question, please?
So, my question is that this is in general perception of that if there is a central venous occlusion, and if you create a fistula in hand, same hand, what will happen? So,
most likely there will be hand swelling, but I don't expect a proper functioning fistula to fail because of central venous stenosis.
Exactly, that is the point. See, veins have excellent collateralization power. So once you connect a fistula circuit, inflow, the conduit, and outflow, even if it's totally blocked, so even if there's a total occlusion of subclavian vein or innominate vein or superior vena cava, fistula does not blocks because of a central venous occlusion. This is a very important point we need to keep in mind, because a lot of time I see patients who had multiple central lines, who underwent some fistula creation somewhere, and fistula didn't work. Okay. Now, if fistula didn't work, there is no thrill, fistula is blocked. And then if you're labeling it, that reason is the patient had multiple necklines, that is not right. That is simply you have not chosen your inflow or conduit properly. Okay. So even if central veins are blocked, they will not cause the immediate surgical failure. What they will do is actually arm swelling. So let's take next. So let's take some hypothetical case scenarios. Here I want to discuss the central venography indications when you're planning for a fistula. Okay. Now, first is a patient, 26 years male, with a pre-dialysis, and there's a no neckline history and looks suitable for left radiocephalic fistula. This is a person I have no reason to doubt for any central venous blockage, although very rarely there might be, but I will not be doing venogram right away. Although now here comes a female, 45-year female who has been on hemodialysis for 5 years, and she had left last 2 years after a failure of initial fistula. Last 2 years she had a left IJB permacath, and now she has been planned for left brachiocephalic fistula. We'll come to this later also, but the right permacath versus left IJ permacath, simply because of the tortuous anatomy of the left innominate vein. Once you leave permacath for 2 years, it's certainly going to cause central venous stenosis, and it's a mandatory that you look for the central veins before you plan for a left brachiocephalic vein. Or you might be in a scenario where you don't have access to, and if left brachiocephalic is the only option, okay, then at least you should include this in your consent that, listen, man, you had your neckline for too long, and probably even if I make fistula, after once the hand swelling is happening, we will need to remove this and do angioplasty for this. Now, third comes the patient who has been on hemodialysis for 9 months, multiple history of bilateral side of necklines, and now you're planning for left arm AV graft. Okay. Now, difference between radiocephalic brachiocephalic fistula versus AV graft is a very high flow conduit. Okay, compared to it's not only the amount of swelling that happens, the rapidity that it happens. It's massive. So if say you create a left radiocephalic in a similar occlusion of central veins, it may take 4-5 days, and swelling will come gradually. And it may be easier to respond with a compression also. But AV graft, once you create, very next day morning, swelling becomes very tense. Especially, it all depends how severe the blockage is. There was a patient, and I think we all learn from our experiences and mistakes, we can call as, where the central venous blockage was so much that I was not able to open, and in that case we had to actually remove the AV graft. So as a dictum, if I'm planning a AV graft, and if there's a suspicion of a remote suspicion of central venous stenosis, always check with the central venogram. Now, fourth is a 38 years female who had a neckline on 1.5 years, who has been on HD for 1.5 years, and right IG permacath for 1.5 years, and I'm planning for left brachiocephalic fistula. Now, this is the patient. Although I will, if feasible, then yes, but if not feasible, I'll not be pushing too much for central venogram. Because we know as a fact that right IJ permacath is a straighter, and it tends to cause lesser of the central blockage. Although history of the repeated infections, history of the flow issues in permacath is very important. But outsetly, I will not be going and asking for a venogram for this patient. But consent will include risk of the arm swelling, and if needed, angioplasty. Similarly, there's a 38 years female on HD for 1.5 years, and who had a right IG permacath for 1.5 years, and I'm planning for right side basilic vein transposition only. So it's same side intervention I'm talking about. Okay, and this is not a smaller intervention; it's a big intervention, because the massive edema can cause severe wound issues as well. So I'll be planning central venography, and if needed, angioplasty also in sanctity. So coming to diagnostic central venography, please remember, this is not the only central venography we are talking about. This is one of those techniques where we are saying we want to look at the central venogram before we are going to plan a AV fistula. Okay, so this is the simple most, and I think right now Dr. Mukhya is not there. I can proudly say that during first vein or second vein conference, this technique was not a routine practice for me. This is something I learned from vein. So a simple 18 to 20 gauge peripheral IV cannula in any superficial vein, okay, in both upper limbs. So you take the patient cath lab, put even before putting in, so you can ask your assistant to have a cannulas in both upper limbs. Bigger the better, although even as small as 20 will do, but bigger the better. So for functional AV fistula, this is just add on to this. When you're suspecting a inflow issues, in that case, excess in place of venous, you would like to have an arterial access. And when you're clinically sure that there is no inflow issue, then you can do a functional vein puncture. We'll talk about this section later on. And also permacath, we'll talk about this later on. Right now, just focus on the preoperative cases. But here is very important to understand that we never take step 2 before we take step 1. And here we are talking about planning for AV access, evaluation of AV access, and duplex evaluation is a mandatory step 1 before we go for venography. It's that important that I personally, and a lot of interventionists who are there, I'm sure they will believe and agree that for the extremity, I do not want to look at venography unless it's some intervention. So for the part of hand, forearm, the arm, that is so easily accessible, and so many more things you can see with the duplex evaluation, that I don't want to see venography just for that. So a mandatory duplex evaluation, and you can also rule out the inflow or the inflow or anosmotic problems with this itself. Now come to the technique. We had cannulas in both our hands. Now we are going to inject dye. Now before dye, it's a good practice if you can have a flush of warm normal saline, because that will also vasodilate it. And the easiness of the contrast, because contrast is a bit viscous thing, so easiness of pushing will be there. So when you actually push the contrast, veins are already flush with the warm saline. You don't want to be standing very next to the the II, the exposure source. So it's advisable you have a 100 centimeter extension line with a 20 ml Radiologist syringe. You should have 2. Okay, and we'll discuss with some venogram findings why so. And contrast material you should dilute 50%, 1:1. First you flush with warm saline 10 ml and then push with controlled force. It's not very abrupt force. These are smaller veins. You can potentially rupture them. But yes, you do need to push with a significant force. I'll better call it controlled force. That is one of the things you will learn as you do it. And it's very important to remember that this is a slow venous flow. Why I ask for 20 ml Radiologist syringes 1+1? Because when you're looking at the image, sometimes you get images very delayed. You want to keep one more dye ready from back and keep on injecting till you get a good picture. Now, a little of chemistry, look on the right side of the picture here. So these are the 2 main contrasts we have with us. The ionics one are not used anymore, rarely available. There are 2 kind of non-ionic contrasts, the omnipaque and the visipaque. Now visipaque is isoosmolar, and omnipaque osmolality is very high. So we want to prefer a visipaque, especially for two things. Here we are talking about anyways patients who had a renal failure, but and I won't be able to ethically justify central venogram for a patient who is pre-dialysis, but who is already on dialysis. So that one of the difference between visipaque and omnipaque is the incidence of contrast-induced nephropathy is much lesser than visipaque. And it's more with omnipaque. But visipaque, you can dilute well. If you look at the diagram here, there are more of the iodines in the visipaque, less of the iodine in the molecule in omnipaque. Simple. The blackness of the angiogram, the dye gets it from its iodine contents. So you can use visipaque more diluted, even up to 1:3. Whereas omnipaque becomes slightly faded if you dilute it more than 1:1. So now let's see some of the acquisitions. So this is and I would like to put actually a disclaimer. We would have slightly better images, but initially almost few days back we thought we'll be coming up doing it live. But there are a lot of images which actually were there on my phone, so I cannot go to hospital and collect it also. So a lot of these images are phone, so you'll have to bear with it. Now look at this venogram. You can see the veins are filling, but these are multiple collaterals. You cannot see one straight vein. And now this is right upper limb. You can see the veins filling. This is the arm area. I'm not, so as I told, I study the extremity with the Doppler, so I'm not much worried about. But what I do want to look at is the central veins. So here, if you see the axillary vein comes, you can see some more bubbles which should not have been there, and there's an occlusion of the central veins on this area also. Okay, so you cannot see here again. So this white one was a digital subtraction angiogram, whereas this is the cine, the cine which we use for coronaries. There is an advantage of this also. Sometimes because cine, you don't need patient to be holding the breath, whereas in digital subtraction angiogram, when you're doing for chest part especially, you want patient to be holding breath. So in those patients who cannot hold breath very well, sometimes cine with a slightly higher amount of contrast helps slightly better. Whereas, okay, this is another picture of right upper limb venogram. You see the veins are very well. You can actually see these are the valves. You can see the valves. I see this flowing well, and this is, you can see in the DSA. Now, if you see the picture, it may not look very well tube-like, and there could be possibly small narrowing, but it's not about exactly measuring what's a percentage of narrowing. As long as the flow is going, there's no stasis, so it's not holding up, and there's not a lot of collaterals. You can be sure that your fistula is going to work to be fine. Okay. Okay. Now, this is a picture where you have a very cooperative patient, you have a good machine. This is the kind of a picture you want with a venogram. There's a lady who had actually, she had a history of hypersensitivity to contrast also. So there's a protocol where you give a certain amount of, steroids pre-op, and then you do an angiogram, and then you can plan a procedure based on that. Now we are done with the first type of central venography, where we wanted to look at before surgery. Now let's talk about the patients who come with venous hypertension. Okay. Now this is on the right hand side. This is a typical patient who is in your clinic. you've got arm swelling, and patient has been getting dialysis from, you can see, getting dialysis from the fistula. So finding an alternate access before your procedure is not an issue. They can use the same for a pre-op dialysis. Now it's very important to understand that normally, if I'm the interventionist, I should go with the intention to treat. There's no point, because this is a because this is a clinical diagnosis. You don't expect anything else to be there. All you want to be sure that how much and where exactly the blockage is. So, with central venogram, especially talking about Indian population, where you want to keep cost to as low as possible, you must go with the intention to treat, and that's where the difference comes in. If it's just a diagnostic angiogram, probably you can do any time. But if you're going for intention to treat, a mandatory dialysis before the procedure should be there. Dialysis is not to wash off your contrast. No, it's there because sometimes you may need patient to be lying down 40 minutes, 45 minutes, hour, even hour and a half. Okay, and you don't want your patient to be, breathless
So,
when you're
Dr.
doing.
Himanshu,
Yes.
I'm sorry to interrupt you for a while.
Yeah, sure.
So, so the first class of patient,
Mhm.
you told there is no fistula, but
Yeah.
multiple history of multiple or single central line puncture. In
Yes.
these cases, when you want to evaluate the central vein,
Mhm.
you will cannulate peripherally,
Mhm.
as we have discussed and shown in one of our previous chapters also. You will
Yeah.
cannulate peripherally. You will follow the procedure. And then along with the peripheral veins, you will see the central vein also.
Yes.
Now this is the second scenario where the patient is coming with a AV fistula, with venous hypertension, with arm swelling, and probably she is coming very late. These things has to be recognized very early.
Agree.
Right from the beginning, when the arm swelling starts appearing, a nephrologist or dialysis person should start suspecting obstruction somewhere, either in central veins or above the fistula outlet. Okay.
Yeah. So in fact, actually good. It's and I will take care of this also. Just not make this boring. My question is, because this patient comes from the nephrologist. So as a nephrologist, I would like to ask people in, everybody in on panel also, when you think, or what's the stage you think you start suspecting a central venous stenosis when you have a patient who is getting dialysis done? Apart from this, the very obvious, arm swelling, what are the other things?
Anyone from panelists?
Dr. Rajesh?
Dr. Shiv Shankar?
Dr. Rajesh's voice, I think, is muted, or you're saying something.
Okay. Dr. Himanshu, whenever we think there's a problems in the flow, first of all, then we should suspect something is there. We should look for that maybe there is obstruction or something else is there.
Yeah. So, I mean, my point was sometime with the early, sorry, excuse me, with the early, blockages or blockages very distal, okay, swelling is not very prominent feature, okay, or, a patient who is well aware. So what happens with this is a recirculation. So the more you have prominent vein, the vein, basically venous return is not going forward, it's coming back into the same arm. So sometimes just stripping off the patient and looking at the both arms distance from a distance, क्योंकि कभी-कभी हमारे इंडियन पेशेंट इतने दुबले होते हैं कि हमारा ध्यान उस हाथ पे जाता ही नहीं है जो हाथ नॉर्मल है, और नॉर्मल हाथ उनका सूजा होने के बाद it becomes almost 1.5 times. If you don't look at the normal side, it may still look to you as a normal hand. So it's very important to at least fold the shirt till upper arm and look at the both hands from a distance. It's a very important. Second is this swelling. that becomes obvious, especially just before the dialysis with the system. And third, obviously, any signs which is suggesting that dialysis is not happening well and you want to examine your patient, then in a routine examination, you can actually catch it up. So, Dr. Mahend, should we further take it?
Whether Himanshu, have you seen collaterals over or collaterals on chest over a normal functioning fistula? Most of the time when we see the prominent collaterals over neck and chest, that also points to underlying central venous stenosis.
Yes, that's one of very important. In fact, a lot of time patients do tell about you, कि sir ये ना इधर से नस सूज गई है, and it's sometime it will be in the prominent area in the neck, but sometimes it's not in the prominent area. They are along the this thing, the chest, lateral chest wall. Dr. Bayan, my one question was, do you expect, say if you take a chest X-ray, and do you expect some of the pleural effusion also to be there?
We see some minimal amount of pleural effusion, but I cannot say with certainty that whether it can be contributed to AVF or not. I invite any other person who can better guide us on this.
Hello,
I mean,
good morning. Good morning,
Dr.
Dr.
Mahendra?
Mukhia here.
Yes, sir. Good morning, sir.
Good morning. I was, involved in the meetings since beginning. Dr. Himanshu, very well going.
Hi sir, अरे सबसे पहले आप ही को contribution वो vote of thanks किया था मैंने.
Thank you so much. Just a few points which have been covered, and I just want to add something. See, first thing was the 2 syringe use. You said that the second syringe, because the flow in the veins is slow, so you use the second syringe with contrast. See, what I do, I use just plain saline to reduce the amount of contrast, just to push the first syringe volume forward. You just push it with saline instead of filled with contrast. And the second thing which I was, interested is when the patient has significant residual kidney function, then we do not use contrast, even Visipec. We use CO2. CO2 is...
I will disagree with you, sir. Sorry, but strongly disagree. CO2 angiography, we have been doing recently. It's one of the contraindication to use in venous system because of the, very significant risk of pulmonary embolism. So CO2 angiography, but I totally take the point of first point, where second syringe you want to put in for the to flushing of contrast from the hand.
Yeah, there is a real fear amongst the person who is using the CO2 as a tool of angiography, but it's been quite safe, and we have not seen someone. If you take the history of the patient, if he has a significant pulmonary COPD or some kind of respiratory problem, then you can avoid. But otherwise, in a healthy individual with CKD, CO2 usually does not causes any problem. So that was the second point. And the third point is about this hand swelling with which the patient has come. See, the nephrologists have the role of prevention rather than, because once the stenosis is inside, then you place a fistula, you didn't realize that stenosis is inside, then obviously if it is a late or it is early, swelling recognition is just a part of diagnosis of central venous stenosis. But prevention of central venous stenosis or placing the fistula before is important. So history taking again and recognizing the high risk patient, getting the angiogram done, and then plan the fistula accordingly. So this would be the answer, because once the swelling is there, once you have placed the fistula, if it is high flow fistula, it's going to cause problem.
Agree. So prevention has always been better. So let's see how we go it further. So mandatory dialysis before the procedure, as I told, one of the reason is not from the contrast exposure. It's because you want patient to be comfortable and lying down maybe for a longer time. Then comes the sheath. So here, a 7 to 8 French sheath should be there. Why not 5 or 6 French? Because a lot of time central venous angioplasty, your balloons which you are using, they need at least 7 French sheath if they are NY. NY and AUX we use as a code language, although we are streaming online, it should be okay. The ETO, the sterilized balloons, when you crimp them really down, so sometime even if its balloon is 7 French sheath compatible, you may need a 8 French sheath. And when you're going with intention to treat in a running fistula, you always image peripheral as well as central veins. Sometimes veins are tortuous and it's easy to miss some stenosis in presence of central venous stenosis as well, only on Doppler. So image the arm, so starting from the puncture point, and then first run you look at the arm, then you go for the chest and inside. Now, position of this is for somebody who wants to go and start trying this and who have been doing some work. Position of hand, table and moment of cath lab has to be kept in mind. Okay. Now, the defaultly they are designed to work for coronary. Okay, so they are designed to look into the chest only. But so you want to sit up with your technician, make sure patient lies down and move the table to make sure that when you're doing angiogram, the table movement is of a kind that angiogram will show you entire part. Okay. Okay, and how can I? Is everybody seeing this blue circle or only I'm the seeing?
Yes, it is seen.
Okay, I think I need to find the eraser tool in here. I'll end show and then I'll start again. Rishabh, can you hear me?
Yes, we can hear you.
This the blue line is not in my screen.
So this is you have selected from Zoom, so you have
Okay.
to remove from Zoom itself.
Okay, and how do I do that? Okay. A little glitch because this is a bit irritating, I was thinking.
Meanwhile, you can proceed with the blue line, Himanshu. We don't have any problem with the blue line.
So, okay, let's.
Now it has gone.
Okay. So, can dialysis prevent from contrast-induced nephropathy? No, and this is very important point. As a nephrologist, as an interventionist, we see daily in and out a patient with the, say creatinine 1.8 or 2 or even say 5, 6. They come to the hospital and they need a CT angiogram, or suppose we have to plan for angiogram for certain things which are life-threatening, and then the emergency department they ask for, or sometime some medicine guy they ask for that you will need a dialysis immediately post procedure. No, it does not prevent from contrast-induced nephropathy. There are a lot of other measures. I thought just to make a small mention here, and we can have some discussion over that maybe later. So on left, this is one first patient. This is the angiogram of periphery. You can see a lot of collaterals. And then you can see centrally left side subclavian is occluded right behind the, the first rib and the clavicle junction. Now, this is a long, we'll come to the armamentarium in a later talk. But here we see the angiogram. First part we have done. the sheath only. But then when you are actually going for intervention, you want to take your catheter or sheath right up there, like like at this frame, and then do angiogram. That gives you a really good picture. And sometimes there is small channels you should be able to find, very trickle, which you can look into. If magnified view, you should be able to get a better picture. And then here we are coming from femoral line. You can see, the right side line inside, and we are trying to negotiate our catheter from the innominate distally back into the upside. So these are, the kind of angiography images you want to do when you're going to treat with intent to treat. Okay, now this is, so you're done with the angiography part for the central venogram, for the arm swelling patient. Next, we are going to look for venography when we are doing simple puncture. Yeah, there is a very important aspect which I'll say, and this was actually one of the full talk initially we thought. When you're trying to put a wire into IJ, and if wire is not going, then what to do? Okay, and this is a very typical example. See, if you look at the venography and you do just in the needle here, so it's nothing, just slightly tortuous internal jugular vein and poor angle of pushing. Okay, and here what we did, we just changed our angle of a needle and maneuvered our wire a bit. Okay, and wire went off. This is venography neck puncture again. Here you see in angiogram, you can see this is a narrow, probably patient had a previous neckline also, but beyond that the vein is open. And here what we did, okay, so this is actually going through the dilator of a sheath. So we have a better access. Normally when you are trying to put through needle and maneuver, then sometimes you have a risk of either needle coming off or causing counter. Also look at the tip of the wire. Okay, this is not the routine wire which you get into along with the sheath. Okay, this is a thermohydrophilic glide wire, which is designed to glide through these. So if you look, if you change the angle a bit, it goes inside. But this is happening because you had the angiographic, idea. Okay. Now next, again, kind of and type of venography. Venography in lines. Remember the third indication we talk about when you have a patient with the central lines and they are not functioning. So these are one of those. You see the permacath with the total thrombosed of superior vena cava. It's some tricky flow going into RA, and here flow refluxing into innominate vein. On right hand side, you can see the permacath in situ, but around the tip, you can see the superior vena cava is stenosed with some thrombus inside. Some of the blood is also refluxing back into subclavian innominate vein. Here again, during permacath, you see this is a permacath which was put in from the left side and it's probably pulled back a bit, or it was left in here. Now you want to advance it. Okay, so now here once you are advancing it, so this all is also use of venography under guidance of picture. You can do it always better. Dr. Mahendra, so I want to know what is happening here on the left side picture. Any comments?
Hello.
Any comments? Any comments? What is happening in this extreme left picture?
Extreme left picture. It's
The video
probably a femoral permacath that is inserted inside. I'm not sure whether it's permacath or only the sleeve, upper sleeve sheath thing is left.
Yeah, so it's actually
Sleeve.
So actually it's a femoral permacath which was in for almost 1.5 years. Patient came and patient was complaining of low flow, and this is an angiogram after pulling permacath down a bit. So you can see there is only flow into the sheath which is surrounding the permacath, and sometime cost issues, multiple things, or the simpler solution is I pulled it back till the iliacs, where I could find some fenestration into the sleeve. You can see still IVC is wide, patent, open, and then you can just advance it over into a IVC. You pull it back, and the same permacath, push it further, and here you see in the last you get the flow into your permacath. So again, venography. So this was the IVC venography which we looked for. I think we have already discussed these. You can see there's a permacath, there's a big thrombus surrounding the tip. Now, suppose this is a patient, okay, the left one, what will you do? Because this is an interesting video. I thought, I will utilize this platform to put this through. So, anyone, management of permacath with a big clot on the tip. Dr. Mukhya, if he's around.
See, Himanshu.
Mm-hmm.
Hello. Initially, when the permacath was blocked, we were doing permacath angiography also by putting some contrast. But what you can see from inside was that only the tip of permacath is blocked. But what is there on the outside is not visible from the inside. So either you do a angiogram from a different site or a different puncture, or you go for a CT. Then only you can tell whether how big clot is there.
So at least you get some idea. See what is happening in this left side picture, and I agree. What happens? A lot of the referrals they come because the CKD patient was he got the CT done with the contrast for some other reason, and one of the findings they put it ki there's a clot around the permacath. Although permacath is functioning well, what to be done? That is my question. Although in this case you see you can when the tip
Hello.
So what to be done for this case?
So, Himanshu ji,
Sir.
In this kind of scenario, although I have not practically, encountered this kind of thing, but what I can say is that if the flow is okay and we need to provide the vascular access to the CKD patient, then and if it is the only access, then I will not remove it. I will just provide the anticoagulation and take a consult from if it is not symptomatic, then take a consult from CTVS surgeon or
Believe me, sir, CTVS surgeon is not going to do anything. Okay, I would like to share my thought process on this, because it's a very common scenario. Really like your background, sir. Which app you're using, Dr. Mukhya?
It's the Zoom, I think.
So background is done very well. Anyways, sorry, got distracted. So, sir, the thing is that if the permacath is in there and there's no issue in flows, and it's elderly man, and I don't want to be touching him at all. I just want to add some anticoagulation to him. Simple.
Yeah.
Why so? Because if you go in one of the previous pictures, and I would actually like to show that again. Yes, here. I don't want that thrombus, which you are seeing in previous, to progress to this thrombus. Okay, that was just some small thrombus around the tip of permacath. I don't want that thrombus to be progressing to the thrombus which we just saw. Okay, so that's one. But say if it's a younger patient or patient where I would want some access in future, Okay, and this has happened with me. I've seen certain patients in COVID. COVID शुरू हुआ तो permacath डाल दिया, अब 1.5 साल के बाद now they are thinking कि what to do. Now this is the patient I would want to take this permacath out immediately before it starts clotting the entire SVC. Give him a strong consult about what's the need of a central vein, need of a AV fistula. Give him an alternate, maybe a femoral permacath for 3 months. Utilize this time to create an upper limb AV access, with the understanding that if symptoms of central vein stenosis they develop, patient may need central venous intervention. What I will do, what I will achieve, this acute clot, which is still softer slightly, I don't want to touch around this too much. And in this 2 to 3 months time, this will also get stabilized, and probably I will not need to do anything. Even if I need to do anything, that will be amenable for the angioplasty. Okay. Now, one very interesting thing I'm going to show. This was actually, I was pushed from so many people in one of the hospital, and the patient was kind of VIP, and they were concerned that thrombus around the tip, when you actually pull out the permacath, can it dislodge and can it go to pulmonary? Can it cause PE? Okay. Although with our experience, we have seen these are adherent thrombus. Here, I did not had option of IVUS. Otherwise, I would have shown. But then we improvise. So there is a stent called wall stent. Wall stent can be partially released and recaptured. So if you see in the picture on right hand side, you can release it inside, and then you can recapture it. So if you look at the picture video on the left hand side, although it may not be very clear, but what I have done, I went from below femoral vein, came to SVC, and opened my wall stent just below the tip of permacath. And then, so this was kind of a filter, which in case that the thrombus dislodges, we will pull it up. Okay. And then we pulled back the permacath. Okay, based on that. In fact, the wall stent alternate use as one of the maximum of any stent we can know. So, anyways, this is, I think, now we are coming to the end of this presentation. This is also very interesting venographic finding where we are going to put a desperate permacath into a situation where patient had alternate, stent placed in from the other side. So this is just to show sometime you can actually go, you can penetrate the stent. You can, here we are trying to penetrate that stent, and then you can take your wire through, you can pre-dilate the struts, and then you can put your permacath across this. Okay, see, there's a balloon which I'm using to dilate this area. Okay, this is the sheath across. So point was, venography is not only we conventionally see, we have to plan of our fistula, then let's see whether to go for a venogram or not. If we just go by textbooks, maybe in India, we will land up doing so many unnecessary, central venogram, and so many unnecessary intervention even planned. Okay. Veins have immense potential. If you have made a fistula and patient is, collaterals are not there on chest, there's no arm swelling, no matter even if there's a central vein stenosis, I do not want to look for it. Okay. There are so many patients who have overt vein stenosis. I want to prevent those. I want to specifically look for those patients. A technique is very important, which is you can utilize during neckline, during permacath insertions, during non-functioning lines, obviously with the central venous angioplasty and the pre-op planning as well. Last 2 slides, I think. So, central venogram, yes or no? I think we have discussed. It's a very yes for certain situations. Cost, it all depends on your setup. I see people doing coronary angiogram in certain centers 7,000 rupees se lekar ke, then standard and 20-25,000 as well. So it all comes down, but cost can be realistically low because you can achieve a good venogram just with 2 IV cannulas. Okay, availability wherever you have a cath lab. It cannot be done on C-arm unless C-arm is excellent quality. Safety, yes, it's safe with due precautions you have told. Learning curve is once you see, it's not a big learning curve. Inter-observer variability, it could be inter-operator variability for initial few cases, but inter-observer variability, no, you are getting a pictures. What about CT and MR venogram? So a lot of time we get patients who come with these films, difficult interpretation. Okay, here you don't have only black and white veins to see, you have a lot of other layers also. Second, no tactile feel. Sometimes you want to pass your wire across, you want to see it's acute thrombus or it's something you can pass easily wire, or it's something which looks rock hard. If you look at overall contrast exposure is much higher in doing a venography, MR venography or CT venography versus a normal, and then it just adds on an additional cost. As I said in one of the initial slides, when we do venography, central venogram in a symptomatic patient, we go with intention to treat. So I think with this I would end this talk.
Dr. Himanshu, well, very well you can remember, probably you missed the route through which I am doing most of my central venograms. The nephrologist, the nephrologist, as a nephrologist, what I face, I mostly, apart from the fistula thing, most of the time when the fistula fails or a patient arrives with no access in an emergency, so when we are seeing the neck veins, they are multiple punctured many times. Okay, the vein diameter is almost okay. We insert a guide wire. The guide wire goes in the chest and get trapped. When we see it in the cath lab, the guide wire is coiling at that in the superior vena cava or in the brachiocephalic, or it is coming back like a U-turn. So what we are doing at that time, the insertion needle or the gelco needle that we use for inserting the guide wire in the jugular vein, we are inserting the contrast or dye from that very needle and getting a central venogram picture. And I think I have sent you more than 50 or 100 such cases, and you have very well dilated them also. So this is a sort of emergency venogram that sometimes we have to perform it on the table.
Yeah, in
not
fact,
pre-planned, in fact.
And that much of with some jugaad that you can very well do even on you have assistant with the video camera on, you can do even on C-arm as well. Okay,
But C-arm with the visibility is not that good.
I mean jugaad and emergency, and yes, if you are going to a older generation cath lab or even C-arm, you have to use the contrast totally undiluted. Your visibility becomes slightly better. That's one of the tip for these scenarios.
So apart from the hand veins or from fistula, the neck veins can be utilized for central venogram in certain situations. And one of the case I remember, when all the neck veins were blocked, we used the femoral vein to enter the right atrium, followed by going to superior vena cava, and through that route we did the central venogram thing, and to find out that the SVC was blocked.
To secret of us.
You did it. Probably you are forgetting it. You did it. As all the neck veins were blocked.
So that's a very standard way. I have shown in one of the when I was showing the venography techniques for treatment, is one of the things which I showed when we go from femoral through IVC and try to cannulate innominate vein from below also. Okay.
So over to our chairpersons, Dr. Rajesh, Dr. Shiv Shankar. They want to add anything or they want to ask anything?
Thank you, Dr. Himanshu, for this wonderful presentation. As you are learning every year something new from you, and you had very well defined all the things regarding the venogram. Any questions anybody can ask?
So Dr. Shiv Shankar is back. Good.
Sir, I was already there, लेकिन मेरा mic unmute नहीं हो रहा.
Sure.
So I wanted to ask so many things because I felt like a student again, rather than being a chairperson here. So Dr. Himanshu, such a nice talk. It's so good to hear you after such a long time. From the time you started about indications, I wanted to ask you, you didn't give some specific indications. So I think it's more about clinical judgment rather than having some very specific indications when we are considering central venography, right?
There were actually certain, so
No,
if you, there are three scenarios. Okay. One is a no-brainer. You have a patient with a swollen arm with a fistula in hand. It's a no-brainer. You have to do a central venography. Okay, so it's one of the absolute indication. You have a permacath or you have a line which is not functioning, and you want to either remove it or to correct it. You have to do a central venography. Okay. You are going to create a fistula in a hand where you are suspecting 100%, very, very high suspicion of central venogram. You have to do a venography for two reasons. Either if you are creating either AV graft or basilic vein transposition, these are the situation you want to tackle the central venography very soon. AV graft, if you create and you cannot leave, an occlusion for say very long. So take the scenario, you're done an angiography, you're doing a AV graft. Now, for all my AV grafts, unless it's very clear, you have ultrasound findings, no history of neck puncture, you can see very supple veins, you can ask patient to breathe and you can see the physicity of the Doppler flow with the respiratory variation. And these all are the signs that there is no central blockage. Anywhere you suspect there could be blockage, in AV graft or basilic vein transposition, you want to quantify that, that blockage. If there's an occlusion, you would want to correct it either in same time. So either do your AV graft in a hybrid suit, जहां पे आपने vein खोली, आपने wire डाल करके देखा, आपने plastic कर दी, and then you connected your AV graft. Okay, you don't want to be landed up कि अच्छा occlusion है, अब हम graft कर देंगे and then we'll come back later and then we'll do angioplasty. What if the wire didn't go through? या फिर हम basilic vein transposition कर देते हैं, हम बाद में आएंगे, फिर हम central venoplasty कर देंगे. What if that doesn't open and this causes so much of edema that everything is in soup? Okay, basilic vein transposition में, although you have an option, doing a stage 1. Okay. Just आपने connect कर दिया and come back. So there are some very specific, indications, and then there are certain where you take your clinical judgment into.
So basically, to sum it up in one line, wherever you are suspecting an occlusion, you should go ahead.
Yes.
That's it. Yes.
So, just one addition, as Dr. Himanshu already mentioned, that most of our patient, only few of our patient will be, pristine patient without any neckline history coming for AV fistula. So most of our patient are at risk. You cannot exclude just by clinical signs or symptoms that CV, central venous stenosis is absent. So what my policy is, in any patient where there is a suspicion, a doubt, not very strong, but doubt, and to protect ourselves also, once the patient is coming to you, you know that he has some risk factor, it could be there, you subject him, ask him that this is a possibility and take the consent from the patient for, central venogram or just angiogram, and this angiogram, I do it for two purposes, not just to exclude the central stenosis, but to prepare the patient to get the best possible access, because as Dr. Himanshu will disagree that he uses ultrasound, but ultrasound has its own limitation unless the radiologist is tuned to, do the good ultrasound to assess the peripheral veins to maximally dilate them. Anatomic, description of peripheral vein is best on DSA. And that, 3 primary fistula, your aim is to get the best site for the patient in 2 arms. So these are the two, important goals when I do the angiogram on the patient before AV fistula placement. First, to get the best site out of these three primary fistula sites, and if the patient has risk factor, then central venous evaluation.
Agree, sir. But I think is the love of ultrasound. I totally agree. If even you're thinking to involve a radiologist to evaluate for the fistula veins, then you better just rely on venogram. Or the purpose is doing, and we have been saying this time and again, purpose is doing your Doppler yourself. That means the person who is going to intervene, because you have been you have seen those veins physically, practically, by holding in hands also. And with time, and every time you see the patient pre-op, you operate, see pre-op, and you operate, you really get a feel, what is this ultrasound telling you. Okay. And in fact, there are a lot of other factors, which distensibility and so many other things. You can actually identify small valves, branches, so many things. It's all about having and doing, ultrasound for your patients yourself, and even before that, clinical examination.
Sure.
I have got one question.
Just one small addition, that because our aim is to place the fistula at primary three sites, radiocephalic or brachiocephalic or brachiobasilic transposition. So cannulation should be done as radially as possible. Most of the time I search for a vein on the thumb. That is the ideal vein for injecting the contrast before placing the fistula. So
Agree.
as lateral as possible and as distally as possible. Yeah.
Sir.
Dr. Himanshu, in one of my patient, she had brachiocephalic fistula and she was on dialysis for 3 years.
Mm-hmm.
Okay. And after maybe 6 months after dialysis, she developed swelling in that limb, in the arm, and she used to complain of pain. You asked that besides swelling, how frequent is the pain during dialysis? After starting dialysis, after an hour, she used to get pain. And ultimately, when the venography was done, we found that there is central venous stenosis there.
Sir,
experience of the chairpersons and the other nephrologists, as far as this part is concerned, do they really get pain related to central venous stenosis? And when we used to decrease the blood flow rate, the pain used to get less, or maybe it is gone.
So now this correlates with few of my patients also.
Yes.
So actually, I did try to specifically find in literature for this. I didn't get much. But yes, it is one of the presentation. Although it should be taken with mix of a patient who anyways get a bony pain during dialysis, which is typically also sometime in the shoulder region.
Yes, it was in the shoulder region in this patient.
But you see, if what I could make out, when you're giving a blood flow back, and if the outflow is occluded, lot of collaterals you can see in the shoulder and chest area. Okay. Don't know how much that is causative, but if relief of the stenosis is causing reversal of flow, reversal of pain, then that could be possibly cause. It has, in my experience, it has happened. I don't exactly remember how many, but less than 10. Some of the patient doing angioplasty had helped, but some of the patients still, the problem is during dialysis, that in general left arm pain, the painful arm, which is having a fistula, still continues. Doctor.
In the same patient, what happened after 3 to 6 months, like this pain during dialysis, what exactly happened? We suspected with, and we found that the central venous stenosis is there, but the patient party did not agree for any intervention. But after, I think, I do not remember exactly, but after 3 or 4 months, the pain was gone, even with the high blood flow rates. Is there a possibility that there could be development of collaterals and that has led to relief in pain?
Sir, too difficult to answer.
But just
It could
maybe
be.
imaginary thought from my side.
It could be. Unfortunately, we don't have anything to prove that collaterals have developed. Okay.
Dr. Himanshu,
Ah.
uh, so you are the only player today for the live cases. So should we move to the next case, or you want a break of 5 minutes for?
Next, we can continue.
Can I ask one question from my side, if you allow? Yeah, Dr. Sinha this side.
Yes,
Hi,
yes,
sir.
Welcome, sir.
You
Yeah,
are
yeah,
welcome,
thank you.
and you can go ahead. Dr. Sinha.
Himanshu,
Sir,
Diख
what
नहीं रहे,
reacts-
sir.
Yeah, what?
Your video is not on, Dr. Sinha. Please put
Yeah, I've kept it off, boss.
Yes,
Purposely.
put it on so that everyone else can see you.
Yeah, so my question is regarding one of my patient is initial 1 hour, no symptoms. But once the 1 hour passes, she is having pain in her whole arm, of that fistula arm. And that is persisting till the end of the dialysis. So even we are giving the blood flow is around 220 or 230 or so. What to do in that situation?
But there is no swelling of the fistula.
Nothing. No.
Sir, my suggestion,
Initial 1 hour, everything is asymptomatic, and everything.
My suggestion will be, I mean, this is just a suggestion, and probably we can discuss this later. See, swelling will take time to happen. So it will, even if there's a flow related pain could be the first symptom. We should look at the pressures in these patients at the venous cannula right in beginning, and then maybe at the time of pain when it's happening. So when we cannulate the vein, we should look at the venous pressure then, and then at the time of maximum pain when patient is experiencing, that time we should look at the pain, and again look at the pressure. When we decrease the flow, and see if that correlates.
Thank you.
I welcome Dr. Piyush, Dr. Jindal, and Professor P.V. Singh. Are they able to hear me?
Hello,
Dr. Piyush?
sir. Dr. Jindal sir is right there from the beginning.
No, but yes, that's why the PVC, I could see Professor P.V. Singh also, and Dr. Piyush. Welcome to.
Sir, if you allow us, should we move to our next talk?
Yes.
As we have crossed the time limit of this talk also.
No, it will be good because it all depends on Himanshu. Do you agree to? Will you like to take?
No, sir, I'm loving it. I would like.
That's good. Then we should
So
proceed.
our next talk is central venoplasty. As we have already discussed the central venography, so we are moving towards the plasty thing. Central venoplasty, different lesions and different approaches. Sir, the purpose of keeping this topic was if the level of obstruction can be there, right from brachiocephalic to superior of both sides and superior vena cava up to jugular, which lesions need to be opened and which lesions don't require to be addressed. So we would like to hear it from Dr. Himanshu, and I would like to invite the panelists or the chairpersons for this talk, and the chairpersons are Mr. Dr. Mohammad Iqbal Bhatt from who is DM Nephrology from BHU, and presently working in Jammu. Next is Dr. Sant Kumar Pandey. Everybody of us know Dr. Sant Pandey. He's a senior consultant nephrologist in Chandan Hospital, Kumti Nagar, Lucknow. He is Dr. Gaurav Shekhar Sharma. He is assistant professor of nephrology, presently at AIMS Rishikesh. He's a wonderful academician. Next. And next is Dr. Piyush Roy, who is senior interventional cardiologist at Heritage Hospital, Varanasi. And he is often serving in solving such cases with us. So welcome all the chairpersons, and up to you, Dr. Himanshu.
Thank you, Dr. Mahen. So I think we did cover our lot of things in our venography talk.
Yes.
Well, and why again the same talk is coming? Okay. Now is the slide of central vein angioplasty visible?
Yes.
Okay. So we can see this picture, I was talking about left-sided line, which has been there, and you want to go and create a fistula on the same side. Look at this picture, beautiful. So the point is there are two curves, 1, 2, and 3. Left innominate, so IJV comes down like this, then innominate goes like this, oops, sorry. And then, so there is a 2-point contact of a permacath, okay? Permacath will have tendency to lie straight. And that's the reason if you have a permacath on the left-hand side for long, it will be constantly touching this side on an inner curve and at this area on this side curve, and which ultimately will lead to thrombosis and stenosis of the central vein.
Sorry to interrupt, Dr. Himanshu. Whether the cause of the central venous stenosis in our CKD patients is only the lines that we insert, or it can happen because of the high flow of AV fistula and the shear stress?
Yes. So I think in very, very simple language, I say that God has not made veins for so high flow. Okay, very simple. And once we put in such a high flow inside, this will definitely have problem. Second is the thoracic, venous thoracic outlet. So if you look at this picture only, this is your, clavicle, and this is the first rib which is coming. Okay. Now, imagine a big hose pipe in which, say, a little flow is going. When you start a very high flow in that hose pipe, that will, swell up. So this becomes a relative narrowing for every single patient when we create a fistula in there. Okay. Now imagine this is a clavicle. Again, if you can see the movement of my mouse, this is a clavicle. There's a vein going below, and underneath there is a, the rib, and then there's a subclavius muscle and some other muscle attachment also. So there is a, the fibrosis and hypertrophy of muscles also. So venous thoracic outlet syndrome is a very significant cause. This also. These are two major. Apart from then, there is a definitely high flow. So what happens that, and based on that, there's a lot of new, developments have also started in terms of treatment, especially for flow reduction. I think in one of the talks today, later in the day, we will be covering that also. The concept is we do not want fistula to keep on going higher flow. All we need is 500, 600, 700,000 flow. But there are times patient, because you are opening an artery into a low resistance venous system. Okay. If hemodynamics permit, patient's flow will keep on increasing. And then at some point, the veins will start closing off. Okay. So based on that experience, now we have also done almost 10 cases, Dr. Mahan, so far, where we focus our approach not on opening these lesions. Sometimes there's a possibility they are not the culprit. It's our inflow. So inflow reduction could be one of the option for this, treating these as well. So indication, coming to this now talks, I'll keep very centered. So first indication is preemptive before planning an AVF. AV fistula या graft या basilic vein transposition बनाने से पहले, we are doing a central venous angioplasty. We're not talking about only, we're not talking only about the venography. Now we're talking about intervention. So as I said, preemptive mostly I avoid, because the problem with the venous flow is when you do an angioplasty and you don't have arterial flow or fistula flow in that case, chances of this remaining open or getting rethrombosis are higher. So you want to have a fistula running on the hand when you want to do this, intervention. So suppose if I've done an angiography, I see there is a stenosis or occlusion, and I'm planning for a AV graft in the same patient. So what I will do, I will open an axillary vein. Okay, I will put on my sheath. I'll do a central venous angioplasty. At least cross a wire, keep a balloon on table. Go ahead, immediately connect the AV, do a AV graft. And then at the finishing do a completion check angio. So that kind of preemptive, yes. While placing permacath in it with occluded central veins, that is one more area. So you have nothing left and your patient still demanding for a permacath. So sometime you can do a venogram, you can cross, you can do a plasty, just sufficient enough so that you can permacath tube can go in. Your target is just to pass put the passage of permacath through it, not to keep it remain open. Then yes, arm swelling after creation of an fistula, and arm swelling in a patient with previously functioning AV fistula. These are two different things. Arm swelling in a patient with previously functioning fistula, the patient which we saw in previous presentation, those are very easy to deal with. I mean, technically, I'm talking in terms of puncture, because the vein is mature, it can easily take puncture. Whereas, suppose you have made a fistula 2 days back, and now patient come out with a swollen arm, and you want to go to do a puncture, putting a 6-inch or 8-inch sheath, and then going a central venous angioplasty, and then coming back and either you want to repair that whole of vein surgically, or you want to keep a press. So that's always a mess. So arm swelling after creation of a fistula in this scenario, I would prefer, if swelling is not massive, at least control it initial 4 to 5 weeks till vein is anyways maturing, and then do an angiogram and further. In extreme case scenario, you can come from the other side. You can use a very small puncture, very fine needle from the fistula side to do an antegrade flow, antegrade angiogram, and then also come from the femoral below to try to cross the lesion and do angioplasty. And then femoral permacath in sitting of previous DVT. So these are all indication where you actually, for a procedure, you are going to do angioplasty. Okay. Long-standing permacath with facial swelling. This is one of the very questionable area, and this question I'm opening to the floor. I do get a lot of time, call or reference and request कि साहब पेशेंट को परमाकैथ पड़ा हुआ है 1.5 साल से और अभी राइट साइड फेस में स्वेलिंग आ रही है, इसकी एंजियोप्लास्टी कर दीजिए. So what is the call of a house कि what should we do, or what's the practice आप लोग देखते हो in your setup? Dr. Mahendra?
Yes, I am listening and thinking. Actually, what I think, until the common outflow, that is the superior vena cava is blocked, the face swelling doesn't appear. Usually, we see less of face swelling because of unilateral jugular or unilateral brachiocephalic block, and more when the superior vena cava is blocked. So.
But there could be scenario when patient already had left side, say IJV was blocked.
Yes, and
okay.
Both the sides of brachiocephalic.
And now you have done a right side permacath and right is also blocked, and now patient is having facial swelling.
Earlier the better. You shift the patient on AVF and then do the plasty thing. Remove the permacath. Removal of permacath itself will create some space that will lead to reduction of the face swelling.
Agree. I think my take on this is also somewhat similar. If you are really worried about face swelling, then the only option is removal of permacath. A lot of time, as I said, the angioplasty of an area which is otherwise not having arterial flow doesn't help much. Okay, even if it has to help, at least you have to remove permacath. Now, one of the recent patient which I found was actually surprisingly left side, everything was open. Only problem was right side facial swelling. But then retrospectively, I asked, the patient was anyways drinking a lot of water. So he was anyways wet a lot. So patient, those who are already, on brink, and they might have some symptoms, and just simple with a good dialysis and good water intake, milder symptoms can be managed. Major symptoms, they should know that this may land up in loss of upper limb AV axis. If permacath is functioning, so at least mera take ye rahega, as long as permacath is functioning, keep it there. Or if you on venography, if you think you can plan a AVF on that, then shift to the femoral permacath with the understanding that we should come back and do a AV fistula as soon as possible. Okay, now this is all about armamentarium. So I think in this particular point, we are better off online than going offline. Because यहाँ पे I can actually find out online images and show it to you. So sheets, you should have in any of the cath labs always 6, 7, 8 French sheath. We will be talking about certain stents who need 10 French sheath. So one sheath at least we need in cath lab. So they should be there. These are the normal routine sheets which are used in cardiology. Then there are certain we call as a long sheets. So long sheets, sorry, 65 to 90 centimeter long, 45. They come into variable this thing length. Purpose is that when you are torquing your wire at the end and you want your wire tip to move right in chest, you need a good support of that wire. Okay, sometimes just wire or just catheter will not support it, and these are one of the most important support system when you're specifically dealing with central venous occlusion. Okay, my personal workhorse is Flexor from Cook Medical. It I think costs around 7,000 or 8,000 rupees. You can easily ETO it a couple of times. You should always have it. And when you use it, even 6 French sheath is enough. You don't need to go for 7 or 8 French in long sheets, because all you want is to take your wire across, then maybe switch to a smaller sheath. Because when you're actually passing a balloon, you don't want to be passing an aux balloon through this. That will take so much of time. Okay, and then Destination from Termo is recently relaunched and excellent sheets. They are also crossover sheets. So crossover, if you look at this closely, they have braided. So even if you bend them like 180 degree, they will not kink. So they are kink proof. Then there's a Mullen sheath, and there are certain sheath that are used in cardiology. Wires. So my personal workhorse is 0.035 hydrophilic glide wire from Termo. And length, wires actually come in 2 lengths. One is this one picture you can see. Actually, now I'm realizing, sorry, not the right picture. Is a 150 centimeter. What we need is a 260 centimeter. Why so? All the angiography balloons we use are over the wire. That means you need to have a sufficient length out of the patient so that you can advance your balloon on that. So you always open a exchange length wire, not the 150 centimeter. They come in 2 type, although they're different, but the J tip and straight tip, like this one, if you see here, is a J tip, is a straight tip. So it will help to drill into a straighter hole. J tip will help you to maneuver into smaller, to different directions. Then this is also important to know that in Termo wire itself, you have a normal Termo or soft Termo and a stiff Termo. Okay. Sometime the wire which is looking exactly like Termo, the basically 035 glide wire, and you will feel it's a bit thicker one. They also come into 0.038. Do not let your technician open that by mistake, because then your catheters, your balloons will not track over them. Sometime your technician has ETO'd them n number of time, or maybe did a temperature was not right, or just simply too many times it had been used. These wires tend to swell up over time. So not more than 1 or 2, or personal recommendation, at least 1 NY wire is mandatory for when you are planning for intervention. Second, the Emplards extra stiff. Okay, there are a few others also which are stiff wire. My personal work, this thing is for Emplards extra stiff wire. It's very important that stiff wire moves only inside a catheter or sheath. Okay, that means suppose you have a puncture on the left brachial artery, also or left elbow in a vein, and your Termo is into IVC. Now you want to track your balloons up, and balloons, simply balloon is not going through it. Then what you want to do, you want a stiffer wire. So you want implants extra stiff going from your elbow to your chest to your IVC. Now, how will you do it? First, you will take a catheter onto your thermo. You will park that catheter into your IVC, and then only you will take implants extra stiff wire inside. You do not, again, it's in red, you do not move stiff wire inside inside body unless it is inside catheter or sheath. So, not only while putting or while removing also. Okay, when you are pulling a wire which is stiff and which is not protected by catheter or sheath, it can cut through the entire vessel. Okay. So here I would like to discuss the concept of tracking over the wire. Okay, these are the pictures which I drew almost few years back to post in one of the Facebook group. Now, we all are familiar putting a left IJV permacath. So I thought I'll just take the same here. Now, if you have a wire here, and please look into the movement of my mouse. If you have a wire here only till here, okay, and now you are trying to push up a sheath or say dilator. हिंदी में बताता हूँ, एंडोवास्कुलर में ये होता है, जो ज्यादा टाइट होता है उसी की चलती है, ठीक है, जो सॉफ्ट होगा वो मार खाता है. And so here sheath, if you are trying to push the sheath, okay, this is the path, and because you don't have enough purchase of the wire, the sheath will tend to go into this. Okay. Now, support can either be gained. No, you need more support. It can be either gained by distal length or strength. So one of the commonest thing which we do is you pass your wire, right into SVC into IJV, so that this gives you adequate support. And then while you're trying to push the sheath, you pull the wire back. So this is a kind of a, pushing and pulling moment, and it glides into the SVC. So that's one thing. Alternatively, as I was saying, you can have a hard, don't do this, but just for a concept, you can hard wire coming till to SVC itself, and then you can still push your catheter on top of this. Okay. Now we see example of this. What happens? You see this, you get called in mid of a night that, somebody has placed left side IJ line. We have been doing dialysis and patient has swollen up. When we go put a chest tube and we took out the 1.5 liters of blood from the pleural cavity. So you can see there's a left innominate vein perforation. So getting the wire through, first thing, we have seen the venous image, the technique of angiography. Now the point is the first thing of angioplasty. What you say to a patient, वायर चला जाएगा तो बलूनिंग कर देंगे, नहीं जाएगा तो फिर कुछ और सोचना पड़ेगा. Okay, so you should know the right anatomy. Now knowing right anatomy is very important, because when there's occlusion, everything else will be visible but your vein. Okay, and what you need to do is you advance the tip of your wire into the line of vein. Okay, so it's very important to know the right anatomy. What is the normal course of innominate vein? What's the normal course of a SVC? Then get into right channel, come from below, and do not push into collateral. These are, 4 basic fundamentals. We are still going through, we will discuss some cases later on. Once we are through the wire, then the point comes to the balloons. Okay. Now, most common mistakes which I have seen with lot of interventionists, they have fear of using the right size balloon. Okay, I see people doing innominate angioplasty with the 8 or 9 mm balloon, and then patient not getting sufficient, relief. The typical size for SVC is actually up to 16 to even 18 mm balloon. Coming to innominate, at least 14 mm balloon. Then subclavian, around 12 to 14 mm balloon. And then rest also depends upon the dilatation of vein. Okay. You do not want to be using semi-compliant balloon. How do you know some semi-compliant balloon? There's a lot of balloon 035 that will be in range of 15, 16, 17,000. Okay. At present, I think there's one more which is coming, but unless it's one of these two, Atlas from Bard and Boston Scientific Mustang. If your balloon is not from this, that's not a high pressure balloon. Okay. Why high pressure balloon? So venous stenosis are like elastic and they're very tough, unlike artery. A very tough, stenosis. So when you inflate it, the normal balloons, the normal pressures, say 5, 6, 7, 8, 9, 10, they may not even open. There could be residual significant waste. So semi-compliant balloon is a big no for venous angioplasty. High pressure balloons, yes. No stent, please. Okay, and we'll come to this later. If you remember, Dr. Mahendra, actually Suez Canal mein last year, there's a lot of memes going on. So this is one of very favorite meme, favoring in vascular groups. One of the person they gave a suggestion they should stent it. So no stent in this area at least. Why no stent? They do not offer you patency. Okay, so जो जितना angioplasty चलेगी लगभग मोटा मोटी उतना ही, and sometimes even worse because they're done with the poor planning, so poor patency. Sky high costs. We can discuss about the cost during discussion. Reintervention is made very difficult because when stents get occluded, a lot of time they get fractured also, impossible to pass a wire through. And then this all is happening to a patient, poor patient who's undergoing dialysis, getting frustrated. So it's a big psychological trauma to patient also. But only if you ask from one point to put a stent, at present, I have only two options. Okay. One is sinus venous that is made from a company called Optimed. If you look at this stent, it comes in an excellent long strength, plus every strut is a separate. So what they say, at least claim as a company, that even if it has to happen a fracture, it gets converted from one stent into two broken stent. And when you're coming for follow-up, it helps you and you can reline it with a new stent. That's their policy, although I have not experienced anything like this. And second is a covered stent. So, which is a fluency, the available one is Fluency Bard. Yes, definitely. Covered stent does offer, a patency the superior patencies, and because of the character, coming back and doing redo interventions is also feasible. So those patients where, no matter how good result you have, patient they come back to you again within 3 months, 4 months, there is a certain subgroup of patients who can still benefit from covered stenting. Okay. And yes, this is the one which I won't mind, stents, the Covera, which has been specifically developed for the venous end of a AV graft. Okay. Done a few, I've seen excellent result, and every patient who used to come back to me, say like every 6 months or a year for a repeat angioplasty, they have been, the longest I have is around from 1.5 years, no intervention at all. So yes, that's one of the stent we should have it. Dr. Mahendra, any discussion, or now we should start with certain cases?
I think Himanshu, you can start with the cases. We'll have the discussion at last.
So this is what I love, is the 10 minutes angioplasty. Very simple. You do an angiogram. You see there is a very fine channel here. Okay, at this area, you see the very fine channel. You pass on wire without much difficulty. You take your standard balloon up. You tell the patient will feel some heaviness, and then on a check angio, you can see here, and this is the actually angiogram on DSA mode. Again, I said all the videos and pictures are from my phone, so apologies. Sometimes the quality may not be good, but you can very well correlate here. There's a hugely dilated vein. There's a very nice thin channel here of left innominate. Okay, and this is post angioplasty. So these are typically, so patient also gets so comfortable sometimes once you finish entire procedure within 10 to 15 minutes, that they do not mind coming, say 9 months down the line, getting a small procedure done, than rather losing, tying off a fistula, going to other hand, or say, thinking for a stent. So these are one of the best one. But then there are those that spoil your evening plans. आप कुछ घर पे बोल के आए होते हो, या शाम को movie जाएंगे, already booked or something, and you started a case at say 5 o'clock, that will finish in say थोड़ी देर में, and then you are there at 7:38 still trying to do the case. So here you see there is a patient we are trying to cross from above. Angiogram I have shown actually before also in the previous slide. But this is a total occlusion. Okay, on total occlusion, you try to pass from above. You have a sheath. You can see this is a braided, the Ansel, Cook flexor sheath right here. Then you have a catheter wire. This catheter coming right inside it, and you're trying to pass a wire, but you don't see any channel. Every time wire keeps on going to Every time wire keeps on going to some other channel. Then you come from below. So Dr. Mahen, here, this is one of those examples. So I'm from the RA, so IVC, RA, I've come to SVC, and I'm into distal part of the innominate vein. And here right now there's only one catheter. But here, see, for the support, I have taken, so this is the sheath. This is actually dilator of sheath. So sometimes dilator of sheath also helps. And then, after multiple attempts, I've crossed the lesion. And this is the first, angioplasty I'm doing. Look at we call it lemon seeding. So just like when you squeeze the lemon, seeds, they squeeze off. Similarly, when you're trying to inflate the balloon across the area of stenosis, balloon tends to jump into area which is open. So you again have to advance it and do it. See, as we are opening the balloon, this area is actually open, so balloon will jump back. This is called lemon seeding. Okay. So solution is you actually advance your balloon further. You can see here. Okay. Now, yep. So then again you try to keep your balloon right in mid of stenosis. And this is post angioplasty. Okay. This is one of the dance. Sometimes you have, you do put effort from below, and that's why cases like this, you need to have two interventionists. So one person who can work from below and one person who can work from above. And believe me, sometimes just crossing the very small 1 millimeter could be difficult, and sometimes you may land up calling off a day because you're not able to cross it. Here again, I would like to show this. The point was of putting this video was what I'm using is the back end of a tip. Okay, this is not a front end of a guide wire. This is the back end of the wire. Now I know where to proceed is. I know the path of left innominate vein from below also. So in this area, for very short, but the back end of the Termo glide wire is a very stiff one. So, but you can utilize this. Sometime the moment you go through, and then you can turn your catheter and utilize the front tip to pass into the further lumen. Like once you go through this, then you can cross again. And then pictures like this. Okay, you have pacemaker wires on left, pacemaker wires on right. Patient had a left upper limb working fistula, which was now almost for 1.5 years. Patient is having arm swelling. I'll be very honest. I was also skeptical about putting balloons across this area, but then I had a privilege of taking out the pacemaker leads in one of the patients who had an infected sinus, and that time I realized how hard fixed they are. But again, when you're trying to do a plasty in this area, first you should always have a cardiologist standby. As per the instruction of my cardiologist, we had a femoral line in. We had him available over the call, and if needed, they were immediately available for the pacing, temporary pacing if needed. Okay. Now, unlike the normal ones, here where we can directly go ahead with the bigger balloon. Here, I would prefer like this. We pre-dilate it with this 5 mm balloon, and then once pre-dilatation was done, then we used a bigger size balloon. Although ideally, I would still wanted to use a 14 mm balloon, but sometimes lesser is the better. So here's the picture, and patient had a symptomatic relief. So standard post-operative, if we have rough edges, then sometime I do use fragment for 5 days. Otherwise, it's a high flow. Patient doesn't need anything. There's not even much described role of antiplatelets, but yes, patient who has been having repeated interventions, are very short, say 6 months, 9 months, again and again. Yes, if there's no contraindication, I do add a platelet, antiplatelet. Sheaths exit site, even if it's 8 French, that's a standard practice. I don't remove sheath and press, just to take a circumferential stitch, and that will do the thing. Ask your technician to remove it at 48 hours. Arm compression with a crib bandage is routine, but arm sleeve, just like stockings on the leg, sleeve actually helps very well for the skin remodeling. Just take it that as any of the procedure like the liposuction. So your skin quality becomes much better. Surveillance calls are most important. The training of patient, setting up the right expectation that this will come back is very important. And you should be able to determine patient's recurrence time. So that this patient angioplasty works for around 1 year, 2 years. This patient is likely to come back for 6 months. Be very extra cautious in the patient where you have opened up the total occlusion. You don't want to go and again spend so much of time. And when the patient comes back next time and you take, say last time you took almost 1.5 hours, and second time when you finish it within say 10 minutes, he really feels good. Okay. So that's it for the central venography, so central angioplasty. Dr. Mahen, we are open for the discussion now.
So again, Dr. Himanshu very well covered.
Thank you, sir. Central venous spacer, I have, it's been now 11th year running. I have only seen one rupture. Okay. And when I was in institution, actually, that's one downgrade I have seen. Even the cost is an issue, or sometimes safety becomes, slightly an upper hand that, say, like I go to Varanasi, I cannot, and I have to come back to next day. My balloon size has come down by 1. For anominate, I would prefer to routinely use 14 mm. Now that's an honest confession. There are a couple of reasons to it. One is if you have held the balloon Mustang versus Atlas. Mustang is a very nice balloon which can be cleaned well and ETO'd very well. Okay. Atlas is a very robust balloon. So it has got like threads on side, जिसमें blood stain हो जाता है. You cannot clean it. Atlas is costlier also. But your recurrence time increases if you dilate it well. Sometime वो 12 से 14 वाला एक window रहती है when you actually dilate it well. The same thing which is going to come back in say 6 months will now come back in around in a year or so. So one patient I remember we had a rupture. The control rupture, it was a partial rupture, and that also improved. We just kept a balloon over, say I think 10 minutes. We did a couple of runs, and then there was no bleeding. The one picture which I showed, the left subclavian, left innominate puncture, accidental puncture, that patient also we just pulled it off, kept a balloon there for almost 20 minutes, and then there was no bleeding after that. So that's a fear of the over dilatation is, I think, is a bit more, and I see a lot of people just under dilating, say 8-9 mm, which I don't know.
The rupture is a real danger, especially the weakest part of central venous system, especially at the SVC and RA junction, cardiocaval junction, which is the weakest part. And it is important before we attempt dilation, we do complete evaluation, including CT angiography.
Sir, I don't know. So that's why especially I want to ask. I have been doing this almost, I don't know, I don't remember how many, but rarely I have needed to go back to the junction of SA and SVC and RA. Rarely. Most often it's so you always have this bit of stump open of SVC. Rarely I need to go. Mostly the culprit is the subclavian, the innominate, and maybe the upper SVC. Total SVC occlusion, I did remember one patient, but I was not able to, recanalize it because it was a kind of a bald SA. RA में आपको कोई area ही नहीं दिख रही है SVC में जाने को. I agree that's those both junction, the RA to SVC and RA to IVC. Definitely, if you are even thinking to go and dilate that area, think 5 times.
Himanshu, Dr. Himanshu, I think Dr. Ashish Verma wants to ask some question. He can unmute him and ask.
Yeah, please.
Thank you. I just wanted to know, what do you do when there is a rupture? If there is a leak or what would you do?
Ashish Verma is interventional radiologist in Banaras Hindu University, IMS BHU, and he is head of department of radiology. And they are doing good intervention work there also. So just to introduce him, now Himanshu, you can answer.
Hi, Dr. Ashish. So depends on the couple of things: the site of rupture, the rapidity of extravasation. Okay, so 2 areas where if you have had rupture, you're gone. Okay, they have to be taken care. Either fistula has to be ligated, or in worst case scenario, it has to be surgical. One is axillary vein rupture. Okay, I'll show in one of the slides today also. Axillary vein lies into axillary fat where there is no external support, and if there's a linear tear to that area, that is not going to hold. There's not supporting tissue, and this will just keep on bleeding. Especially if you on angio you can see there's a lot of extravasation, rapid extravasation. The blood starts going into fat, then that starts percolating into chest wall. So that's you should be very careful on that. Although, and second part is, as Dr. Mukhya said, junction of the RA and, from either SVC or this thing, to SVC or IVC. I've seen one patient where a stent actually caused pericardial tamponade. And that patient was so obese, even percutaneous tapping could not be done, some issue, and then actually had to open chest to relieve that. Okay, so and repair that area. So, but if you identify a rupture, just go back and put a same balloon which you have used, again back with slightly lesser pressure. Okay. So if you went to 10, just make sure you go in 8 and hold. And do not just keep on, and then obviously you also have to make sure that patient's hemodynamics are good, patient's PTINR was good. There was no other pre-existing situation which was reducing the clot. With multiple holds of 2 to 3 times, up to 4 times, if you're seeing the decreasing trend, you can actually, keep patient in observation. But yes, this is something which should be never be taken lightly. Especially one of the things which I said, do not push into collaterals. If in process of doing so, you have been damaging your collaterals, one collateral which is taking origin from say innominate going into chest wall somewhere, you have actually perforated that, then you cannot do anything. It will bleed. And then if you are lucky, if you can identify, you are the specialist, you can probably go and put in a coil. But I think that's something which should be clearly avoided.
Yeah, in fact, one of the practical contraindication of doing angioplasties in general is unavailability of, material which is required to salvage the problems. If there is a rupture, you need to place the stent, you need to have the backup from the cardiosurgery side or cardiology side who can do the pericardiocentesis or, take the patient in OT immediately. So, you have to have some backup to handle those complications.
Agree, sir. But so rest two are utmost important. You should not do in a setup where you don't have a cardiologist available on call within few minutes, and at least also you should have a cardiac surgeon also available in case if you need. Best, I would love to have a covered stent, but I have worked in I have worked in almost all of the premier centers in the country. None of them have on the shelf available covered stents. That's the problem is again logistics. 1.5 लाख का स्टेंट है, डॉक्टर साहब कितने दिन आएगा, कब चलेगा, मंगा तो लिया था, वापस करवा दिया. I had one patient who had ruptured SFA, superficial femoral artery, I think a few months back, and I had specifically asked for one, because arteries may see rupture more common than vein, where you need to put in a covered stent. और मैंने कुछ 1 महीने पहले ही चेक किया था, and then suddenly when you ask it, it's gone. Sir, वो use नहीं होता इसलिए वापस भेज दिया है. So logistics are a big problem. But that kind of Dr. Mukhia, but where you can come up with most of the leakages, you don't need to panic for a stent. And biggest thing is do not put a bare stent at all. Bare stent तो क्या करेगा, वो जो छेद है उसको और टेंट करके बड़ा कर देगा. So a prolonged controlled ballooning is something which you can always, at least कुछ भी नहीं हो रहा है, आप balloon inflate करके छोड़ दो, ठीक है, उस एरिया में. ज्यादा से ज्यादा it will lead to the DVT of the upper limb, but that will save the life.
Another thing is, the necessary material means you can encounter complications not just by rupturing, but the part of the guide wire can, get into the circulation. You need to snare it back. So you need to have some materials. You cannot just go and do the procedures without proper material available in your,
Totally agree. Snare is actually useful a couple of times. Number one is this also, but more than that, sometime if you're going for, we call it brachial floss. So suppose one of the very problem we face sometime with the difficult angioplasty is कि wire तो cross हो गया, अब balloon नहीं जा रहा है. Now balloon is not tracking at all, and you want it. In that case, you want to pass your wire into SVC, from SVC into IVC. From below you snare that wire and you take it out. Now you have a wire jiska ek end you are holding on the femoral vein, and then one end you are holding on the elbow. And then, with this, and you are maintaining a constant pull that from both ends, and then you try to push the smaller size balloon on top. So that's also, agree, snare is one of the things which you should always have.
Just two things which I wanted to mention. These are patients of chronic kidney disease on dialysis. Most of them, they come in fluid overload state. They come with significant arm swelling because of central stenosis. Liter of it is important, those patients need to get their cardiac workup, echo at least, to assess their cardiac function, as well as do the dialysis before taking them for dilation, because that can cause problems while once you dilate, 1 or 2 liter of fluid will go into the central circulation and it can compromise the cardiac function. So that is the preparation part is again important. And the other thing is just a physiological thing. Physiological thing means, the subclavian artery is physiologically narrowed at the thoracic outlet. So once you are doing the angiogram, then it's important to remember that this physiological narrowing is not considered to be as a cause of arm swelling or
So, sir, number one, that is why, I mean, as an interventionist, my policies do not entertain a patient if he doesn't know his nephrologist. So, no, we do not as a proud, and that's a proud learning I had working with Varanasi Nephrology Society. One of the biggest reason of any complication, the biggest risk factor of any complication of a CKD patient, if he doesn't have a nephrologist looking after him. Okay, and I think that also Dr. Mayank will agree that we have, I personally have learned by even certain wrong decisions. A lot of time patient come कि वो कहीं किसी technician से dialysis करा रहे हैं और ये हुआ है वो. They're not physiologically, preserved. And no matter what, I cannot help a patient by doing an intervention if he's not being physiologically treated before by a treating nephrologist first. So that I fully agree.
So Himanshu, are we done with this talk? So
Yeah.
it is over to the chairpersons if they want anything to ask. Dr. Gaurav, Dr. Iqbal, Dr. Piyush.
Yeah, I think Dr. Ashish still wants to ask something.
Yeah.
Sir.
Dr. Ashish sir can unmute himself.
No, it's okay. I'm done. Thank you.
Thank you, Dr. Ashish.
Okay.
Dr. Iqbal, क्या हाल चाल?
Good, sir. Thank you, sir, once again. This was, in fact, a learning opportunity for me rather than a chairperson. Just one small query is that in your opening remark, you said that in a fistula, the flow of around 500 to 1 liter is good enough to for a good dialysis. But practically, I faced that in a couple of patients, even if at a blood flow of 600 to 700 ml, the flow through the excess, even at that level, the flow which is this flow is not able to sustain the dialysis. Adequate flow through this dialysis lines. So, what is the appropriate flow for this?
See, I will answer this in a reverse question way. What is the best flow you want in your dialysis machine for a fistula, for a patient for a good dialysis?
So I would prefer at least 300.
300 to 350. Okay.
So 300 to 350 typically is the one what you get from a permacath maximum. Okay. Fistula, when we say rule of 6 is, a mature fistula should roughly has around 600 ml of per minute of blood flow. If you are not getting that much of blood, you should look if there is any issue in a fistula. We'll be covering that in some talks. The point is, if fistula flow, so my point that time I was making, that in this process where you have connected a fistula and in process of arterialization, sometimes fistula can dilate over a period of time, and the flow can actually increase into liters, 2 liters, 2.5 liters per minute. Okay, That's too much. The point there was that in place and sometimes this high flow is further causing the central venous narrowing because of simply high flow. And what if we are only focused
Relative narrowing.
and what if we are only focused, no, actually you can see the actual obstructive lesion also. You do angioplasty, again you put a very high flow in that area, and that will again develop a intimal hyperplasia. Okay, so what if along with opening the central veins, you also need to decrease inflow so that you can improve the flow dynamics in the area where you have done the angioplasty. There has been a lot of papers recently that which is called the fistula flow reduction techniques, where in such big size fistulas, apart from doing central venous angioplasty, you also decrease the flow of fistula. Also, there are certain patients where if you are not able to completely open the central veins, at least decrease the flow in fistula so that a fistula can run without any major problem at say 600 or 1000 ml per minute, and then collaterals are sufficient enough for that at least. Okay, so that was the point. If fistula is running very well and you are still not getting enough blood, you have to see some technical issues, either with puncture points or something. We are missing something. Okay.
So any other questions and queries from chairpersons? Hello, Himanshu.
Sir.
So if there are no further queries, we can move to the next session. And are you okay with the session or want a break of 5 minutes?
We should take a break of 5 minutes and come back.
Sure, you are allowed to take the break of 5 minutes. Thank you, chairpersons, for making
this. You can continue some discussion meanwhile. Otherwise, our attendance to 42 will go down.
Okay. That we are doing. The way these.
Hello.
Hello, sir.
Dr. Mansin, I'm Dr. Dole. Yes. Dr. Himanshu.
Dr. Dole, Dr. Himanshu has taken break of 5 minutes.
Okay, good.
You'll be back. You are welcome on this virtual platform.
Okay, sir. That's I want to put one question actually.
You can ask. We will try to answer.
Dr. Man is there now. Okay. So, what is the chance of recurrence after stenosis? Do you have any idea how we should follow after procedure? What is the standard protocol for follow-up of this patient after angioplasty or venoplasty? So I want to get comment from here. Anyone from us?
Depending upon the lesion, he is going for follow-up either 3 monthly or 6 monthly by doing venogram.
Okay, what is the chance of recurrence? See, it's
almost all recur. Either
almost all recur after.
Sometimes we have seen in few patients, probably the high flow, in fact, stopped the early recurrence in some central vein lesions. There were high flow fistulas. When you dilate those areas, those high flow, that high flow in fact prevents the area from collapsing or the fibrosis from collapsing. So some patients surprisingly maintained for 1 year or 1.5 years, but almost all recurred.
Dr. Hemant Singh.
Yes, sir.
Immediate post-op, how many days they should be put on some treatment? Anticoagulation is needed or not? One. And if needed, after how many days of anticoagulation you ask the patient to come to your OPD for follow-up? After central vein angioplasty.
It's an OPD procedure. The procedure is being done in OPD, patient being observed for 2-3 hours. After that, the patient is being discharged. And there is phenomenal response in arm swelling if it is there. You can see phenomenal response with more than 60-70% of the arm swelling disappearing within next 24 hours. Yes. And next 3 to 6 months follow-up is being done. And in fact, the appearance of the symptoms or appearance of the arm swelling itself will guide you towards the follow-up.
No. Do you go for anticoagulation
That is
immediately
not
and stop?
sir, that is not necessary in every case.
It's not
If-
necessary.
no, sir.
What are the cases where you go for it?
अरे बकवास
Thrombotic cases, he is going for that thing. If you are removing a pump cut which was thrombosed or anything, then he
How many days anticoagulation is needed, and that will be only oral anticoagulation you go for, or you practical points I'm asking.
7 to 10 days of IV Clexane.
IV.
Sorry, enoxaparin or deltaparin. Mostly deltaparin we use.
Regmin you are using it. Yes. Okay, that's nice. And then subsequently, how frequently you call these patients for follow-up to see for the any stenosis? Because most of the lesions which has been angioplasted, there are chances that they will get stenosis. How frequently they should be follow up? Every 3 months or 6 months it should be done.
We are trying to build up a follow-up program for these patients as well as for AVF patients also. All the working AVF patients are advised to show Dr. Himanshu or whoever so med has the fistula every 3 months to see for the impending complications. And regarding this central venous occlusion, a 3 to 6 months follow-up is necessary.
What is your experience so far that suppose 100, I do not know the number, maybe 50 central venous angioplasties have been done in last 5 years or so.
More than 100, sir, more than 100.
100. What is your experience? How frequently they have re-stenosed, and what do you do in this situation in these patients?
Almost all surviving re-stenosed over a period of 3 to 6 months, maybe up to 1 year.
1 year.
Almost all will re-stenose.
And what do you do with these re-stenosis patients?
Again dilatation.
Again,
For the
dilatation.
central venous thing, you cannot do anything except the dilatation thing.
No,
However,
but in these re-stenosed patients, if you go for angioplasty, how is it different as compared to the first angioplasty, or
it is
results
easy.
are the same?
The first angioplasty is usually the most difficult thing because
Yes.
you are breaking the fibrous band for the first time. The next angioplasty, since you are prepared for the lesion to re-stenose, you are well prepared. So early intervention is done during the second one.
Re-stenosis angioplasty is easier as compared to the first.
Relatively easier as compared to the first one.
And what is the outcome in these patients?
So outcome is good, sir. For if you what we are doing, we are just prolonging, we are decreasing the morbidity and we are prolonging the life of the AV axis. Both these things are very well achieved.
If there are few questions in the chat box. How commonly you consider putting stent for stenosis?
I think Himanshu has answered it very well. Apart from 1 or 2 lesions, even if there is a gun on his head, he is not going to put a stent in these central venous.
Yes, stenting for venous stenosis, stenting is not preferred or not recommended except for rare cases. And another question is if he has any experience with stenting with this stenosis.
Only he can tell, I think.
I think he's back now.
Put few stents and he can tell about it.
Dr. Himanshu is back now, and you have to answer this question from the chat box. Dr. Manjeet Pal Singh wants to know what is your experience of this stenting in central venous stenosis, and if yes, you said that it should not be preferred or it should not be recommended. But if you have done in few cases, what has been your experience as far as stenting is concerned?
Actually, my experience of stent comes from more than stent seen than stent put.
Oh.
So
done stents, you have seen more.
I have done, I mean, every month at least I see 1 or 2 stents which are blocked, which I see. And then I see a lot of patients and I keep recanalizing them time and again. Now if I'm, the problem with stent is, I think I should be able to share one, give me a second. I should be able to share a couple of videos. They were in my this thing. Anyway, the point is when you do angioplasty, the most important thing when you do a check angiogram, you see, okay, still there's a lot of residual narrowing, okay, and you want to put in a stent. If your collaterals have disappeared or significantly decreased, veins sometimes do not look as open, but you should not stent it just because it's not looking good. By putting a stent, you can make it look good, but you're not going to increase patency rates. Okay. Not stenting in first go for sure ever. Now you have a patient who keeps on coming back to you, say within 3 to 4 months. There is one patient I know. So those are the patient, yes, you do want to put an stent. Okay. But with the understanding that the superiority is only if you put an appropriate stent. You want, if there's a financial issue, you want them to manage on a repeated angioplasty 1 year, 1.5 year, 2 year, till they arrange enough money for a covered stent. Only superiority that has been shown is by a covered stent, nothing else.
How costly is covered stent as compared to the routine stent?
Fluency comes around 1.39 lakhs or 1.4 lakhs. Okay. So, and so 1.2, so one something in that range. And then along with that, you need these are self-expandable long stents. So you also need a balloon for that. So covering a balloon and stent combo is 1.6 lakhs. Okay. Now, अगर किसी patient को say in setting like Fortis Medanta जहाँ पे a simple angioplasty costs almost 90,000 1 lakh rupees और एक साल में 2 या 3 बार angioplasty करानी पड़ जा रही है, for that patient it will make very much sense. Okay. But second thing, when you put stents, only put stents for the patients who are compliant to you. जो आपके patient हैं, आपके पास आते हैं, कोई भी issue होता है तो every 3 to 4 months they can come back to you. You don't want, you want, you know, and third is, you know, you don't want to be extending your stent across the joint. That's a very, very sure. Stenting in AV fistula. So sorry, Abhi, we are. I think we are only talking about stenting in the central veins.
Central veins.
हाँ, तो central veins में यही है. There is one more scenario, जहाँ पे you know, I would want to put a stent. If you have a free floating thrombus, okay. So आपने permacath एक patient का किसी reason से permacath निकाला, permacath पे आपने देखा बहुत बड़ा सा clot था, and now you want to again put a permacath in, or you want to do something. So one of the use of stent is to plaster a segment of clot against the wall. Okay, you do it in IVC, in arteries also, sometimes aorta. So that's मुझे exact indication patient कुछ याद नहीं आ रहा है, but we have done, I remember a couple of them. So जहाँ पे you go put in a stent with the intention to plaster a clot on the wall. So that's one.
That's good. Dr. Mahendra, should we go for the next talk? Dr. Hemant Singh, are you?
Yes, sir. I am there with you all.
Yes.
So let us move for our next talk. And I think now Dr. Himanshu is a bit comfortable, as after recovery he is almost there for continuous for last 2 hours.
Yes, but I would actually पहले से माफी मांग लेता हूँ. This is not that comprehensive talks, because this balloon or that balloon, our thought initially was to actually select 2 kind of patients and then real time use you know, the balloons and see their you know, effect, and unfortunately that is not happening. So Dr. Mahen, would you like to put on for the panelists?
I will like to invite our chairpersons, Dr. Gulshan Mukhia sir. He was there till now, but I think presently he is.
No, he is still.
No, he is there.
Yes, you can see him on the screen.
So he's DM Nephrology from AIIMS, and he's Professor of Internal Medicine and Associate Professor of Nephrology at Gitanjali Medical College, Udaipur, Rajasthan. And we can very well see his interest in interventions right from the beginning and in past chapters of vein also. So our next chairperson is Dr. Kunal Gandhi. He did his DM from SMS Jaipur, and he is presently working at Max Super Speciality Hospital, Delhi. He has over 20 publications and peer-reviewed national and international journals, and he has been a co-investigator of a number of landmark clinical trials. So welcome, Dr. Kunal Gandhi. Our next chairperson is Professor Rajesh Kumar. Professor Rajesh Kumar is presently working in Safdarjung Hospital. Previously, he was head of department of that Safdarjung Department of Nephrology Safdarjung, and he has done immense work in keeping that department up, and is starting the work of intervention and other nephrology work in that department. So welcome Dr. Rajesh Kumar.
Thank you so much, organizers, Dr. Ahmed Singh.
So over to you, chairpersons, and Dr. Himanshu to start the talk.
Hi, Dr. Rajesh. Hi, Dr. Kunal.
Hello.
So, Dr. Mukhia, I've been always your big fan right from beginning. So since we met in first time, and aaj bhi, one of the first thing I said that venogram technique, that's one of the learning which I took from the vein was doing a venogram, and it's really been helping me a lot in my career. So thanks a lot, sir.
Most welcome.
So let's start. As I said, that the initial thought was this balloon or that balloon, to actually hold balloons in hand and select the different patient population and show that what is this compliant balloon, what is semi-compliant balloon. But anyways, now we are moving from torso to hands. So coming to peripheries. And before we start blasting them with different this or that balloon, we should know what are the types of lesions we are looking at. Okay. I think there's a talk later in the day by Dr. Tripathi, where he should be covering about the natural history of fistula. So with that, we will be able to identify more about these lesions. But if you come about the four peripheral kind of common fistula, it's the radiocephalic fistula, brachiocephalic fistula, then we have a basilic vein transposition, and then we have AV graft. In radiocephalic AV fistula, you have typically the most common is a swing point stenosis. Then you have a long or short segment of radiocephalic stenosis. Sometimes you can actually face an occlusion, and the anasmotic narrowing itself. Then in brachiocephalic fistula also, you have a swing point or juxta-anasmotic stenosis. In any of these veins, not only in this, but anywhere, you can have a previous valves which can actually lead to stenosis, and then puncture point stenosis. Basilic vein transposition, again, the upper end where you swing it, there you can have stenosis and again puncture point stenosis, and then AV graft. Okay. Now, AV graft may the most common, most notorious is the recurrent stenosis at the venous end, and then sometimes you even face with the thrombosed AV graft itself. Now, let's start with the first. We have already had discussed some of the the armamentarium. So this, when you do a radiocephalic AV fistula angioplasty, most important is the first and most important step is the access. Now here you see there's a hand, this is the hand side, this is the elbow side. If you have a space, distal radial artery access is the best access you can get because of the suitability of being able to maneuver your wire in either artery as well as veins. Also, once you are done, you can compress this properly without any problem or any risk of compromising your fistula puncture site. Now here you see there's a radial artery, and this is the anasmosis area, and you see the faint filling of the cephalic vein. Here also cephalic vein is a bit smaller. So first thing, you do not never directly jump onto angiogram. You should always decide areas and your size of balloon, type of balloon on your preoperative ultrasound, and you should be able to ask your technician to arrange appropriate. Why so? If you are doing a angioplasty for a say assisted maturation, a fistula which was not maturing, and you want to do sequentially dilated, and fistula which is right now is only 4 mm, the maximum size you're looking is a 5 mm. You don't want to over dilate it, and you want a one long size balloon. So we should know that balloons are available in different sizes. Okay, whereas if you know there's a fistula vein, here is 7 mm, here is around 4 mm, then you need accordingly you need sizes. Now let's go further in this. We have taken a radial puncture, we've done an angiogram, a DSA, you're seeing this is a, so I apologize, these angioplasties we may not have very extensive images because I tend to store pre and post mainly. Now here we are using a Mustang balloon. I think this is around 4 mm balloon to dilate the occlusion area. Sorry. So here after doing the the angioplasty, you can see the result of one angioplasty. Now in this particular case, what follows through is a long drug-eluting balloon. There's a long drug-eluting balloon, which I'm almost starting from the anastomotic area to the elbow. Now, whether to put DEB or not, I think it will be better off in an open discussion. My take on doing drug-eluting angioplasty is, why do it? First thing we should know, why do we do it? We do it because in the process of angioplasty, you're actually dilating the vein and you are damaging the intima. Now, this damage initiates a process which can further accelerate the neointimal hyperplasia. Okay. Now, the drug-eluting balloon, the paclitaxel which is there, and this one, it lines the intima with the drug, and this is a persistent delivery system. So that drug remains in the area for some time, and it delays the formation of neointimal hyperplasia. So theoretically, it increases the patency. So person which after a normal angioplasty should come back to USA in 6 months' time. After the DEB, patient will come back to you almost, at least 1.5 to 2 times for that. In personal experience, I don't have numbers of that much to put something, good numbers, but roughly around 40 to 45 DEBs I have done. And it's a very common, practice to see that these patients typically last longer. So these angioplasties, they don't come back. Now it also comes at a cost that we'll again discuss, but this is here we have used one balloon, and after that we have used another balloon, which is almost 2 to 3 times of cost of that. So cost is also a very important factor. But look at the result. This is again, there's a 3 minutes of long duration for the drug delivery, and you can see here. Now, if we are bothered about the very slight rupture, so even in this video, if you see these retained contrast areas, I will again play it. If you can see it, see at these margins. Okay, when the contrast passes, you can see some light retained contrast. So there could be very mild, bleeding, but typically this all stops because of the fibrosis that is happening surrounding to the vein. Okay, prolonged inflation is the key. Here again, you have a distal radial artery sheath. This is still also in the anastomotic area, then it's totally occluded vein. Okay, it's going up, and then this is the post-angioplasty result. This is again one more case where you can see there's a distal radial artery, excess gone through, and this is a post-angioplasty. So this scenario is a very easy one. I will say one of the, because your access is very clear. The problem comes where we make really distal, fistula. So right at snuff box or at very near to elbow, sometime where you cannot get a puncture point. Okay. Then either you have an option of puncturing radial artery at snuff box. Puncturing radial artery at snuff box problem is, here you will have to put a sheath size almost at around 6 French, and that artery cannot take 6 French sheath. If it takes, it lands up into hematoma. So in such scenarios, you may have to come from above, so retrograde. So just vein ko puncture karne ja rahe hain, ultrasound guided, you do a retrograde puncture, you come down the line into the vein and do angioplasty of the entire vein. The problem is you are doing angiogram against the flow. Sometimes doing angiogram becomes an issue. Now look at here. This was what we have been doing so far. Now here what is we are talking about? Ki retrograde venous access. So ye artery hai, and this is where we are going through. So excuse me. So one of the alternatives, जब ऐसे किसी complex lesion में when I'm working, so what I do when you want to have a continuous angiogram and you want to come from above, you can actually take a femoral puncture. You can take a wire all the way up into subclavian and park your catheter into brachial artery. Use that only for a angiographic method. So only angiogram करने के लिए उसको use करेंगे. Crossing, wire, angioplasty, that's everything is done via this approach. Okay, so that's one of the cheat point. Now coming to brachiocephalic angioplasty, these are again because you have a distal axis. It's easy to go. You can puncture radial artery and you can do angiogram, and then under guidance you can do angioplasty. Again, if you are mostly you are doing you prefer to take a high pressure balloon, but you never always go to high pressure balloon. Remember, when you are going to very high flow, you are causing more intimal trauma. So a lot of time it happens that yes, we do open Mustang across, but this just opened up at say 6 mm pressure. Then you don't want to crank it up to 15 or 18. You just maintain a pressure at 6 for long, and do angio, and if that's open, it's done. Okay, a lot of time this narrowing at the juxtaanasmotic swing point is also part of the scarring process that is happening outside vein. Okay, so it's very and that scarring will just need the little bit touch of a balloon, not a high pressure balloon. So remember, when you're doing angioplasty, not always crank it open to 15, 18 or 20. You always go slow, see what is happening and what is the result at the low pressure, and then you go it. Okay. Now size, like this is almost thread and this is almost 6-7 mm, but with experience, if you are using NY balloon, most of time you don't need to on the venous side, because this is a surgical site also, there will be surrounding fibrosis also. Even if it say ruptures, it will be contained rupture. So you can directly take a 5 or 6 mm balloon. You don't need to go for a 2, 3, 4. That will save a lot of cost. And with what confidence I'm showing you, look at this picture. On if you can see my arrow here, these tiny small things, there are slight little extravasation, but they will heal, not an issue. Okay, so this will save you one extra balloon. This is again, this is a fistula where you have a mid, interesting, this was a very hi-fi personality where a fistula was made, but then they were afraid that this cannot be used, and this was a documented open fistula which I have seen on a Doppler, but they did not use and kept on using permacath for almost a year, and then 1 year down the line fistula became like this despite no use. Okay. Now this is a typical way, I don't know if it, because we have seen it surgically also. This is probably site for some old puncture as well as the retained valve. So that can also lead to intimal hyperplasia, and this was the result of angioplasty. We did AV fistula, radiocephalic fistula, we did brachiocephalic fistula. Now it's a basilic vein angioplasty. Now, as we have done more and more, we have been doing more and more basilic vein transpositions. Now, for last couple of years, we have started getting interventions of our own patients with the basilic vein transposition. Now, basilic vein, you typically get two things. One is this dip, okay? There is a functional narrowing even if you cause a twist or if you not take an appropriate curve right from the day one, and that has to be immediate post-op, that should be surgically corrected. But these kind of swing point stenosis that happen almost a year or 2 years down the line, they respond very well to, if it's the only if this is there's no other lesion, if there's the only area, they respond very well to simple angioplasty even with a non-compliant balloon. Okay. However, like this patient also has an inflow, then the multiple areas. So this is the result of angioplasty. Now, early swing point stenosis responds to low pressure PTA. Look at the angiogram here. Okay. There's a good size vein. Not much of this thing, but you can see, the pressure, the swing point stenosis. And more than that, actually, if you can focus, see how vein is collapsing with the flow. See immediately distal to the flow here. Okay, vein is collapsing. So that is one of the feature. Anyways, that you actually get that clinically the thrill in area will decrease. So clinically, you want to look at the area which is the pulse and thrill junction. Now, this patient, I would expect pulse and thrill junction should be somewhere in axilla. Okay. Now, last part of the peripheral angioplasty comes as a AV graft angioplasty. Now, this is a typical picture, and we call this a 5 minutes angioplasty. Literally 5 minutes angioplasty, because you have a graft which you have a patient have been under a follow-up. And now patient comes back to you that, sir, my pressure graft venous pressures have been rising persistently, number one. And when they put a needle, now initially it used to say stop in 20-25 minutes time. Now the blood is taking almost 40-45 minutes of time to stop, or maybe even more. That's a indication you need to go for a angio, the check angio. And it's one simple passage of wire, you plasty it and you come back. Okay. But AV graft angioplasty sometime, is not always simple, because sometimes it's when you're really short of time, you thought you'll do it in 5 minutes, you do a plasty. By the way, this one addition which I'm sure a lot of you might know, but those who you don't know, this is called we can take a roadmap in DSA setting. If you have not been using, no matter how old your cath lab is, but still you check with the technician, there are possibilities of taking roadmap in most of even older generation cath labs as well. That helps you to give a carbon picture of the previous angiogram and say advance your wire on this. So you wanted to finish this off in 5 minutes. And when you do a completion angio, this all looks perfect. but then you'll end up with the central venous. So sometime in follow-up, it's also important to look for the central veins. I mean, not in follow-up, every patient, it's also important to look for central veins also. Especially when you immediately after doing angioplasty, still your graft pulse has not converted into thrill. Otherwise, sometimes it's very easy to miss. Now, somebody asked me about the putting a stent or not. Now look at this angioplasty. I'm doing this at 1240 Mustang balloon. This is a post-angioplasty picture. But again, now we have gone again with the over distension and keeping for very long, and see the picture. Okay. Now this is the difference. Yep. This looks very inadequate angioplasty. Simply, it was the pressures were low. Following that, we went on a pressure almost till 18. Kept it for high pressure with a prolonged angioplasty, almost for 3 to 5 minutes, and then this was the result. Okay, still narrow, but I think we'll take it. Now, talking about stents, so this was, now I forgot this, why and where this stent was put in, but this patient came to me who had an AV graft. Then beyond that, yes, okay, there's an AV graft, then the stent was placed into graft going into vein, and after that this lady has been coming to me, and what has happened, this is, you can see it's a valve site dilated, and just beyond, above that, she has developed this narrowing. Now this is into axilla. Every time, few weeks, a few months down the line, she comes back. She's a ECHS lady, so we can't get anything more but ox balloons for her. And every time she comes, I just balloon it, and that's it. Okay. ECHS, they don't understand. They don't give you approval for, at least I understand, for cutting balloons and all. So every single time she comes back, every 6 months or so, or sometime 9 months, she will thrombose of the graft also. So then we will thrombolize or surgically clean up. And again, this area we will do angioplasty and come back. This is a very typical lesion where you should be doing a cutting balloon or a scoring balloon to put a dent into the neointimal hyperplasia and surgical, and then open it up. Okay. This is again area where you don't want to be going very high pressure right in beginning, because this is the axilla. If this bleeds, then you'll have to stop the fistula, nothing else. You cannot do anything. Although with the repeated angioplasties, almost I think after for 5 or 6 angioplasties, now we go almost till around 28 pressure, but still opens to this much only. So coming to this balloon or that balloon, so we have high pressure balloons. The smaller the balloon, higher the pressure it can go. So for a 12 to 14 mm or 16 mm balloon, 14 to 18 mm Mg is really high pressure, because normal balloons will go around say 8 or 10 mm, not more than that. Boston Scientific comes with the Mustang balloon, and then rest two are the Conquest and Atlas are from the Bard. So Mustang and Conquest come up to 12 mm only. So anywhere you want to go above 12 is the Atlas. You can see this is a very robust balloon. This one is costed around 25,000, the Boston Scientific Mustang, and this one I think 27 or 30,000 around Conquest and Atlas. Then you have a Flexitone cutting balloon, which we were looking for the lesion like this. Okay, so they have actually very fine blades on tied, on external surface of the balloon. So you don't want to be using like this. So like this patient, this area I would want say like 10 mm balloon, but I don't want to be using a 10 mm cutting balloon for this. I want 5 or 6 mm of cutting balloon, so that should be able to divide the intima at multiple places, and then use a semi-compliant balloon, not a very high compliant balloon, the semi-compliant balloon to dilate the area. Then comes the third one, the drug-eluting balloon. So the concept is, as I said, to coat the freshly damaged neointima with the paclitaxel that decreases the process of neointimal hyperplasia. At the moment, apart from few more, two most common are the Lutonics, that is from the Bard, and Ranger, that is from the Boston Scientific. Lutonics come at the 035, the wire system. So it's a slightly more expensive, whereas Ranger comes on the 018, the 018 and 014, the finer wire system. So if you are planning to use a Ranger, I will advise to remember that right from beginning, the first wire you should open is the 018 wire itself. Otherwise, you will end up spending a bit more money on the wire. So I think this talk I would like to stop here itself, and focus more, take more things on the questions and discussion. So Dr. Mahendra, all to you.
Yeah, again, Himanshu, in the beginning you said you are fan. In fact, I am your fan. Once I listened a lot of things and learned a lot of things from you. So, thank you so much for such a nice presentation,
Dr. Ash, Dr. Mukhi, I'm just reading comments also. So Dr. Ashish, very, very valid point. Roadmaps, they give much more radiation. We should be very cautious. That was, I think, once in a blue moon. I was trying to record it for some the similar purpose, for demonstration purpose. Otherwise, I don't routinely. We do. It does help in a lot of complex lesions, although.
Hello.
Hello.
Doctor, good morning.
Oh, sorry. Sorry, I have received a call on my laptop actually. Haji. Sorry, I'm back.
Okay,
Himanshu, Dr. Kunal here.
Hi, Dr. Kunal.
Yeah, so that was a very interesting talk. Actually, a lot of times there is always a dilemma because a lot of patients, because of the affordability and all, the angioplasty is not possible. So suppose you do an angioplasty. So how do you follow up? How to follow up these patients, and how many time you do advise that patient should undergo angioplasty before a new fistula is considered? Because every time doing an angioplasty, the cost and all will be too much.
Agree. In fact, what I would like to share is, give me a second. I wanted to show something. Okay. So we can see this. Is my screen visible?
Yes, your screen.
So Dr. Kunal, first thing we should always remember that plasty is not the only solution. Okay. My approach to this is, first, if patient had a running fistula, you evaluate whether patient is going to really benefit, by doing angioplasty. If you have got a certain areas, open, and it's fistula was running till few days back, it's worthwhile giving the first angioplasty approach. But depending on the final outcome, if you land up using balloons and sometime maybe some thrombolysis, you would want to give fistula a rest for a few days and then reassess. Now, if you had a successful angioplasty and then patient is coming back to you, say 6 months or 9 months down the line, he has been a good patient, compliant patient, I won't mind doing angioplasty again, this time slightly go more aggressive, maybe in ballooning. Last time we did to 5 mm, now do to a 6 mm. Okay. Now, but if my last time, when I did and it re-thrombosed very soon, okay, that is a big time that I'm not going to touch that patient again for a fistula, this thing. Sometime on a clinical examination itself, you see radiocephalic fistula, which was there, now it's totally occluded. You don't want to touch. So the first thing which I decide whether I'll be doing an endovascular intervention this patient or not, if this fistula is running or not. If this fistula is running, it's the technical success rate of angioplasty in a running fistula is much better than a fistula which is totally occluded. Okay. Second is a recurrence. If patient is having time again within 3 to 6 months, patient is having recurrence again, then I would want whether to offer a drug-eluting angioplasty, or say it's a very focal, like in this patient. That's why I opened up a picture. This patient had a very focal stenosis. This is, I think, surgery done somewhere in Varanasi. And also I do routine patch plasties here also. So you should know there is a surgical patch. Now look at this area. We have to put in a new patch. This will last at least 5 times longer than the normal angioplasty. So you should have the armamentarium with you. You should have options. Not unnecessary pushing for patient for fistula every 3 to 4 months. No, that is a big no. Unless that's the only option you have left.
Actually, Dr. Himanshu, I would like to ask question. At all places, the angiography and angioplasty facility is not available, but dialysis facility is available even at the district level or tehsil levels. Probably Dr. Kural wanted to ask that in those situations, making another fistula, it will be a cost-effective effort as compared to going for angioplasty and maybe restenosis and recurrent angioplasties.
So my answer, so I'm also answering
what should be the take-home message in these situations?
Sir, in place of abandoning all of them, we should be able to pick and choose those who have only got this, say, very significant area of narrowing, say swing point stenosis only. You should be able to simply plug it, say if you have a fistula here, just simply plug it a bit above, or do a surgical patch plasty, rather than going for a basilic vein, for a brachiocephalic fistula, because that will again take time to mature and so many things. So if you don't have angiographic facilities available, at least develop a good practice of doing ultrasound, determining things on that, and then intervening surgically. Surgicals are the best. Surgical outcomes are the best.
Few of my patients patch plasty and they have really worked well, and I fully agree with this part.
We have done with we have done some really good patch plasty.
Yes, and they have worked well for many months. Maybe in few cases it is for a few years, you can say. So instead of going for recreation of every fistula, you can consider this part as well, if you have got a good surgical vascular surgery team with you, Dr. Kural.
Yeah, just a few points which I want to add on and mention. The first important thing is to correctly perform the fistulogram. It's very important before you decide that you want to go ahead with angioplasty. You must know to perform fistulogram correctly, because fistulogram, as Himanshu mentioned, that it is a circuit. So you have to assess arterial part, inflow part, the cannulation part and outflow part, central veins. So you have to do a complete study. Once you have done the angiogram, diagnostic angiogram, then you should sit back and study carefully whether this angiogram findings are correlating with the clinical findings. Unless they correlate very well with the clinical finding, you will not do the procedure of angioplasty. You will not gain anything. So it is important to learn how to do the angiogram in a fistula. many a times, suppose it's a low flow fistula is a radiocephalic fistula. So my practice is to cannulate the brachial artery and put a 4 French dilator, just dilator, not the sheath, and then through the three-way I push the dye, and then you can see the arterial as well as the venous part of the fistula, and as well as the central part of the central veins. So you have to plan how you would gain the maximum information in a particular situation by performing a diagnostic angiogram. And then comes the reading part, because it is again very important. As I said, clinical features should correlate with the fistula. You have a luxury of finding whether the patient is having inflow problem or outflow problem, whether the fistula is non-maturing or it is hyperpulsatile. So already you have some clinical diagnosis, and then you get an angiogram and then you study it. And the second point is to know when not to intervene, some of the absolute contraindications. So the absolute contraindication is just, you can, say one. It's just if there is an infection in the fistula, you will not do the procedure. So infection of vascular access is a contraindication. You have to leave it, treat the infection, and then think about intervening it. The other contraindication which I can think of, which is not an absolute one, but it is a relative one, is the new fistulas, less than 1 month old. You will not, intervene in those kind of situations, because less than 1 month old will be too fragile. And after that, once the angiogram is performed, then I think more than 50% of stenosis, if it is clinically correlating, should be the one where we should think of dilating it. If it is more than 50% and it is explaining your clinical findings. And then you have to decide whether you want to completely dilate, whether you will have to under-dilate the stenotic part, or you will have not to dilate at all, like asymptomatic central stenosis. You have not to intervene. So if you have a situation where there is a AV graft and there is a venous anastomosis stenosis, you would like to perfectly dilate that AV graft venous anastomosis stenosis. And in that situation, because most of the AV grafts are 6 millimeter, I think, and most of these venous stenosis will be perfectly dilated if you oversize the balloon, by say 1 millimeter or so. And many of the situations, like in the arterial stenosis, most of the time you get the perfect results, perfect dilation. But in the venous AV fistulas, you have to most of the time under-dilate them. Under-dilate because you cannot get the perfect result in most of the fistula angioplasties.
So, sir, I will slightly agree to disagree. Venous angioplasty, you over-dilate, but you accept the under-dilated result. That's the point.
So
that I'll give example. The most of the AV grafts are 4 to the tapered one are 4 mm at one end and 7 mm at the other end. And when you actually anastomose, you actually make it bigger, almost till a centimeter. So AV graft venous and anastomosis almost a centimeter. Okay. Now you're talking about 10 mm. Typically, we go to and when you go and inflate it, you want to reach at least that 8 mm. So you will not use 6. You will use 8 mm balloon. 6 will always leave. And second thing I said, these venous anastomosis are resilient, we call it. It is a very tough venous narrowing up, very tough. So they're like, you open them like this, they will look, we saw in so many angiograms, they just come, what you achieve with over dilatation is, sometimes you can actually break that intimal hyperplasia at segments so that your effective results become big. The adequacy, what you gain is, the most important is the loss of collaterals, and there should be no stasis. If you are having significant collaterals, which were there before and still after the, abhi to hai, thode se kam ho gaye hain, those better hai. If you are having a significant collaterals, that means still things need to be done. Okay, that will directly reflect into the outcomes of the procedure. And same time stasis also. So sometime, you may want to cut off the DSA and come back to Cine and do a long exposure, say 15 seconds, 20 seconds, do a run, see if the contrast is holding up at some point.
Yeah, another point, Himanshu was about the, prolonged balloon inflation. How much time do you keep the balloon inflated to?
For the drug-eluting balloon, normally it's 3 minutes. For even normal angioplasties also, roughly 1.5 to 2 minutes I do. But if it's a drug-eluting balloon, at least 3 minutes is mandatory. That comes in the IF.
Yeah. I think drug-eluting balloon I have used in only one of my patient where recurrent stenosis was a problem, and what I remember is that drug-eluting balloon, they are not used to dilate the stenosis. They are there to deliver the drug. So you have to pre-dilate. And then apply the balloon for delivery of drug.
Yeah.
But so if you inflate the balloon for say more than a minute, do you use heparin?
So for AV fistula angioplasty, yes, we always use heparin.
So what actually my practice is not to use heparin at all.
Mm-hmm.
So what I do the standard inflation till the disappearance of waste, and then immediately deflation. And I have not found anything, inferior results in terms of duration of balloon inflation. So although there is a trial, of prolonged balloon inflation versus the standard inflation, but apart from cosmetic results, you don't gain much, and you expose the patient of heparin, and then after removing the sheath, the hemostasis again will be a challenge if you are using heparin. So in almost all of my patients, I have not used heparin for angioplasty purposes.
Okay, that's anyway. I think that's a very different practice from the standard angiography practices at most of the centers, I will say, because radial artery punctures are a very routinely done, and even so, that's the best thing when you do radial artery puncture. Every cath lab nurse is trained to take care of a radial artery sheath. They have a specific bands, everything. But yeah, I agree. I think one of the other point is where this thing is turning to is patient assessment. Okay, you want to do an intervention. You want your patient to be dialyzed a day before, mandatory. You want patient to be able to lie down sometime. A simple angioplasty might take 45 minutes, 30 minutes. It may take 1.5 hours sometimes also. So you don't want patient to be becoming breathless, So that's one. Also reflects in patient's tendency to bleed. Okay, patient is uremic, patient will tend to bleed. Sir, one very interesting picture yesterday, couldn't get it. There was a patient I was planning to do. I was trying to do brachycephalic fistula angioplasty, and the point made by me only almost a couple of years back, and I forgot that this was a patient with a high bifurcation of brachial artery. Now, I typically always, if you choose between radial artery and ulnar artery at that area, your ulnar artery is always slightly bigger. So technical success rates are slightly more when you create an ulnar to cephalic vein fistula. So a patient came back to me. I didn't look at the notes also in detail, and my technician, this is brachycephalic fistula, was angioplasty karna, and I had punctured the radial artery. Now, radial artery puncture mein I took an angiogram, and in first go, I actually didn't look that, okay, this is the bifurcation. And then I'm trying to pass my wire, but wire is not going. What was happening is wire was going above the bifurcation. So, and my fistula was from the ulnar artery. Then in that case, I had to go back and, puncture the ulnar artery and come and do a angioplasty from that area. So sometime you be prepared for the surprises, sometime your own, sometime of the others. I think there are some questions on the chat box also. I think it was about the cutting balloons we did mention. So take a rubber band, okay, and you're trying to inflate rubber band time and again. What you want to do with the cutting balloon is actually cut the rubber band at 6 pieces, and then you try to open it. So that's the concept of cutting balloon, that you put a sharp incision to your intima, and then you open it with a lesser pressure balloon. Usse you will land up causing, less damage to intima. And sometimes the picture I showed, certain of the lesions which you can't even dilate with very high pressure balloon, those can also be treated. More described in the peripheral, lesser described in the central lesions. Peripheral maybe it's not. So if you look at the balloons, they come very short length. So jo flextome hota hai is only 2 centimeter long. Okay, so they are not for very long. So out of the entire area, entire segment, you will have to choose which is the segment where you want to use a cutting balloon. In case of tandem stenosis, it would be very difficult to assess the significance of central stenosis or peripheral one in isolation, and then should not leave anyone when doing a so it's actually dictum when you do a peripheral angioplasty, you should always finish up with a central venous check angio, so that you're not leaving us at least central venous behind. And Dr. Manjeet Pal Singh, so any other role of intranasal desmopression to reduce chances of insertion site bleed and prevent uremic bleeding complication? Sir, a question to you. Is there any role of intranasal desmopression to reduce chances of insertion site bleeds and prevent uremic bleeding complications apart from hemodialysis? मैं medical वाला बंदा नहीं हूँ,
Yeah, I presume the question is whether desmopressin can help reducing bleeding or achieving hemostasis better in this kind of situation procedures. See, we have not encountered that situation where desmopressin is being employed, because desmopressin, yes, it has got its role in uremic bleeding control. That is a different situation. But in procedural part, in practice, we have not used desmopressin. Most of the time, because fistula is visible, we press the cannulation site for 10 minutes manually and achieve the hemostasis without any problem. And if the sheath is too large, most of the time I get away with 7 French sheath, but if it is too large, then we can use the purse string sutures to achieve the hemostasis. In fact, I can tell you my own cannulation technique, that I do not puncture the fistula vein directly over the vein itself. I just get a small tunnel. I enter the vein by the side of the fistula vein, under the skin. Subcutaneous tunnel is created while I cannulate the fistula, so that I get some space to achieve the hemostasis by manual compression and directly not compressing the AV fistula. So coming back to this question that desmopressins use in AV fistula cannulation hemostasis, I think as I have not used, I feel in this kind of situation, procedural part, it seems
into the vein, because that gives you a very good nice flap over the puncture point. So that is something is a lesson for me for from today's conference. So I'll use it. Next time I use it, I'll mention about you. Puncture of a fistula where anyways inflow is and you want to puncture a fistula retrograde, it's a very important point. You can put in a tourniquet and make them engorged. Dr. Compression hemostasis. Sir, first thing, closure devices are not meant for, I mean, there has been not description, but first thing, it is a very, it's overkill. A closure device costs around 16,000 rupees. As Dr. Mukhya said, most of the time it's just a compression or maximum a simple, one stitch, that's it. Because this vein is right next to your skin. So you can get away with it. Radial artery anyways is not meant for a device closure technique. Femoral artery, yes, but none of the other. AV graft, again, if needed, a simple purse string suture or simple suture will do. Okay. Arterial site puncture, no, not for a radial artery. Femoral, it's a luxury. Mil jaya to bahut badhiya.
Yeah, another actually point as we were discussing about the achieving hemostasis and cannulation by the side of creating the subcutaneous tunnel, you have to use 2-finger technique to manually compress to achieve the hemostasis. One at the puncture site, another at the arteriotomy or venotomy site. And I make it a point that I stand for 10 minutes. The timer is on the screen, and then we continue to press it for 10 minutes to achieve the hemostasis before we ask the nursing staff to dress the cannulation site or the procedure part of the fistula. So it's very important, because many a times, as we have witnessed as a nephrologist, when patients who undergo coronary angiographies, they come up with a lot of complications, post coronary angiographic complications of femoral hematoma. Because cardiologists are just leaving the hemostasis achieving part to the nursing staff, and they are unable to spend enough time to hemostasis. So I think completing the procedure properly is also an important part of endovascular procedures.
So this reminded me one of the case which happened recently, that you have to ensure that your nurse so sometime your fistula is suppose created here, and you land up, you're putting your puncture point here. So this is really near. So if you have not told nurse properly, वो जो pressure bandage लगाते हैं, that will land up pressing your anastomosis itself. So, compression is very important, and it should be done yourself. You should not leave it, as long as unless you develop an assistant who knows what you exactly want. Dr. Ashish is saying that radial closures are available. Yeah, I agree. Actually, there are a couple of closure devices are available. I personally have only believed and regularly seen results of ProGlide, which is a suture-based closure device. That's only available for the arteries which are 5 or 6 mm and bigger. For smaller arteries, there are plug kind of different closure devices available. I don't have any experience of using that. Maybe you can use that, but compression works in most of time.
So I think we can move on to the another topic of today's conference. If there are no further questions.
Dr. Mahendra, I think this is where we take a bit of break. after this, I'm actually excited. I'll be talking to my mentor after a long time. So I'll just give a brief about him, and then we'll, meet him. So Dr. Ramesh Tripathi is the vascular surgeon who have trained me. He has been trained. He himself is a trained in US. He was in a consultant vascular surgeon in UK. Came back to India in 1998. He has performed one of the first. Not one of the first endovascular aneurysm repair of India, tibial angioplasties in India, before he left to New Zealand and Australia for around 7 years. When I was getting trained, he was in India for around 4 years, 5 years, between 2011 to 2015 as a director of Narayan Hridayalaya Hospital. I know him. I know him so well that he's like. Every single place he's like a guardian to me, and in the entire vascular world, he has been inspiration for us. He has extensive name in venous world as well. He has a Tripathi trapdoor technique of deep vein valve repair, as well as I was lucky to be part of rival technique, which is another technique of deep vein iliac veins. So presently he's the visiting professor in Stanford. He's a distinguished fellow of multiple societies across the world, and he is presently in Queensland doing academic as well as the individual practice. So I requested him, I think 6-7 years back, I brought him to BHU to give one of the lectures in PG series of the MS General Surgeons. And today I'm looking up to his talk, and it is basically about the natural course of AV fistula and factors affecting it. So he just messaged me that I think he should be there on time. So we'll at this moment, Dr. Mahen, I think he's not there. Dr. Mahen? So we should take a break, and hopefully we should, I think, let's schedule. We are running on time, or we are running a bit late?
I think 15 minutes
we are running. Okay, so we were supposed to finish 12. We are 15 minutes late. We should reassemble at around 1:30. We should start putting maybe messages across for the reminder to assemble 1:30, and then we should start with that lecture and take the conference further.
Sure. Thank you.
Okay. Thank you, sir. Thank you, everybody.
Thank you.
Hello. Test. Test. Hello.
Grammarly can help you write quickly and confidently, so you
Rishabh?
Yes, sir. Tell me.
डॉक्टर त्रिपाठी को मैंने बोला है तो ही इज जस्ट जॉइनिंग इन आई थिंक 5-10 मिनट्स
ठीक है सर, अभी
एक बार
तो
देख लेना जैसे
सर 1:30 पे ज्वाइन करना है ना?
एक बार मैंने टेस्ट रन के लिए बोला था उनको बस
अच्छा ठीक है, तो सर टेस्ट रन कर लीजिए, कोई दिक्कत नहीं सर, सिस्टम ऑन है
ना?
हाँ
ठीक
सर,
है।
अभी हम लोग लंच कर रहे हैं तो कनेक्ट होता हूँ मैं।
कर लो
Okay.
मैंने बस उनको बोल रहा हूँ कि अगर वो
ठीक, आप सर बताएगा तो म्यूजिक बंद कर देंगे अभी हम, ठीक है?
ठीक है
ओके।
Hi sir, I think you are still muted.
Yeah, hi.
Okay, yeah, we can see you.
Can you hear me?
Yeah, I can hear you. Can you share your Rishabh?
Yes sir, tell me.
Sir, can you put your slide? Yep.
Yes sir, we can see the screen.
Okay, just one second. How do you put the, okay.
Go on your Zoom on the side bottom bar.
Now sir, we can see your desktop, you can open the present, yeah. Now you can do the full screen. Yeah, perfect.
You got it?
But sir, it's not in the full screen right now, you have to press
Yeah. I'll press play.
yeah, now it's okay sir.
All good?
Yeah, all good sir, your audio and video is both are good. So you can hear me as well, na?
I can hear you well.
Okay,
Yeah.
thank you.
ठीक है sir. Half 20 minutes में I'll ping you up.
No worries. See you
Okay.
soon. I will also go and change into a shirt.
Okay sir.
Okay, bye.
Expose the vein and the artery through a 6-centimeter skin incision. Dissect out the brachial artery and cephalic vein. Ensure that there is no stretching or kinking of the vein. Use suture to close off side branches. Do not use metal clips. Use the laminate model selection tool to gauge the artery external diameter. Attempt to place the start notch of the model selection tool over the artery. The VasQ model is selected according to the model number written next to the smallest indentation that accommodates the artery. When in doubt, choose the larger model. Thread the VasQ device up the vein by holding the brace so as to leave the anastomosis suturing area conveniently free and clear. Cut the cephalic vein in preparation for an end-to-side anastomosis. Trim the vein at an approximate angle of 50 degrees. Perform an arteriotomy in the brachial artery of 5 to 7 millimeters and anastomose the cephalic vein to the artery in your routine manner. The area of anastomosis has to be free of fatty tissue. Slide the VasQ along the vein onto the anastomosis. Use a suture to knot 2 eyelets of the device brace and suture it around the artery. Close the surgical incision in a routine fashion.
Dr. Roy, hi, how are you?
Yeah, I'm fine. Nice seeing you, and you're welcome.
Thank
Mr.
you very
Tripathi.
much.
Yes,
Thank you for your invitation.
yes. Welcome. We are delighted to have you in our conference. And Dr. Himanshu just briefed about your help to him, and you are really a fantastic vascular surgeon. And
That's
we
very
heard
kind.
from him, and we are delighted to have you with us today.
So,
It's my pleasure.
So Himanshu, am I audible this time?
yeah, it's a bit loud, although.
Okay. Okay, I'm reducing my volume.
Yes, yes.
So, sir, I'm bringing you back to Banaras a second time.
Oh, thank you very much. The first time was a great experience as well.
Yeah, it was great, except I remember we really choked up your asthma. I remember.
It was a cold January, I remember.
Yeah, I think it was one of the master's PG program done by Dr. Puneet at BHU.
Correct.
Yeah. How is weather over there in Australia right now? It's really cold up here.
So it's summer here. It's around 34 degrees, 32 to 34 in the daytime.
Just
And
contrast to what the temperature what we have here in North India.
Yeah, it's mild summer, and in the night it goes up to about anywhere between 15 and 19 degrees.
Any new COVID curbs?
Very little. We don't have any curbs. Travel from Queensland to other states has opened up, and now everybody is of the opinion that the corona virus latest strain, the Omicron, is a milder variety, and sooner or later everybody is going to get it. So
Exactly.
sensible precautions and vaccination is the key. So I had my booster shot yesterday, and now they've started vaccinating between 5 and 12-year-olds here. So it's all good. I mean, schools will reopen after the vaccinations, and I think life will get back to normal very soon. I hope, unless there is
Let us hope for the best.
another strain or something,
I wonder, I was due for my booster shot, but last week I got COVID. Today is day 7. So I don't know when I'm supposed to get my booster shot. I don't know.
After a month or so, Himanshu.
After 4 to 6 weeks, you can.
Yeah, after a month or so. That is going to be ideal time.
Yes.
Okay. Sir, finally we can see you, Sinha sir.
You already have got a natural booster,
Yeah, that's true.
We can see Dr. Sampath. Welcome, Dr. Sampath.
Yes.
And Dr. Raja Ramchandran, you are also most welcome in our Welcome.
Hey, Raja boss.
Hi, Manshu.
So there's a lot of okay. I think I'm going to moderate this session because
Yes, sure. You are going to moderate this session, but before I would like to say something. Am I audible?
Yes, you are fully audible.
Tripathi sir, Himanshu is working with me for last around 6.5 years, right from the day when he returned from USA. And after every work and everything that surprises us, he always used to say, I learned it from Tripathi sir. And after doing the first chapter of WIN, we developed so much gratitude for you. I asked him, man, just show him me how Dr. Tripathi sir looks like. If somebody can mentor some student into this form, definitely he has some distinguished powers and capacities. So we are very thankful to you, sir. Your student is doing a lot of good for here in Varanasi as well as there in Delhi. And apart from that, he is able to influence other surgeons to do the right thing and to improve themselves. So we have a very high regard for you, sir. Over to Himanshu. Now you will moderate this session.
Thank you so much, Dr. Raja. I think that a lot of credit should go to Himanshu because, you know, I can pour as much nectar into anybody's hands, but they have to drink it.
Yes, that's right.
So I think that a lot of credit goes to him. And we always emphasized on doing the right thing in the right way, getting it right the first time. And so, yeah, it's been a pleasure. And a lot of fellows who trained under me, I hope and think that they have carried the same ethos forward. And it's all to do with patient care and improvement of vascular services in India, where we require it really badly. So, you know, thank you for your kind words.
So I think I'll start with one, very common instruction, or I'll say teaching that used to come from Sir, which I heard from him. And then when I reached to Mayo and I was talking to Dr. Glowinski, same thing come from the both top ends, that a lot of time it's a clinical scenario and you're stuck with the decision making. And how will you do it? How will you decide whether to plasty or to not, whether to do surgery or to wait? A simple solution. You think about if it's your father, mother, in that scenario, and what you're going to do. So same thing every single time Dr. Tripathi used to tell me, and same still stands for me today. So friends, I welcome Professor Ramesh Tripathi. He's my mentor, but this is full, this was a cartoon which was made by, I think, Venus News a couple of years back. And I really love it. I don't know how many people have shown this and total summed up CV into a tiny little picture. So Professor Tripathi is currently a consultant vascular and endovascular surgeon in the Sunshine Coast and White Bay areas, and an honorary associate professor, Faculty of Medicine, School of Biomedical Sciences, University of Queensland, Australia. He is a distinguished fellow of Society of Vascular Surgery, USA. He is a distinguished fellow of American Venous Forum and an honorary member of European Venous Forum. He is also 2017 recipients of Asterios Castamores Lecture by European Society of Cardiovascular Surgery. He was introduced into Sigma Xi Honors Research Society in 2017. He serves as the advisory board of College of Phlebology, UK. Professor Tripathi is a surgeon scientist by training, and his clinical research and publication involve open surgical and endovascular solutions to aortic, visceral, peripheral arterial, and venous diseases. He performed India's first endovascular aneurysm repair and subsequently thoracic endovascular aneurysm repair in 1997 and 8. His team also performed the first talent to accelerant EVAR in Australia and New Zealand in 2005. Dr. Tripathi is an associate editor of Journal of Endovascular Therapy, a distinguished reviewer for Journal of Vascular Surgery. Now he is also an editor in that, EJVES, JVIR, and a guest editor for seminars in vascular surgery. He serves on editorial board of Journal of Vascular Surgery, Journal of Cardiovascular Surgery, Vascular, Phlebology, Aorta, Asian Journal of Surgery, Endovascular Today, and Vascular Disease Management. More than that, this was just some of the point from his CV to read. I must say that I've seen his CV in print, and it's a textbook. And one thing I have learned, from many others, and I think we'll keep on learning from him, that age is no bar. And if you want to learn, you should always, at every single stage, keep on looking what you want, and then strategically keep on making a plan and then implement it. Sir, I also want, apart from this, actually, I wanted to introduce you to Dr. Mahendra, because he's also another lifeline in my life when it comes to personal as well as the professional practice. Dr. Aman Singh was my senior in Varanasi in BHU. We had our personal touch since beginning. And the day I came back, the reason I stayed back in India, the reason the things I enjoy doing in India, including academic work, is because of him. So today, thanks for giving your time, and I would like to welcome our chairpersons as well for today. Uh, which, yeah, Dr. Raja.
Yes, Himanshu, go on.
Dr. Raja Ramchandran, he's associate professor at Department of Nephrology, PGIMR, Chandigarh. He's I mean one of very close senior from BHU. Our connection goes back to the days of library when he used to prepare for his super specialty, and we were preparing for PG. He has extensive in academic interest and has been doing excellent work in nephrology in India for very long. Next, we have Dr. Jayant Kumar Hota. He is presently working as a senior consultant nephrologist in Indraprasth Apollo Hospital, Sarita Vihar, New Delhi. I may think, since Dr. Tripathi have worked in Apollo for a year in 2009-10, I don't know if you came across with him, but you might know each other. Dr. Hota has many honors and distinctions in MBBS and was a university topper. He has published many international and national papers. He is actively involved in DNB teaching program as well. Welcome, Dr. Jayant. And then we have Dr. Ajay Pal Singh, who is a consultant nephrologist at Apex Hospital, Jaipur. He has done MD from SMS Medical College and DM Nephrology from SMS Medical College as well. He has been involved in a teaching experience, and presently he has been consultant in nephrology department at Manipal Hospital, Jaipur as well. Thanks a lot.
Our next chairperson. Yes.
So how can we forget the senior most person in in today's meeting? Today we have Dr. P.K. Rai sir. He has been one of the pioneers of nephrology in Varanasi, and I think he has seen I'll say this way, a lot of water has gone through the Ganges since he has been seeing the practices of nephrology evolving in Varanasi as well as in India. Wayne has been happening through his constant support. At this age, he has been actively right from Wayne 1. He has been very actively involved, and his support and blessings have always been there. Thank you, Dr. P.K. Rai sir. Thanks for joining. So, alt screen over to you, Dr. Tripathi. Please, you can share your screen.
Thank you, Himanshu, and also Dr. Rai, Dr. Hoda, and Dr. Ramachandran for a warm welcome today. I'm going to talk about natural course of AV fistulas and the factors that affect it. As you know, I'm in University of Queensland in Brisbane in Australia, and this is my Twitter handle, RK2 Vascular.
We can't see
I hope some of you are on Twitter, and you can follow me, in future as to what all I'm doing in terms of vascular work in Australia.
Your screen is not shared, sir, yet.
No?
No.
Just give me a second. Let me see what's going on there. Now?
No, not yet. Yep.
Visible now, sir.
You go? Okay. Yeah. So, as I was saying, in the bottom of the screen is my Twitter handle, and you can follow me to see what vascular work I'm doing and the new research that we are doing in Brisbane. So going over to the main topic on AV fistulas, you know the historical aspects of AV fistula, starting in 1960 with the pursuit of a proper dialysis access for end-stage renal failure patients. And the first one to be devised was a Scribner shunt And it was there almost until the late 1970s and early 80s. And I remember as a resident in Jipma, Pondicherry, I used to see these things sticking out of patients' hand, like plastic tubes, and wonder what they are about, until one day I was told that these are implanted inside the artery, the radial artery and a vein, and then you're able to do a dialysis through that. So further to that, the development of the Quinton, tubes with, the prongs for the arterial end and the venous end. And then obviously in the mid 60s, you had Simino and Brescia describing the radiocephalic AV anastomosis. And what they described was a side-to-side anastomosis, which a lot of, vascular surgeons and nephrologists continue to do that even till today. Then the newer techniques developed in terms of an end-to-side fistula, radiocephalic, and then when the cephalic veins in the forearm are not good, then the brachiocephalic in the antecubital fossa. And then came, various techniques to deal with the failures, including, doing maturation of the vein with ballooning, and further to that, techniques to treat dialysis-associated steal syndromes, and also, basilic transposition in the arm. So the history of AV fistula has undergone a huge change, and change is happening even as we speak today in the discovery of newer techniques that will take care of some of the risks of AV fistula, and the reasons why failure occurs in AV fistula, and to treat them, we have further new techniques. But then, at the crux of all this is a dream team of a vascular surgeon, a nephrologist, and a good dialysis technician. And also, I would like to add, in most modern situations, a nurse educator, and also a good ultrasonographer who can follow up the patients and give you exact data on flows and velocities, and also be able to scan central veins. So basically, the premise is that, if we preserve the upper limb with better veins, then we can create good fistulas, and we can get started around 4 months prior to hemodialysis initiation, because the maturation of vein in an AV fistula takes around 6 to 8 weeks. I'm very, unhappy when people are not able to wait. I would rather wait 8 to 10 weeks rather than 6 to 8 weeks, because when you try and cannulate earlier, then the issues with AV fistulas also begin earlier, and they begin much before the vein is fully matured. And then you need to develop a good buttonhole technique, both arterial and venous, and be able to utilize them on a regular basis. Mind you that eventually the buttonholes will have to be rotated, and the buttonholes may themselves become aneurysmal if you use it too many times. And then you have the 3-monthly clinical evaluation, including a good and ultrasound-based follow-up, and then following up for any failures. And, if there are problems of stenosis, then we do angioplasty and stenting in some cases, or maintaining them with drug-eluting balloons to prevent delayed stenosis because of neointimal hyperplasia. And the eventual goal is that you continue dialysis until the patient is able to find a suitable donor for a kidney transplant, and following which fistula can close spontaneously in 3 years, or it can have a revision done by the vascular surgeon. But everything is not so straightforward. You would want in a real world to go from A to B, and that's your expectation. But the reality is that you have to meander around until you reach to the point B. But I think that this is a beautiful slide, because our ultimate goal should be to bring reality as close to expectation as possible. And then only we will be providing our patients a better care, care without much, anticipated complications on the way, because half the job in this jumbled graph work is basically treating the complications. So in terms of natural course of AV fistula, we know that AV fistula has to mature. If it doesn't mature, there is a AV failure. And we know from our practice that the failure rates can be as high as 30 to 40% in some cases. There is the early failure, which may be related to surgery, thrombogenicity, and also, patient, what do you call, characteristics of their arteries, and central vein problems, which have not been, uncovered at the time of AV fistula creation. And this is where patient selection and proper, preoperative evaluation is of great importance. And then there is the failure to mature. Some veins are already sclerosed. They have been used for IV lines, etc. in the past. And also some of them have lost their elasticity due to increased matrix metalloproteinases in their smooth muscle wall. The smooth muscle wall is, as it is, very, scanty. And then, if there is already a digestion and, collagen layering in the walls, then they fail to dilate as well as you want to. And then you have the late failure of a mature fistula. And again, there are myriad reasons why fistula can fail at a later, date. And some of the issues could be in terms of neointimal hyperplasia, stenosis in the vein, venous side, stenosis in the arterial side, and these need to be managed in the long term. In patients who have got grafts, etc., then the stenosis may give rise to thrombosis, and that has to be managed as well. We do need to have strategies to promote AV fistula maturation and salvage failing or failed AV fistula or graft. And these strategies are paramount. If we are able to look at all of our strategies in terms of pre, intra-op, and post-operative care of these patients, then our reality can come as close to expectation. Central venous drainage is often a missed area, and I think every attempt should be made to look at it prior to AV fistula. And a good, duplex scanning is very important. Respiratory physicity in the central veins, and so those ultrasound, parameters have to be looked at. And when in doubt, a venogram is of great value for these patients because you can create AV fistula and then having to deal with severe edema in the arm and not being able to use the fistula or get the fistula matured in time. These are serious issues. So if you look at AV fistula maturation, a lot of maturation again depends upon what's happening in the wall of the vein, and there have been many studies done where it has been shown that it's related to VGEF release, it is related to matrix metalloproteinases, etc. And also in terms of inflow, we need to have vasomimetic action of the blood flow. And a nicely constructed end-to-side fistula with lesser shear areas and a good angle created between the artery and the vein. And this is something I used to teach the fellows, that the crux of the issue is looking at your arteriovenous fistula and creating them in a most physiological way to prevent future complications. So the maturation is an adaptive process. It involves remodeling, both by increase in its cross-section and also increase in the smooth muscles and the venous endothelium as well as adventitia. And this, to a large extent, is related to, matrix metalloproteins. If you have an increased release of proteases, then these proteins do not get layered in the walls and they do not respond to the dilatation, or they do not respond with dilatation. So, as I said, both ECM deposition and cell proliferation migration occurs at the wall level. So if you have a failure to mature, there is no wall thickening and no outward remodeling, then the AV fistula cannot be used. But even if you have a successful AV maturation with the wall thickening and outward remodeling, there still could be an access failure if at a later stage there is a lot of neointimal hyperplasia, especially at the anastomosis and swing points. And this itself in the long term will cause a narrowed lumen and maybe amenable to dilatation at a later stage. Again, flows and shear stresses. The flows increase and then plateau out. The shear stress increases in the first few weeks. That is around up to 18 weeks, and then the stresses start to come down. If you look at the mean fistula vein diameter and the fistula blood flow rates, you can see that if you compare, as the time goes from the AV fistula creation, the forearm veins, they dilate quite effectively to about 6 millimeter in diameter and above. But majority of the veins still stay between 5 and 6. But if there is a vein which attains a 5 to 6 millimeter diameter, say by 8 weeks, I would consider them pretty good to be able to be used. And if you look at this diagram here, it almost parallels the diagram on the left-hand side, whereby the higher the diameter, higher the blood flows. And that is what we need to achieve. We need to achieve maximal dilatation of the, of the AV fistula venous side, so that the flow rates are also, adequate enough to be used for dialysis. So what are the other mechanisms of failure? Early thrombosis is one, and that's a really bad outcome. It may relate to poor vein quality, poor surgical technique. Poor patient selection is the paramount thing, which is kind of like an umbrella factor, because it all relates to vein quality, hypercoagulable state, persistent hypotension. So all these are, you have not selected the patient properly in terms of a poor protoplasm, a poor vein artery, and you do a bad AV fistula, then this is all, relatable. Continued smoking in end-stage renal failure patients. I found rather rare patient who continues to smoke, because the AV fistula dialysis patient is a really very, resigned patient, and he wants to do things which will preserve his life. And so, but if a person continues to smoke, then obviously he's a sitting duck for, thrombosis, both arterial and venous, especially in areas where there are, stenosis. Magnesium levels, they have a negative impact on AV maturation, and that needs to be looked at by the nephrologist prior to referring patients for AV fistula. And mind you, most elective fistulas are well ahead of time. So I think that in many ways, persistent hypertension, hypomagnesemia, all these need to be looked at, smoking cessation, and also thrombophilia and coagulation abnormalities, which basically is hypercoagulable states. These need to be looked at, especially, patients who need anticoagulation. And choice of anticoagulation is a serious issue in patients with renal failure, because use of anything, has to be titrated with creatinine clearances and suitable, medications, which patients in end-stage renal failure can take easily. They are not so easily reversed if a patient comes in with thrombosis and needs some procedure done. And I think I've alluded to this while I was talking about the anastomoses and anastomotic angles. And it's the areas of low shear that have to be avoided and or prevented by good anastomotic technique. And also there are now techniques which allow you to reduce the amount of shear stress and turbulence in that area. So we know what all, areas stresses can be there and strain can be there in the arterial wall. And these are nicely mapped by some of the, computational flow analyses. And then you can look at it as to what has gone wrong and hopefully correct those. AV fistula anastomotic angle, 30 to 50 degrees is optimum to minimize neointimal hyperplasia in the long term. And this is something which we need to be cognizant of. So there is a new technique that is called the VASC procedure, and this essentially can limit the amount of shear stresses patient is undergoing and prevent neointimal hyperplasia. And this is external advice, and have a look.
Expose the vein and the artery through a 6-centimeter skin incision. Dissect out the brachial artery and cephalic vein. Ensure that there is no stretching or kinking of the vein. Use suture to close off side branches. Do not use metal clips. Use the laminate model selection tool to gauge the artery external diameter. Attempt to place the start notch of the model selection tool over the artery. The VasQ model is selected according to the model number written next to the smallest indentation that accommodates the artery. When in doubt, choose the larger model. Thread the VasQ device up the vein by holding the brace so as to leave the anastomosis suturing area conveniently free and clear. Cut the cephalic vein in preparation for an end-to-side anastomosis. Trim the vein at an approximate angle of 50 degrees. Perform an arteriotomy in the brachial artery of 5 to 7 millimeters and anastomose the cephalic vein to the artery in a routine manner. The area of anastomosis has to be free of fatty tissue. Slide the VasQ along the vein onto the anastomosis. Use a suture to knot 2 eyelets of the device brace and suture it around the artery.
So the computational flow modeling with this device has shown that it can
Close the
reduce,
surgical incision in a routine fashion.
it has shown that this device can prevent neointimal hyperplasia in the long term. But the data of its efficacy is still lacking in major studies. So we are still awaiting, it's physiologically and theoretically a really great device, but how effective it is, it's still, being studied and investigated. So if you look at the preoperative arterial and venous characteristics, we got to look at the diameter, we got to look at calcification, and we got loads of Monkberg's calcification and calciphylaxis in end-stage renal failure. And we need to look at anatomical variation. Early origin of radial artery is often a very beneficial. And we also need to look at radial artery absence or, various variations of ulnar artery in the arm, making sure that the Allen's test shows a patent Palmer arch to prevent any ischemia in the long term. Also, you need to look at because these patients have got so much of peripheral arterial disease, we need to make sure that the inflow is good and there are no stenosis in the path. Adaptive arterial dilatation is an important event to accommodate increased flow, and that occurs in AV fistulas. We know it. But the calcification, which is circumferential in diabetics and in end-stage failure patients, it inhibits that dilatation. When we look at the vein, again, we look at the diameter, we look at pre-existing areas of thrombus and sclerosis, and this thrombus is no longer thrombus, it's layered collagen type 2. And so it basically is an area of stenosis or obstruction. We need to look at distensibility. Vast amounts of wall sclerosis limit the distensibility of veins, and therefore, they are really not usable. Anatomical variations are several in the venous side and much more pertinent than on the arterial side. And these variations may give you a very good short cephalic vein at the wrist or at the snuff box, and then these peter out into various branches. And so we need to know where we are. if you're going to put an AV fistula, is it going anywhere? And the ideal thing which I teach my students is that you need to form, if you are going to rechannelize your river, then make sure it's going into the ocean. Otherwise, if it's just petering out, then again, you can't use it as a AV fistula. Or you'll have to do another, procedure where you'll have to take it off from the most, distal end of the most patent area in the vein, and then put another, a vein graft or something to keep it going. And obviously, older the patient would not get a renal transplant, and therefore the AV fistula is so much more important in the older patient. And these patients have got lots of issues with their, various endothelial growth factor development and release, and therefore their AV fistulas are poorly matured as well. Advanced age patients have got more matrix metalloproteinases and other inflammatory markers like interleukin-6 and tumor necrosis factor alpha, and these also lead to damage of the endothelium in distal AVF and poor maturation. These patients may have persistent hypertension because of, their heart condition, and if the reservoir is not great, then the AV fistulas are not great either. The other issue is that a distal AV fistula in heart failure patients can often tip them into severe heart failure, and therefore you need to carefully evaluate these patients. And I said before that end-stage renal failure is associated with increased levels of inflammation and oxidative stress, and I alluded to various inflammatory markers like interleukin-6 and tumor necrosis factor alpha. We also have increased, ICAMs and LCAMs and VCAMs, and therefore, there is tremendous amount of stress on the endothelium and also on the wall of the veins. And these induce fibrosis and also vascular calcification. So what role does surgeon have to play in terms of creating AV fistula? Any surgery is a surgical trauma. So, you need to make sure that your surgery is minimally associated with any major triggering of inflammatory markers, which are already going to be done by your fistula creation. So all these things can happen: loss of vasa vasorum, infiltration by macrophage and lymphocytes, especially your B lymphocytes. And then migration and proliferation of inflammatory cells, and ultimately NIH, neointimal hyperplasia. And I've alluded to all the inflammatory cells that can cause them. In terms of surgical trauma, one has to be very careful in creating a clean operation, an operation where there is minimal trauma to the blood vessels, and one has to really pay attention to the kind of stitching, to the kind of clamps, and to the kind of handling of these blood vessels. And only then you can be a really good surgeon to do all these AV fistulas. Often in the medical colleges and in the vascular training programs, the AV fistula is often relegated to the junior most, fellow. And the reason is not that the fellow is, it is an operation which anybody can do, and any amount of trauma, the AV fistulas will withstand it. But it's because this is where you learn your art of doing arterial anastomosis, arterial and venous anastomosis. And if you are able to learn to do it really well, then you can go on to do any kind of major critical surgery. So although vascular surgeons and trained AV fistula surgeons, mainly the transplant surgeons, have got an advantage, but nowadays, with the development of endovascular techniques, then there are others with the skills like interventional radiology, nephrology, interventional nephrology. They're all going to catch up in time and learn newer techniques that will allow them to minimize the surgical trauma, as much as possible. So that's what we are looking at in when we look at the future AV interventions. If you look at currently, if there is a problem, the surgeon is called, he opens the blood vessels. If there is a stenosis, he puts a patch. If there is a thrombus, he does a thrombectomy. He looks at the and does an on-table angiogram or fistulogram, and then finds where the problem is, and then goes and does an angioplasty at the moment. But then there are other techniques as well. In the initial phase, you can do what is called balloon assisting maturation. And, this has been shown to promote some remodeling and also maturation, because it can release certain, markers which promote maturation. But on the other hand, the downside is that if it's not done properly and not done not done over aggressively, if it is done over aggressively, then there is likelihood of, intimal and medial injury, which can lead to recurrent stenosis or vessel rupture. If there is a recurrent stenosis, cutting balloon can be used. And this is my go-to now for all recurrent stenosis. And I combine cutting balloon angioplasty with a drug-coated balloon. And this works really well with recurrent stenosis. Repeated stenosis, you can dilate, you can put a stent, but mind you that stents alone are not the answer, because they promote neointimal hyperplasia themselves, and that's the reason why now we have, drug-coated stents, and there is some, evidence to show that some elastase therapy can work. I have never used it. There are some people who use it as a topical solution on the AV anastomosis, etc. There are, foams and gels which contain these, drugs, and they can be applied on the anastomosis for a certain duration of time and prevent any neointimal hyperplasia, or even, it causes vessel dilatation and helps in maturation and maintenance of a blood vessel without neointimal hyperplasia. I've alluded to drug-eluting and balloons for angioplasty. Cryoplasty, we did try it about, say, 7 years ago, and I was not so impressed by it, and I don't use it in my. Again, brachytherapy is something that has been tried in the past. I'm not so sure. I have not used it, and the reason being that it's dosage, how much brachytherapy, how often, and and what is its outcome have still not been established. And the modality of brachytherapy, is it going to be intravascular brachytherapy, or is it going to be external brachytherapy? Adventitial wraps, I talked about this just now in terms of both elastase therapy as well as to inhibit vascular smooth muscle proliferation. Still, these are, I say, voodoo science, because we don't have any objectification of what, drug dose or what is side effects at that level, and I don't use it at all. Mechanical support devices to optimize AV fistula geometry. Again, the VasQ video that I showed is a part of this study. And as I alluded in the video, that there is limited data and we await further results. Gene therapy to modify some patient risk factors which are easily identifiable. And this is something for the future, I hope. Aiming to minimize surgical trauma, endovascular techniques have now been developed, and I'll show you one such. It's called the wavelength, endovascular AVF system, and have a look how they do it. So wires are placed in artery as well as in vein, and they are coupled by a magnets. And you burn a hole, basically, between the artery and the vein and create a AV fistula. And this embolization promotes, and there are newer techniques now evolved where you can put in a stent across that hole, or you can create a buttonhole like a like an ASD device or something like that. But framework of a ASD device where in reverse, which allows blood to mingle between artery and vein. And also newer developments are in the pipeline. How much it prevents the various factors that cause AV failure are yet to be studied in detail, and what is its efficacy, the data is still lacking. But that is for the future. For now, the nephrologist, vascular surgeon, dialysis technician, and an ultrasonographer and a nurse educator are the core of the AV fistula dream team. We need to look at anatomy in the beginning when we see our patients. We also need to actively select the right patients and create AV fistulas in a most minimally invasive manner so that we allow them to mature, and also we follow them up, keep an eye on their AV fistula performance so that we can deal with early thrombosis, failure to mature, and also late failure because of neointimal hyperplasia and other factors. So this, in a nutshell, is a blueprint for AV fistula care in the modern times in this day and time, and I hope that this is a good start to your conference, whereby it sums up, the talks that are going on, which deal with all these issues. So thank you for having me, and I'm happy to take any questions if any.
Okay. Sorry. Yeah. So thank you, sir. Thanks a lot for this all. It was really pleasure listening to you after so many years. I mean, on a presentation mode, especially after COVID, because you've been missing on for the physical conferences. For all the viewers, I must say that when I was in training, there was a rule कि खून माफ है लेकिन फिशुला बंद होना माफ नहीं है. That used to be so evening. So typically morning time used to be big cases, and evening, as sir said, we were lucky that when we were initial fellows, so initial fistulas we used to do under direct supervision. लेकिन वो तो ठीक है, but the moment you are doing something alone, the dictum used to be while going back, you have to go. You have to check patient or agle din tak over next 12 hours. It used to be a continuous fear, what will happen, and I think that training of keeping an eye, learning what is happening, that gradually led us to gave the confidence and understanding of a process that today I'm able to go to Varanasi or say like some other place, land in the morning, operate say 12 or 13 cases in a day, and then comfortably come back, and then go back and see in 2 weeks time what is happening. But this should sometime I think this reflects slightly negatively when I see myself, but I think that experience that has to come when your training has been happening with that depth. So thanks a lot, sir, for always being there. For even right now, if I have any question, we have a direct hotlink, so we always put on either ourselves or sometime other Twitter. So any questions from the panel? Yeah. I would like to make one comment, and before we can thank you to you, sir. That see, I think this was a very clear reflection of practice, a quality of practice which we have in India versus what you see overseas. A lot of limit. We are still stuck at a very early phase where we deal with much nutritionally poor patient. I will say, if you ask me, one factor which is the biggest deciding factor of AV fistula maturation or whether you should make it or not, I will say, does patient have a nephrologist or not? I mean, it may be a question mark ki why so. Lekin, I mean, maybe at your end, is it really possible? But in India, yes, we see so many patients who are just being managed at different, this technician level. So, but yes, upcoming treatments will eventually reach, including endovascular AVF. I wish that we should be able to first one to perform in India. I've been closely observing that, and I wish, very soon in one vein, we will call you in for the wavelength queue as well.
Himanshu, can I ask one question? If you permit?
Yeah, sure, sir.
Sir, I am very much interested. First, thanks a lot for your such a very lucid and very pleasant presentation. Really, though we are not a surgeon, but the way you expressed your thoughts were really fantastic. My interest was this incidence of thrombosis with the magnesium level. We never thought about this one. I think in clinical practice, we never try to see the magnesium level in any patient being sent for AV fistula creation. So how does this happen? How this low value of magnesium leads to thrombosis? What is the pathophysiology behind it?
I think the magnesium is one of the, it's involved in the calcium pathway. So if magnesium is less, then calcium tends to fill in those areas where magnesium would be. And therefore it causes more, what is called calciphylaxis. It leads to more, layering of the calcium in areas and stiffening the arteries. So I think it plays a lot of role in stiffening of the vessels, and also it is one of the factors in non-maturation of the veins.
I think that's I think hypomagnesemia is also one of the it's somewhere in the atherosclerosis formation system. It's one of the pre-atherosclerotic factors which has been described.
And I think if your patients are hypomagnesium, having low magnesium, then it's better to correct it and also add a statin to their, to their regime, so that that will prevent some of the activity that happens when calcium and other, calcium tends to fill in those areas where magnesium would have participated in the atherosclerotic pathway.
Thank you, sir. Okay.
Good.
Thank you very much, Himanshu, and it's been a pleasure to talk to your to the Banarasi Nephrology Society, and BHU and Varanasi is close to my heart. So thank you so much, and I hope that we'll be able to join again and discuss more. As you know, AV fistula is not my area of great expertise, but I'm more than happy to contribute. And Himanshu, thank you very much. I'm very proud of what you have done and what you are doing, and continue the good work.
Thank you, sir.
Thank you.
Sir. So, am I audible?
Yes, you are fully audible.
Okay, sir. So, if you all allow, then let us move to our next session. And this session will be coordinated by Dr. P.K. Rai, sir. Over to you, Dr. P.K. Rai, sir.
Oh, thank you, Dr. Mahinder. And the next talk is by Dr. Mehta. Dr. Mehta, are you able to hear me? Dr. Mehta, yes, you are welcome, Dr. Mehta, and we are going to be enlightened with your talk. He will be discussing a new area of vascular access management, AVF management from low flow to high flow, and how exactly we all face these problems in our day-to-day practice, that good number of times the fistula is not functioning well and there is no flow. Contrary to it, there are many patients where the fistula is really working well and there is a high flow. And how to manage these patients? We have with us Dr. Mehta from he is senior consultant from Lilavati Hospital, Mumbai, and he is one of the renowned interventional nephrologists of the country. And he has already been a speaker in our vascular and endovascular interventions in nephrology conference in previous years. And in this, the chairpersons we are going to join us are Professor Suraj Godara. He is Professor of Nephrology and Renal Transplantation, Mahatma Gandhi Medical College and Hospital. And the second person who is going to join us is Dr. Jayant Hota and Dr. Prasant Barnwal. Dr. Jayant Hota is not able to join, I think so. Dr. Prasant Barnwal is a senior plastic surgeon in Varanasi, and he is also associated in making AV fistulas, and he has got expertise in making fistulas in complicated situations, and he is one of the senior most plastic surgeon of Varanasi. With these, I think words, I hand over the session to the chairpersons, and and at the same time, I welcome you all today in this conference. And this really becomes a very important conference for us when we all join and share your views. Uh, Dr. Mehta, are you able to hear me? And
Yes,
can I
yes.
request you to start your talk?
Yeah, I can. Can I share my slides?
Sure, sir.
Yes.
Am I visible?
Yes, yes. Your slides are seen on the screen, and you are fully audible.
Yeah. So thank you, my dear friend Pradeep, for having invited me for the VeinCon 2022. And I was hoping actually to visit Varanasi, but and also have a look at the new corridor which has been opened up. But for the corona epidemic, which has flared up again, and also thanks to the chairpersons. What I thought when I was invited to give a talk on, and I've been talking majority of the time on central venous stenosis, but we have been doing a lot of work on AV fistula also. So let me just compile whatever we have experienced over the last few years. You might find this talk as little bit of repetition of Dr. Tripathi's talk, which I'll touch upon briefly. And the subsequent part, you might just feel that it's a continuation of what thoughts he put up forward. And I'm going to just present what is day-to-day practice, the problem solving, etc., which we encounter. So if that's how you feel, it's just purely coincidental. I've never met Dr. Tripathi, but I thoroughly enjoyed his talk. So as we know that though fistula is the best form of dialysis, but it's not benign, it is toxic. It's basically a non-physiological anomaly, and its toxic effect for the most part are unrecognized, and as we would call it, they fly below the radar and not get detected. And we also know that better vascular access leads to better patient survival, and we actually don't have an ideal dialysis conduit. And we also are living in an era with a lot of diabetic and hypertensive patients. So vascular access estate is very scarce. And that's why we need to preserve whatever we have rather than hope that we will make new one. And ideal thing would be to have a matured fistula. And now what's that? We all know this rule of 6, but most important that is we have to realize that fistula is a circuit which starts from the heart and ends at the heart. And that's why it is highly dependent on cardiac output, the blood pressure, the size of the artery, the inflow, and also the quality of artery because of the high prevalence of diabetes and atherosclerosis. This was alluded to by the previous speaker, and just to emphasize on that once the fistula is made, the remodeling takes place, and if you have inward remodeling, that's where your fistula is not likely to give you good results. But if you have outward remodeling, and that is where your fistula is going to be ending up in a very successful use of the fistula. As opposed to this, we must also address upon condition of high flow access, where hemodynamic is affected by flow rate that is larger than the blood flow, which is required for hemodialysis. It's typically defined as a blood flow of more than 1.5 to 2 liters per minute, and one where the excess flow is actually 20% more of the cardiac output. And it causes venous hypertension, Steele syndrome, heart failure, and arrhythmias, which is due to increased cardiac load and systemic Steele phenomena. Clinically, though very less diagnosed, but once you start looking at this condition, there are quite a few patients who have this sort of problem, and I'll be presenting one of these cases in the end. Now, coming to the interventions in nephrology, this started long ago with a publication from Dr. Gordon and Sidney Glantz of the USA, whose work was based on work of Transit And this was way back in 1982, where a paper was published in the Radiology Journal of treatment of stenotic lesions in dialysis, excess fistula, and shunts by transluminal angioplasty. Professor Gerald Bethard in USA has been considered as father of interventional nephrology, and I had a pleasure of meeting him just before starting of Corona in 2020 at in USA for during the last conference of ASDN, where we were physically present. This was in Las Vegas, and he was the one, after completing his nephrology training, he joined hands with cardiologists and learned the technique and started practicing it. Now, when we talk about interventions, one is that there is a failure to mature. And this was alluded to by Dr. Tripathi, that yes, there is something called as balloon-assisted maturation, which has many definitions. And basically, it is an angioplasty to achieve serial dilatation of the prospective puncture X segment, which does not occur spontaneously. So, if you look at it, if you construct all the fistulas, either they end up with successful spontaneous maturation, or there is a failure without intervention, just a primary failure, which may happen on table or within a couple of days. And then we have quite a few number of patients who we call it FTM, failure to mature, and which needs intervention. Now, when we send them for intervention, you either have a situation of what is called as a successful assisted maturation, or your intervention fails, and some of these fistulas have to be then dumped into the dustbin. So what is balloon assisted maturation? So you have class 1 and class 2 BAM. So you have large vein which are more than 6 millimeter deep, or small vein which are 2 to 5 millimeter. You do sequential dilatation 2 to 4 weeks, successively larger balloons 10 to 12 millimeter, and you keep on repeating it till they become usable. So this was a paper published by Miller in Journal of Vascular Access. It was very much practiced, but nowadays it is not very much in vogue from this. And then one of the factor is also competing or accessory veins, which can be ligated or coil embolization done. So this was the bottom part of this slide shows the poster which we presented in ASDI in 2021 of this lady who had come with venous hypertension. As you can see, she has big ulcers on 2 of the fingers, extremely painful hand, with the hand pain would get aggravated during dialysis. And the reason for that was that if you look at this is somewhere just around the elbow, and this vein was visible, which was being punctured. But when we did the angiography, beyond that, in the upper arm, the cephalic vein was so thin. And because it was thin, accessory vein had developed, which was returning like this towards the hand and causing pain. So when you would put a needle here for venous return, blood would go up to here and then get returned into the hand, causing a lot of pain. So what we did was just went in there, did the call embolization. This which vein was cut off. We instructed the patient to tell them not to puncture this segment. This was done, and within a week, her hand swelling disappeared. You can see the ulcer has already healed, and patient had a successful use of the fistula. This was in spite of the fact that 2 of the urologists and vascular surgeons and a radiologist, all of them had advised her to get this fistula closed because nothing can be done. We do it, this BAM, in a different way. We also face a lot of patients who fail to mature their fistula. So this was the patient, a 70-year-old myelodysplastic syndrome, hypertensive. Fistula did not mature after 3 months, being dialyzed on top. So ideally, these are the patients who should be subjected to angio. And when we did that, we found little narrowing here, lot of narrowing there. So we did this plasty here, and then this plasty here, and this was the final result. And now the fistula became usable. So this can be also called as balloon assisted maturation in our setup, and not the one which I alluded to earlier of serial dilatation. This was a patient whose fistula was made well 8 months prior to his reaching the stage of requiring dialysis. Now, when we face this sort of problem, how does one react? Okay, so a surgeon might say, forget it, we can make a new anastomosis here and get a new fistula going. But a person like interventionalist, interventional nephrologist or radiologist might want to do a angioplasty here and get this same fistula going. The problem could be, if we were to do this anastomosis, is there is no guarantee that there will be no another juxta-anastomotic narrowing, number one. The other problem could be, other way to solve this is also do what is called a spechplasty, which was also referred to in the talks earlier in the day. So various options are possible, and it depends on how you look at the whole problem. The point is, yes, this is possible to tackle endovascularly. As opposed to this, if you have this sort of a problem, so another fistula made well in advance and just not matured. Now patient is, obviously you would not have done angiography at a time when a patient is just pre-dialysis for the fear of, pushing him onto dialysis due to contrast nephropathy. But if you get this sort of veins, which are diffusely diseased, then obviously you'll have to look at other alternatives, because these are not the ones which are amenable to endovascular interventions. However, this, yes, can be tackled, though no vein is visible. So obviously we cannot talk about any surgical intervention at this moment. But if you do it properly, then this is the end result. So this is how, if there is no flow, you can. So let's look at this situation. So 49-year-old diabetic lady who had refused fistula in the pre-ASRD, though following regularly. She started on dialysis 1 month ago, right internal jugular, and then right radiocephalic, left radiocephalic AV fistula was created. And as usual, after discharge, we always call patients on day 15 just to assess that everything is in order. We found fistula working well. On day 25, frantic call, oh, there is no thrill, and AV fistula is not working. So what to do? So she was immediately asked to come to the hospital, get admitted, and this is what we did. We accessed it from the radial artery, and you see that there is no vein visible. We managed to pass the guide wire across, and then we found that yes, some thrombus, etc., is there just here at the juxta-anastomotic side on the venous side. So angioplasty was done, though we found that the vein has opened up, but yes, there is a thrombus still sitting there. We kept on doing angioplasty. 3 times we did, but this thrombus would just not budge. So that was the time when we did take a decision that let's put a stent, and because the vein has not yet matured enough, and we only had coronary stents available, so we decided to put about 3.5 by I think 15 millimeter balloon here, and these are, as you all know, balloon mounted stents. So we deployed the stent here, and we thought which is end of the thing. However, the thrombus got migrated onto the arterial side. So now what to do? Luckily, the same balloon of the coronary stent was available with us. So we deployed that, ligated the artery, and this was the end result. And this fistula then worked well for several years. As opposed to that, if you have poor flow situation after 3 months, so this lady, 55-year-old, obese, diabetic, left tracheocephalic fistula, now comes with reduced thrill, and the reason is very obvious here. And then there is another narrowing upward towards the axilla. So Plasty is done at both the places, and the fistula becomes matured and started using it. This is the final shoot. And then after 4 months, she comes again with poor flow, and you find that the whole vein up to the cephalic arch is diffusely diseased. And then we do multiple plasties at various places, and then again we could achieve the whole vein patency. So that's how also one can make the fistula help mature and become usable. Now, this was also alluded to that there are late malfunctions in a working fistula. So this is a 53-year-old female, non-diabetic, on dialysis for 5 years. Suddenly, one night she calls up to say that there is no thrill. So obviously she's counseled and told that come tomorrow morning. So next day morning she calls up to say, oh, my thrill is present. I am not coming. But we somehow persuaded her to come, because the fact is the fistula closed down, though transiently, needs evaluation. Likely there was a thrombus which got spontaneously dislodged. But the question also is, if there was a thrombus which got dislodged, why did the thrombus form? So whether there was an underlying venous stenosis. So she's brought in and subjected. So as you had suspected it, yes, there is a big thrombus sitting there, which somehow became in such a way that, yes, it became usable. There was a very nice distal filling from in the palmar arch, so that was fine. But we did thrombosuction, and this was the partial improvement here, but not complete as one would have desired. So angioplasty is done. This is the result, not very good. So another angioplasty, still not so good. Ultimately, we kept on doing it both places, in the body of the fistula as well as in the venous side of the juxtaanastomotic segment. And this was the final result. That now there is no thrombus visible here. And then this fistula is working from the last 5 years. And also not to forget that if there is a poor flow, look at the inflow. So this was the fistula at the left elbow, and very nicely visible veins, but moment, and I mean, anybody can puncture it, even a novice technician could puncture it. But moment you puncture it, it will collapse. So we were wondering what's happening. And now this is the situation where you have to actually study the circuit. So we went from the femoral artery, and that's where the problem was. There was this arterial inflow narrowing here. The vein, draining vein was perfect. It was this problem. So moment you puncture this vein, this arterial inflow would be so low that the vein will collapse and you won't be able to do any further dialysis. So this was plastered and then stented, and then this is again made sure that the fistula works well and the draining vein is perfect. And this fistula immediately then became usable. So never to forget that inflow is also a part of fistula. As I said, it's a circuit and you have to look at the fistula. Now, what about the catheters? So this is a paper come from Kidney 360, published December last month. So is there any impact of previous tunnel catheter and their location on upper limb AV fistula function? Because we encountered these patients in last 3 months, a few of them which I am going to present. So what was the conclusion of this paper? Was, and this came from Australia, so Dr. Tripathi might know about it. So previous tunnel catheter use was associated with poorer AV fistula function at 6 and 12 months with a higher rate of assisted maturation. The presence of an ipsilateral tunnel catheter was associated with lower successful fistula use at 6 months compared to contralateral. So what has been traditional knowledge and supposed to be practiced, that we should try and avoid AV fistula and the tunnel catheter ipsilaterally, but somehow it is not practiced as much as. So let's look at this. So this is a patient who is right brachiocephalic AV fistula, has a swollen hand being dialyzed in Ahmedabad, and actually this patient was referred by Dr. Rajapurkar. He said, just sort this out, what is happening. And if AV fistula was very difficult to use, when we did the angio, this is a very good fistula, but the culprit is here. There is a right brachiocephalic vein stenosis, and so we came in from the fistula, and it was very difficult to, cross it, but somehow then we managed to persist with it, and this is how we could enter into it. See, the wire has gone in. So once we went in, then we did the plasty, and this was still a recoil here in spite of repeated plasties with good dilatation and good pressure and good timing. So it was decided to put in a stent over there, and this is the stent which was deployed there in the right brachiocephalic vein, and within less than 24 hours the hand swelling settled, and it was very comfortable for the patient to. So this obviously occurred because of the previous tunnel catheter on the same side. And here is another patient, basically renal calculus disease, who has again left elbow AV fistula, and then also has the left IJV tunnel catheter, and he has this very, very painful swollen left upper limb. He cannot lift it also, and he's in trouble. He was subjected to angiography, where obviously left brachiocephalic AV fistula, brachiocephalic vein was found to be narrowed, and so he was referred for problem solving. So I gave him two options. I said, look, your right IJV should be used for TCC. You remove the left IJV TCC, and then you can do left subclavian vein or brachiocephalic vein plasty plus or minus stenting. And that is what is one option. But ideally, you keep your left IJV TCC, forget the fistula. We will assess if right-sided AV fistula is possible, because clinically when I examined him for the first time, I thought we can make a right AV fistula and close the left brachiocephalic AV fistula. But patient was very adamant. He's told me very categorically, don't touch my fistula, do whatever is required to be done. So now in this sort of situation, what do we do? So, okay, so this is the referring nephrologist picture with which patient is sent to us, and we reconfirmed that yes, there was this narrowing, and so we had to assess the right side, and we found that right IJV was thrombus, but EJV was patent. We managed to puncture it and put in a wire all the way down. Now was the question of puncturing this. This was very difficult, and this is CTO. So we went in first with the soft end of the Terumo glide wire, but that failed. So now I'm going in with the hard end, and you have to literally dig in. Like now, see this. Once you have achieved that, now you don't go further with that hard end. You go in with a soft end, and now we have managed to go in there, and that's how. Okay, this look it can be tackled later. So once we have went in, we had to remove the TCC, and once we did that, we did the plasty, and this. Now remember, there is a high flow fistula. That fistula had a flow of nearly 2 liters on the left brachiocephalic side. So we had to plasty this, and then we have to put the stent. Now the problem would be when we put the stent on the left brachiocephalic vein is that we have to prevent the jailing of the right brachiocephalic vein with SVC and the left brachiocephalic vein junction. So first we put the catheter here, made sure that our stent is going to be falling short of this area, so that otherwise if you put the stent in and you block this area, you can't put this one here. So this is the final picture. You have a very, very patent. And within 48 hours, patient's edema and pain settle down, and patient is happily doing dialysis through this till the edema settles, then he'll be switched over to the, he's been referred back to his. And this is a very, very sorry state of affair which goes around. In spite of our repeated attempts to educate people at large, this is what we keep on saying. There's a 29-year-old man, 1.5 years of dialysis, and you'll see everything. His very huge body surface area of about 26, 27. And he's come with right upper limb swelling, which has a fistula, and face is swollen, and he cannot lie down. He's orthopnic, and he's also edematous. His weight has been now gained by more than 10 kilos. So he's now weighing almost 110, 120 kilos. But he says he's been less than 100 kilos. And CT has been done, and you find that there is a right brachiocephalic vein stenosis here. And there is this another stenosis at the cavoatrial junction. And we had to do something and see the sorry state. Within 1.5 years, somebody has created, due to multiple catheters, the right side is blocked, IJV is completely blocked. This is somewhere we hope we have come from the EJV. We thought we'll try to go in from the left side, but we punctured the left side and we find this sort of picture that we cannot lead, which does not lead us to anywhere. Right femoral vein, cut off here. Left femoral vein, cut off here. So all sides blocked. Now, how does we go up? Somehow we managed to get in through here, and we were getting stuck here. This is the azygous vein. We just couldn't go beyond that. So then, mind you, this case took 4 hours. Myself, interventional radiologist, his associate, and my associate. 4 people working on this case for 4 hours. So one of the radiology associates said, sir, why not we at least do plasty of this? We did plasty of this. We found a way down to go down. Now see, this is what has happened. This is your IVC. These are your renal veins and below. So the future problem is, where are we going to do a transplant for this young man? So that's another thing. So ultimately, we did have this, and we had to put the stents here. So this is, if you remember that CT scan, this is exactly the same picture. So you had a stenosis there, you had a stenosis here. We did plasty here, we did plasty here, put a stent here, we had a stent here. There was a measure file inserting the stent, so we had to put stent in stent here. So ultimately, this has happened, and patient has improved tremendously symptomatically. So these are the situations where you have no flow, low flow, or very high flow with other problem. This is another method which has been described as Miller's bending, which is basically advocated either for high flow fistula, for flow reduction, or for Steele syndrome. So this is the one where we utilized it as a flow reduction. So 40-year-old female, 6 years on dialysis, left brachiocephalic fistula, 2017 AV fistula angioplasty, graphy and angioplasty done for this reason. And this is how it was done, and we could achieve a very good result there. So this from 2017 got 12 till January 21. When she started with symptoms and signs of CCF, pulmonary hypertension, hyperdynamic circulation, left chest vibrations during dialysis. An angiography was done in February, which showed high flow fistula and no central vein stenosis. The flow volume was 4 liters. We did counsel her for intervention, for flow reduction, but of course, with the risk that this fistula might close down, and she said that we'll hold on. Problems became bad. This is what happens, worsening symptoms, a very dilated vein here, dilated veins in the neck causing headache and earache, and she could not walk properly, could not perform. Now flow has gone up from 4 liters to 12 liters. So we had to do endovascular intervention. And we decided to offer a Miller's bending procedure. So first made sure that central veins are patent, and this is how so this is where we have marked that this is what we would be attempting to do bending, and this is after the bending. Yeah, we have done the bending here. I'll show you. So this is how one does the Miller's procedure. Somewhere near the anastomotic site, you make 2 incisions on either side of the veins, take a calyx clamp, go from below, take the suture out and come from top of the vein here and tie it. So this is exactly what we did, as was shown in this article by Professor Miller. Typically, you put a balloon of 4 to 5 millimeter and tie the knot over it. But if you don't want to do that, then you can use this modification as a dilator. We also did little modification in this technique, in the sense that when we put the balloon and put the suture around the vein, we did measure the flow right at that time on table. The first time we got it at around 1500, we said, no, this is not. So we tightened it further, made sure that the flow is reduced to 800 ml. So you can measure the flow on table. So this is what we did, and this is how the final picture is. So this flow came down from 12 liters to 800 ml. So this is the balloon, the 5 millimeter balloon, around which we inflated the balloon and then put a suture around it, and that has worked well. And after 15 days, look at this, the vein has started becoming towards normal. Her throbbing headache has gone, her quality of life, the work performance has improved tremendously. So by doing Miller's bending, the flow related problem, which are patient specific, which go mostly unrecognized because there is very little correlation between excess flow and clinical symptoms of excessive flow. Cardiac output is the driving force maintaining both flow and pressure within the hemodialysis access. And we can use Miller's bending technique to effectively treat high flow AV fistulas. So I would end here by saying that we began by various stalwarts in the field of nephrology, starting all the way from Willem Paul, going to Sidney Sheldon, then Brescia and Simino, who were the nephrologist, and Apple was the surgeon over there, to Belding, Scribner, and Tankov, and Gore brothers for Vortex Graft, and lastly, Professor Gerald Bethard, as I showed you, and then developed initiation of American Society of Diagnostic and Interventional Nephrology, and that's how we, as nephrologists, have become interventionalists and trying to do something for our own patient, for their benefit and longevity. And I thank you once again for having invited me. Thank you.
Thanks, Dr. Mehta, for the excellent coverage of a new dimension, because we are facing the AV fistula problems day in and day out. Good number of times the patients, some of them have got poor flow or there is no flow. And contrary to it, in few patients, there is a high flow of fistula. And I'm happy that you have focused on this part, and you have just showed us that it can be managed with the endovascular interventions, and we can safely manage the fistulas and salvage the fistulas by doing endovascular interventions. Although it's not very easy, but at least it's a good news for all of us that we are all exposed to these things, and you are doing, and you have got personal experience of doing this AV fistula interventions, endovascular interventions. And if there are questions from the audience or the other chairpersons who are interested, if there are any queries from the delegates regarding this talk. Dr. Sampath, do you have any questions? No.
So, Pradeep, one thing I would like to add to it, somewhere in the previous talk of this AV fistula, it was said that almost every patient comes back when you do the AV fistula angioplasty. I would like to not totally agree with it because if you choose your patients properly, if you choose your balloons properly, if you choose your pressures properly, if you choose your timing of dilatation, inflation of balloon properly, you can achieve very good success. Because see, I mean, even if I work at a place like Lilavati, which is supposed to be a top class hospital, patients do have financial issues there also. And most of the time, what I've learned now, having been doing this interventions for last more than 20 years, is that the first procedure for this sort of work is budget-wise patients last procedure. If this fails, patient cannot afford anything more. So that is a situation. So whatever we do, we must ourselves make sure that we are able to give a very good result. Now, having adopted this, so I started this inflation of balloon for 3 minutes. Even 20 years ago, when it was mentioned 1 to 2 minutes, I said, no, let's go 1 minute more. What difference does it make by waiting 1 minute more? And our results have been good. Not more than 20% recurrence. Right now, I have a patient who's unfortunately admitted with a stroke, diabetic patient whose first angioplasty was done way back in 2005. And then he had another intervention in 2010. And that fistula is still working today. He's unconscious, he's on ventilator, but his fistula is working. 21 years.
That's a good news. And what literature says or what the other persons have shared their experience, in 6 months to 1 year time, good number of angioplasties, there is a re-stenosis. And you have to go for re-angioplasty in these patients. And if it happens like this, the timing and ballooning and of the in this stenosis of managing stenosis of these patients, it's really good. How frequently you come across re-stenosis in your patients?
Yeah, that's what I said. So about 2 to 3% primary failure. Primary failure meaning either we are not able to do it or we have a good result on table, but within 5-7 days fistula is closed down. So that happens in about 2 to 3% of patients.
Suppose angioplasty has been done and it has been successful, and in the follow-up at 6 months or 1 year, what is the percentage of re-stenosis in your patient?
That's what I'm saying. Not more than 20%.
Not.
So
that's really a very excellent result, you can say.
Yeah.
Sir, this is something beyond any literature. This
Yes.
is a wonderful result.
Yeah.
Yes, we really congratulate you for this.
It can be only achieved with a very close follow-up.
No, so that's what I said. See, we have to dedicate the time. See, the difference, I mean, I'm not against anybody. We are all like colleagues and I have my team which has an interventional radiologist and a vascular surgeon. We work as a team and we choose our role as to what are we going to do for this patient. This team has been we have been together for more than 15 years. And ultimately, the purpose is simple and we all are dedicated towards giving a good vascular access to a dialysis patient. So we work with that single aim of achieving excellent results. So once you do have that sort of policy in mind that we must work as a team and try to get a good result, I think it is
good
achievable.
results. To me, it appears that good results are because of your nice team and focused way of working. And that's why, because if you monitor these patients and you are really concerned for these procedures and what exactly is going to be the outcome in these patients, and that really leads to the good outcome in your patients.
See, because as a nephrologist, we should be, captain of the team.
Yes.
This is where the problem sometimes occurs not in major hospitals, but outside, like this patient whom I presented last, he had been to 3 interventional radiologists, 1 vascular surgeon. not aware, the nephrologist is not aware that he's going there and getting his things done. So total discoordination. When his problem became so bad that then the nephrologist said, okay, go to Dr. Hemant Mehta, he will try to sort it out for you. So this is what is happening. There's total discoordination between the nephrologist and the other. See, all nephrologists are not doing this procedure. Okay, granted. But at least nephrologists should take command that, look, this is what is to be done. This is what is required to be done. Don't do this, don't or do that. Like the reason his right brachiocephalic vein thrombosed was the last person put in a catheter, there was no flow. So he kept on pulling out the catheter till he got a good flow. And we knew that was not in the right position. The tip was left in the right brachiocephalic. Now, if you leave a tip in the right brachiocephalic vein, obviously that vein is going to thrombus sooner or later.
That's true.
Yeah. So that is where your coordination is required. The nephrologist should tell him, look, this is what you have done is wrong. Do something.
Boss, can I ask one question?
Yes, yes.
Yeah, Dr. Mehta, thanks. Very nice presentation. My concern is about this recurrence of stenosis after plasty.
Yeah.
We all know that the pathophysiology behind this is there is a lot of fibrosis is going on at the site of stenosis. So how we are going to prevent those recurrences? Are you doing something special for that? That's why you are.
No, that's what I said. The recurrence rate is low because we deliver good result by, choosing everything, trying to choose everything in a perfect way. So once you have dilated it well, and then the only thing we tell the patient is to do the exercise, because anyway, nothing will help. Neither your antiplatelets will help, nor your anticoagulants will help. And in fact, we should avoid vitamin K antagonist, because vitamin K antagonist will precipitate the calcification into the arterial intima. So that should also be avoided. So nothing of that sort. So just patient is then told to do proper exercise and monitor the fistula, and that's it. And the most important thing, every patient, when they are especially from outside the center, is told to throw away his Velcro belts. There is a very rampant malpractice of using Velcro belt to tie around the fistula after the dialysis is over, because everybody is in a hurry. Patient is in a hurry, the staff is in a hurry, the dialysis units are over burdened. So put a Velcro belt and move out, because nobody has the time to press it for 10 minutes and then put a simple micropore dressing or something like that. So that is one thing. You don't put Velcro belt. That's also very useful tip.
Great message. Thank you.
Yeah.
Dr. Hemant, one question. I'm Dr. Sanjay from Bangalore.
Yeah.
Dr. Hemant, you told about this Miller's procedure.
Yeah.
See, you said that you should have a balloon dilated and then try to tie it, or is it necessary that the balloon should be there?
No. See, there are 2-3 ways. Okay. One is you do it endovascularly. So you come in there, position your balloon at a site where you are going to bend, put a suture. The purpose of having the balloon inflated is that you don't over tighten it.
Overdo it. Okay.
So you are tying it just around the balloon. Once you have made sure your knot is perfectly positioned, then deflate the balloon and remove it. The vein is already narrow, as I showed in the picture. Number one. Number two is, if you are not able to reach there, so I was talking to Dr. Vandan Niyar from Emory University, and she does it with a surgeon. So they open up the vein, she comes in with a balloon inside, and then surgeon openly places the knot around the surround the vein. Okay. And the third one, as I said, in case you don't want to use the balloon, there is actually a nomogram available, that if your vein is so much and if you want to reduce it to so much, you have to choose this balloon. That I didn't show here, but that nomogram is available. But typically you will be ending up using 4 or 5 millimeter balloon on an average. So you use that balloon, inflate it, or you, as I showed you in the last picture, modification is the, this vessel dilators which are available, which vascular surgeons use. They will typically have that 4-5 millimeter diameter only. So you can put that, just that is to avoid the, but then to do that, you'll have to, make a puncture into the vein, because how will it go inside? So you need a vascular surgeon again there. So better ways to put endovascularly the balloon and tie a knot around it. Now, because sometimes this vein is so big, like we encountered it in recently one of the patient, that it was just not possible for a callus forceps to go around the vein. So then we said, let us not try it. We might puncture it, and then we'll call the surgeon to do it openly. So we have to be also careful. It is not something where we are able to, take a per-stitch suture around the vein so easily, because it's a dilated vein and a very high flow vein. Is like in our patient, 12 liter is too high a flow.
And one more question, sir. And you said that your primary failure rates are around 1 to 2%.
Yeah.
And do you have a cutoff beyond, let us say, the size or the diameter of the vein, beyond which you will not attempt fistula creation? For example, we expect around 2.5 millimeter to be good.
Yeah.
So is there a cutoff or the lower limit beyond which you will not attempt a fistula at all?
So this also was done as a part of our DNB study and presented in one of the outer conference as a poster. So we did study various sizes of arterial and venous diameter. And yes, if the vein is less than 2 millimeter, we should not try to make a fistula. So this is again an area where I am actively involved in prevailing upon. I don't make fistula myself, but I prevail upon the surgeon. I assess the patient clinically. Every patient of mine going for fistula undergoes the Doppler study. Some of the Doppler studies are also attended by me, so that I know what exactly the radiologist is looking. And then I tell surgeon, look, this is the only site where you will make the fistula. Oh, I can make it. I said, okay, you can make it at risk, but you come maybe forearm. Don't do it at the wrist. Something like that. So again, our role also comes there. If we are not making the fistula, we should not allow the other person to be over enthusiastic and trying to do things which are not likely to have good outcome. So that is another thing.
I fully agree with Dr. Mehta. Even if fistula is made by urologist or plastic surgeon, the nephrologist involvement is very important, and it really, if you are involved, the fistula outcome is going to be good in your patients. And it's really very important. If there are no more questions, can we conclude this session? I think there are no questions now. I thank the chairpersons, Dr. Prasant Barnwal, and I once again thank Dr. Mehta for the excellent coverage of a new topic which we really face in our day-to-day practice. And with his talk, we all are going to be enlightened, and we can go ahead with the management of heavy fistula from no flow to high flow, and we can really give good lease of life to fistula as well as to the patient. Now, thank you once again.
Thank you, Pradeep. Yeah,
we will switch over to the third talk of this post-lunch session, and it will be by Dr. Sampath. Dr. Sampath is already online, and he is going to talk about light at the end of the tunnel. You all know Dr. Sampath. He is one of the renowned nephrologist and interventional nephrologist of the country, and he is a chief consultant of nephrology department from Madurai, and we have chairpersons with us, Dr. Pankaj Beniwal and Dr. P.K. Dole and Dr. Sanjay Srinivas with us, and I do not know whether the chairperson, I could see Dr. Srinivas and Dr. Pankaj Beniwal. You all are, yes, and Dr. Avilash Chandra. Avilash Chandra is additional professor, and of nephrology at Lucknow, and Dr. K. Dole is assistant professor of nephrology at Guwahati. All these senior nephrologists are there in the panel of chairpersons, and I hand over the session now to the chairpersons, and I request Dr. Sampath to share his slides so that we can start the talk. Welcome, Dr. Sampath.
Yeah, thank you. Thank you, Dr. Roy, for this great invitation. My only concern is that I am not able to be there physically there because, as we know, man proposes and COVID disposes.
Yes,
so,
that's true.
So,
but
yes.
but do not get decided. Maybe next time we are going to have you and your company and along with your family.
Thank
and
you.
it will be pleasure having you at Varanasi.
Thank you. Thank you very much. So I have been listening to great talks over the last few hours. My talk will focus on, possibly I won't say that very advanced level interventions, but I'll focus on the aspects of tunneled venous catheter placement, which we all face, and the concerns that we encounter in our day-to-day practice. I'll start by this slide. The question was asked, what is the specialty which deals with the most challenging cases? And no prizes for guessing in this conference that when it comes to various domains of comorbidities, number of drugs, length of stay of hospital, long-term care placement, emergency department visits, nephrology came head and shoulders above other specialties. And that is possibly one of the reasons why nephrologist is lost in thought most of the times, and he has missed the bus of interventions. And thankfully, things are happening in a beautiful way all these 10 to 15 years. And we have a young bunch of nephrologists who are very well trained and also daring to go in the field of interventional nephrology. As far as the central venous catheters used across the developed nations, you still see that close to 20 to 25% of prevalent patients are still dialyzed with the help of a central venous catheter. So the first encounter of an end-stage renal disease patient in India is not an encounter which we all suffer. Often in an emergency unit with extremes of uremia, and he has never met a nephrologist before, and there is no AV fistula and not even a mention, and high rates of infection with a non-tunneled CV catheters and higher need to acquire. So this all points down to the higher need for acquiring mastery over the tunneled central venous catheters. And I don't have to talk about the advantages of tunnel venous catheters, and you have everything you can see. The catheter survival is improving by the year, and the relative ease of insertions. Even now, when I go as an examiner for a DNB, I now ask the students whether they have inserted tunnel catheters. Over the last few years, I always hear the answer that yes. So this was not there earlier, and with an acceptable rates of infection. So this was the first series of tunnel central venous catheter which came out from India, and this we had the 100 tunnel catheters inserted in our center, which is published in the Indian Journal way back, where we showed that as it could be a very good access to have as a primary access in those patients who are ready for a renal transplant. And so even last week we had a patient who underwent a renal transplant with only a tunnel catheter, and which was there for 2 months with a her mother was a donor. So these are the 3 T's that you will look for in a successful tunnel venous catheter placement. The tip, where should you place the tip, and how is the top? Is there any kink? And how is the tug? How good are the blood suction which is coming out? So the way that we do is always by looking at the cross-sectional area of the vein, and in fact, we of the probe placed just above the clavicle. But there are situations where the probe may be placed for longitudinal to have a longitudinal view of the vein, and this is not ideal because then the entry point of the vein becomes much more higher plane, and this leads to higher chances of kinking because then acute angulation happens. So always go as close to the clavicle as possible. And this is another issue that most often we are comfortable with using a 16 gauge needle, but in situations where the vein is very small, then you need to have a micro puncture set with you with a micro wire and also a micro catheter. So this is especially important when you have a very small diameter internal jugular vein, not when the vein is so large, but when the vein diameter is small, as is seen often in patients who have had repeated internal jugular non-tunnel catheters being placed. Then this is the time at which you will be well served with a micropuncture set, which you can use it for very good use. And the other issue, which again is emphasized by the earlier speakers, is that always you should have the, on the right side, you try to keep the tip inside the inferior vena cava and not allow it to curl in the right atrium, so that it is easier for you to manipulate the catheter. So on the left side, always we have issues, challenges, because what we see in the 2-dimensional view is that this has got 2 or 3 bends, but you have to visualize and think in your mind that this 2-dimensional view may not be correct. You can also have an antero-posterior curvature of these innominate veins, especially on the left side, so that you will have to face challenges. So this was one of the wires which we placed, and we had severe difficulty in placing it from the left side innominate, and you can see that the wire was not entering very easily. And when it entered, you see that it is crossing the midline, and it is growing away and crossing the midline of the spine. So this tells you that this patient's guide wire, which is put in from the left side, has gone into the azygos system. So this is an important message, that there should not be any crossing of the wire across the midline. And so you will have to remove it. And because sometimes this azygos system can get very much dilated in the presence of central vein stenosis, and they can easily admit these wires. So then, as far as the tip designs are concerned, we have now come to a stage where either it is the symmetric tip catheters, which we always use, or the glide path and the palindrome. All these 2 catheters have come in, has become very popular now. The step tip catheters and the split tip catheters are slowly giving way to these catheters because of the fact that the ease of insertion, and also the fact that you can easily switch between these arterial and venous ports when there is a low flow, and also for the fact that the recirculation rates or minimal, if any. So as far as my approach goes, I feel that the glide path catheter seems to have slight edge over the palindrome, especially when it comes to non-peel away sheath insertion, because the palindrome has got what is called a venar tract, which is slightly more cumbersome, slightly complex than a glide path catheter, as we shall see now. And also a smaller kink diameter in the glide path catheter sees to it that you are able to negotiate the curves very well. So this is a glide path catheter, which on the left side we are putting in. You can see that a good amount of dilatation has to be done, and this dilatation has to be carefully looked in at the cath lab with the fluoroscopic guidance, because the kink of the guide wire should not happen. And you will also, when you are inserting with the help of a non-peel away sheath, it is a good idea to have a dilatation done with a largest dilator which is available with the assembly of the peel away sheath, so that this becomes easier. And you can see that the glide path, for people who have not used glide path, I can see it has got a central stiffener, which is very ideal, which is very useful, where you thread the guide wire through that and see to it that it comes out through the hub of the catheter, and grasp it with artery forceps so that it doesn't slip in. After that, you will just have to glide in and you can see that the catheter is very well placed. So there could be anatomical variations, and this was one non-tunnel catheter which was put in on a patient, and this has gone to the other side, and when we injected the dye, we saw that this patient has a persistent superior vena cava, and there was the left superior vena cava, the right side was atretic, and you can see that the dye is going into the coronary sinus from the left side. And this was a patient who had no other vein was possible to insert, and the right AJV, you cannot use it. CAPD was not possible. Left side tunnel, the CVC was possible, and we had doubts whether it will work. So persistent left superior vena cava could be there in most common thoracic venous anomaly, 0.5% of the general population. It drains via the coronary sinus into the right atrium, and sometimes it can drain into the left atrium, 5 to 10%. Up to 40% of cases, there are associated cardiac anomalies. So you have to be alive to that possibility. So what we did was just insert a tunnel catheter on a straight line with a guide wire, and after the dilatation, so we were able to have this catheter functioning well, and this patient is still on dialysis for more than 1.5 years now. So even a left superior, persistent superior vena cava could be used as a conduit, final conduit in those patients in challenging situations. But a straight course of a left-sided central vein may also mean placement into these. So you have to be aware that descending aorta can be pierced, internal thoracic vein, or pericardium or mediastinum. So be aware that you may place these into these catheter, into these other areas also. I will just move on. And this was our latest paper where we have been doing, we have been using the 70% ethanol log solution for our biofilm formation in dialysis patients, especially tunnel catheters who come with fever and they are culture positive. So this was a paper which we used, which we published along with Dr. Kashi. So this, he has done some excellent lab work where he has shown that in this culture plate, the 70% ethanol seems to work well with a variety of bacteria. If you see Pseudomonas, Acinetobacter and Staph aureus, these are indications that the tunnel catheter should come out. So we have used 70% ethanol and salvaged these catheters without removal of these catheters. And so this, again, in the lab, he has shown that subcultures in ethanol, E. coli, there is no growth in contrast to the control. Staph, absolutely clear broth, and also Pseudomonas, absolutely clear broth in contrast to the control. So 70% ethanol has got good way of usage in patients who come with tunnel catheter infections. What I do is fill it, and then after 5 hours remove it, and I repeat it for 5 to 7 days, and more than 80 to 90% of my patients who have a biofilm formation, the catheter could be salvaged. So I make 70% ethanol by diluting 7 ml of 100% ethanol, which is available, with 3 ml of normal saline or distilled water. So what about this issue of placement of tunnel catheters in the mid-right atrium? So we have always been, all the guidelines say that you shouldn't put it at the cave atrial junction, but you should go further and then put it in the mid-right atrium. But is it always safe? There are some issues, and as we shall see. So this was a patient who had facial swelling after the first month of tunnel catheter insertion, and we did an angiogram. We saw that there was a thrombus. You can see the negative image, a big thrombus sitting at the close to the tip of the catheter. So this is much more common when you place the catheters in the mid-right atrium. So you have got to be, so even here you can see that the catheter is placed well above, but still the patient had large thrombus, and which was again confirmed with esophageal echocardiogram, which was again repeated after a thrombolytic therapy, and we are able to have lysis of this clot. So catheter associated right atrial thrombus, the incidence is underestimated, and the tip location inside the right atrium increases the risk and presents as a catheter dysfunction, or sometimes SVC obstruction, as we shall see, as we have seen now, or pulmonary embolus. And thrombolysis with or without catheter exchange is being advocated. You can get away with without catheter exchange if the clot burden is smaller, and long-term anticoagulation is required, but unfortunately sudden death can happen. So we have to be aware of that. So this is a talk which I have fashioned for people who are venturing into the central venous catheter insertions. And so you may think that there is light at the end of the tunnel in every time you place a catheter in the central vein, but this tunnel could be the headlights of a speeding train if you go by Sidhu's words. So you have to be careful in every interventions that you know what you do, because the primary motto is that first do no harm. Thank you very much for this excellent opportunity.
Thank you, Dr. Sampath, for an excellent talk. And I think we all have been enlightened with your experience of handling this tunnel catheters and its associated complications. There are few questions.
So first of all, I will like to ask the question.
Yeah.
Sir,
Yes.
I'm Dr. M.N. Singh, sir. I'm one of the organizing secretary of this conference also. And
Yeah.
individually, I am doing 10 to 15 permanent catheters per month.
Yeah.
And I am really excited to see the concept of 70% alcohol.
Yeah.
And what I could gather from you, I will like to be corrected by you, sir.
Yeah.
Sir, you said that we are supposed to use 70% alcohol.
Yeah.
Then it should be diluted with saline in 2/3 to 1/3 of volume.
Yeah. So what I do is I take 7 ml of the 100% alcohol.
Fine.
And then dilute with 3 ml. So it becomes 70%.
So it becomes 10 ml. And then,
yes.
And depending
yeah,
upon
you use it. Yeah, depending on the volume, you use it.
Depending upon
Hardly you use 1.6 or 1.7 ml.
Sure, sir.
And then add another 0.2 or 0.3 ml, so that there may be some loose losses by drainage.
Sure, sir.
Keep it for 5 hours. You will find dramatic improvement, I assure you, that you may not have to remove most of your catheters. But if somebody comes with septic shock, don't persist. Okay, otherwise, if somebody comes with fever and dry gas at every dialysis, you use it and then it will go away.
Something new, sir, and it's good to listen. I am excited about it. I will do it and I will let you know, sir.
Sir, absolute.
I request all the chairpersons to unmute themselves and then interact with Dr. Sampath. Dr. I will ask Dr.
Dr. PK Boss, can I just ask one question? Yeah, Dr. Sampath. So, as per your statement, this absolute alcohol is available for IV use. Is it available easily in the market?
Okay, the laboratory, they have absolute alcohol for DNA extraction and other things. So you can, you can get it from them.
So just make it 70%, okay?
Yes.
And then in a day, just you have to give once, or you have to repeat it?
Only once, 5 hours. 5 hours every day for 5 days.
Okay.
So ask them to come, and then see, most often our patients will be on alternate day dialysis. So even on non-dialysis days, ask them to come, have this ethanol lock, remove it, and then use heparin lock, ask them to go back, and then do it for 5 days. You will find good results.
Great, thank you.
Dr. Sampath, Dr. Sanjay here. In continuation with this, have you found any negative effects of the ethanol on the catheter? Because when I was using it,
I have gone through the literature and I found that it doesn't produce any negative effects. The carbothane, which we most of our latest catheters have carbothane, it doesn't affect.
Okay, sir. Why I asked you this is, see, when I'm using translumbar EBC pump cat, we keep the catheter for long. And my technician used to use the regular spirit, that is sterilium, along with the iodine solution.
Okay.
So, of late, what I was finding is, after 6 to 8 months of use of catheter, there used to be a crack on the catheter, the hub. So I thought it was because of the sterilium that he was using. So that is the reason I asked them to stop using sterilium and continue with only iodine. So now I am not finding that problem. So that is the reason I asked. Is
No,
there any
because-
other reason where you have found a catheter crack? Anything else that you can point to, since you are also using long-term catheters? Any other reasons, sir, that you can point to which may be causing the crack of the catheter, just because you are also using long-term catheters which are indwelling for long?
I am not able to.
Okay, sir.
Tell you, yeah.
Okay.
Sir, one question from my side.
Yeah.
You say once you have used this alcohol and we have been successfully used rather. So how when will you decide? Say suppose he's having recurrent infections. So how when will you say now this is the time to remove the catheter and we should not be using it again and again?
See, these are all not these are all not evidence-based. These are all individualization. So if you have patients who come to you even after 5 sessions of alcohol therapy, still if he continues to have it, I think you should not persist. You will have to remove it.
And suppose he does respond and comes to you again after say 3-4 months.
Yeah, I have used. I have used, because you see the advantage of ethanol is that it does not produce resistance, and biofilm formation. Every time you use it, it is able to reduce the biofilm, and drug-resistant bacteria are not selected. So I don't use only ethanol. I always use it along with systemic antibiotics.
Okay. So has there been any randomization, like you use it with the alone, alcohol with antibiotics and all?
Nice that you brought it up. I got a call from Dr. Narayan Prasad only a couple of days ago, and he was saying that we should have a multicentric study. I'm sure Varanasi and others can pitch in. We will do a good study and then publish it.
Yes, it may be a good study if we go for a randomized control trial in this.
Sir, did you notice any side effects? Any side effect apart from the suspicion of some catheter material? Nothing.
Sir, can it be used for the pure biofilms without infection?
No. How do we recognize those pure biofilms?
You usually see that the flow problems are there, but when you do the angio-C, there is no block. It is you probably has a proteinaceous sheath there which is blocking.
Yeah, I have not used it. I have not tried it.
Okay.
But possibly it may.
So, normally, what are you using for the catheter fills?
The catheter fills is only heparin.
If there are no questions, there are no questions in the chat box.
Just one question.
Oh.
Yeah, Dr. Sinha here. Sir, regarding 2 questions right now. One is regarding the tip position, because once you are putting the this renal catheter, the patient is usually in the lie down position in the cath lab. So mostly we try to keep the tip in the right atrium or so. Once the patient is in erect position or during dialysis, if he is sitting, the tip usually goes little up. So usually goes up to the junction. So what is your take on this issue?
No, I go up to the mid atrium, and then I am not very comfortable putting it too low. I put it at mid atrium on a lying down posture so that there will be an excursion up by 0.5 centimeters. So I think that will be the ideal way, because putting it too much inside the atrium, there is always a chance that the atrial wall can get affected, and if there is a problem on the atrial wall and also impingement on the valves, you don't want to have all those.
Thank you.
Excuse me, sir. This is Dr. Prem from Patna. Sir, I have one query to Dr. Sampath, sir.
Yeah.
Sir, have you encountered any complications or cardiovascular side effects after inadvertently or accidental spillage of large volume of 70% alcohol in catheter?
No, we are being very careful, and we see to it that we ourselves give this antibiotic lock and the ethanol lock. We don't leave it with the sisters, we don't allow others. So it is better that you yourself do it. And I have not had any cardiovascular complications still.
How long should we inside the catheter?
So I told you, it is 5 hours.
Okay, thank you, sir. Thank you very much.
So it was a wonderful talk, sir.
Thank you.
If there are no other questions, then we conclude the session. And
No, there are a few questions in the chat box. Let me complete because then the things will be. Just a minute. The question has been, sir, please guide if antibiotics perm cath locks are recommended or only HEP lock. One. And the second question is, volume of 70% alcohol, should it be as per the volume mentioned on the catheter hub or less?
See, the second question, you will have to just increase by another 0.1 or 0.2 ml so that you give allowance for some spillage inside the vascular tree. So slightly go, if it is 1.6 ml, give 1.8 ml. The other question is about the antibiotic lock.
Yes.
Antibiotic locks varies. The first use of antibiotic lock, I used it 15 years ago, was a very bad experience because I had used gentamicin lock for catheter infection, and after say 2 weeks of gentamicin locks, he developed severe vestibular toxicity, and then he said that he will sue me. So that was the last time that I used gentamicin locks. So I have been using cefotaxime, which is cheap, which is available, and this is not being now used in large numbers in our population. So the bacteria are not having so much resistance. So I have been using cefotaxime along with for my patients, especially infected patients, not for everybody.
You shared this experience in hemodialysis international conference in Delhi. I think when you used gentamicin and the patient developed autotoxicity and they had problems. But still good number of centers they are using
it.
Heparin, they add gentamicin to it and they fill it in the catheter. If there are no questions, I thank Dr. Sampath for an excellent talk on a topic which we are all facing. We are all doing tunnel catheters and coming across the complications. And you have nicely answered almost each and every query by our fellow nephrologist. And thanks again. And I think we should switch over to the next talk. Dr. Mahendra, over to Dr. Hemant Singh.
Thank you, sir, and thank you all the chairpersons. And
can you hear me?
Dr.
Yes.
Sanjay Srinivasa is there, and I just want to remind him that still some work of his is left, and probably next time we are going for that lumbar perm cath insertion live with your help.
Yes.
Yeah, very soon.
Maybe in the next conference, we are going to have you as operator and going for the lumbar.
Yeah, I am also eager, sir, because this needs to be, propagate as well, at least for the sake of the patients.
Yes.
Yes. Thank you. Thank you, sir.
So our next topic is about vascular access in cardiac patients. And the speaker of our on this topic is Dr. Tejinder Singh Chauhan. Dr. Chauhan, are you there?
Yes, I'm seeing there.
Yeah, good evening, everybody. I'm here, sir.
Dr. Chauhan is a senior consultant of nephrology and head of Department of Nephrology and Renal Transplantation in Fortis Escorts Hospital, Faridabad. Dr. Chauhan has got immense interest in renal transplantation and this procedural practice. So we'll look forward to him for a great talk and a great exchange of knowledge. I would like to invite our chairpersons. The first was supposed to be Dr. D.S. Bhadoria, but probably boss is not keeping well because of COVID. Next is Dr. Lalit Pursnani. Dr. Lalit, are you there?
Yes, I am there.
Dr. Lalit Pursnani is professor in Department of Nephrology at RML Hospital, Delhi, and he has a teaching experience of around 9 years, and he is proficient in primary glomerulopathy and transplant-related nephrology. Another chairperson is Dr. P.S. Patel. Hello, Dr. Patel, are you there?
Yes, sir. I am here, sir.
Very nice to hear your voice, man. So, Dr. Patel,
Yes, sir. Good.
DM from
Very good afternoon.
Dr. Patel did his DM from Institute of Medical Sciences, BHU, and he is presently serving as assistant professor in IGIMS, Patna, Bihar. So, over to you, Dr. Tejinder Chauhan. You can start now.
Thank you, sir. So, is my presentation is visible to everybody? Hello.
Yes, sir. It is visible.
So, good afternoon, everybody. After this, so this is the last presentation, I hope. And after a very excellent presentation by the stalwarts in the nephrology field. So, but I think that it should not be the least one because my topic is very important. Since the cardiac disease is the leading cause of death among the dialysis patients, approximately 45% of deaths. And when to compare the general population, dialysis patient has around 20 times greater risk of having the cardiovascular death. A great amount of data has supported this greater incidence and prevalence of heart disease in dialysis population, like in this HEMO study. When in this study, what they have found that around 1900 dialysis patient at the baseline, they have 80% have some sort of cardiac disease. And when they split it into the type of cardiovascular disease, the congestive heart failure is the maximum, that is around 40%, and equivalent percentage of the ischemic heart disease. And during their follow-up around 6.5 years, they find that around 1700 cardiac hospitalization with this patient, the 42% is because of the acute coronary events. There is around 343 cardiac death, which constitute around 40% of all death. So the cardiac mortality and morbidity is very significant in dialysis population. And one of the goal of RRT is to improve survival. So definitely it has to do something with the cardiovascular disease and the risk factor associated. And it was proposed that by the better control of fluid management, better control of hypertension, good control of anemia, and the better control of solute like phosphorus, etc., somehow we can able to reduce this cardiovascular risk and improve the patient mortality in this population. For initiation of RRT, we need access, and for the access choice, The KDOKI 2019 update says that in preference of central venous catheter, most of the incident and prevalent dialysis patient should have a fistula or graft. Although this is a conditional recommendation, very low quality of evidence in the favor of that. So formation of AV fistula in a dialysis population is not without side effects. In a very thought-provoking article by Richard Amerling and Claudio Ronco, they have enumerated all the side effects of a fistula, especially on the cardiovascular system on a dialysis patients. According to them, use of a fistula become mainstream without any prospective trial or consideration of long-term negative effect. They asked that why hemodialysis patients, even those who began dialysis at young age, do not survive beyond 20 years or so. Why the traditional risk factor of cardiovascular disease is not associated with mortality in hemodialysis patient, and somehow there is an inverse relationship is found. Similarly, CV interventional trial doesn't show much benefit in dialysis population. And why survival of preemptive transplant patient is higher than those transplanted after initiation of dialysis. So somehow, and why hasn't the increased prevalence of a fistula been associated with an improved first-year mortality till the date? So somehow, answer of majority of this question related to the dialysis type and the access that is a fistula. So let's see what fistula does to the cardiovascular system. Maintaining a fistula in one's body lead to several changes which can divide into the acute changes, which is occur immediately, then subacute changes, and then there is a chronic changes. When the fistula is created immediately, there is a loss in systemic vascular resistance. First, because of access related, because the extremity distal to it is bypassed, and which increase the shear stress to such a degree that release the various vasodilating substance like nitric oxide. That lead to the systemic vascular resistance goes down. So patient blood pressure fall acutely. To counter it, the sympathetic system is activated, and that lead to the increased stroke volume and increased heart rate. All these ultimately lead to the increase in cardiac output. And various studies have shown that the cardiac output is increased by several fold, around 10% by third day and 14% by the end of the 2 weeks. In the long term, it was found that within a weeks that the blood volume also increased because of greater vascular returns, and there is an increased right atrial, pulmonary artery, and left ventricle and diastolic pressures. So Reddy and et al. Try to find out what are the long-term cardiovascular changes following the creation of a fistula in a patient with end-stage renal diseases. What they have done, they retrospectively analyze the patient, and they do a 2D echo examination of this patient before creation of a fistula dialysis, and after a median time of 2.6 years. They found that the body weight of these patients are decreased, the plasma volume is also decreased, and systolic blood pressure is also decreased significantly. All the three changes are beneficial to the patient. They decrease the left ventricular remodeling and left ventricular hypertrophy, and help in prevention of left heart failure. But what happened to the right heart? They observed after their observation period of mean 2.6 years, right ventricle dilatation and dysfunction is developed significantly. So, as the congestive heart failure is usually traditionally linked to the systemic hypertension volume overload, these changes induced by fistula can lead to the heart failure or not, which is also shown by the Reddy and et al. That in their follow-up, they found that around 43 of patients develop incident heart failure in this patient. 75% of this heart failure patient has a preserved ejection fraction, but the patient in which the heart failure was developed, they have increased left atrial volume, increased right ventricular dilatation, and increased right ventricular dysfunctions. So apart from doing these things like increasing the venous overload, they proposed a scheme that creation of AV fistula in this patient increase the venous return of the in the body, which lead to the increased right ventricular volume and load. This right ventricular dilatation and dysfunction can cause the heart failure. Similarly, they also proposed that wasted systemic perfusion through the AV fistula lead to the increased myocardial demand, and there is a combination of right ventricle failure and the increased demand is caused the increased heart failure in these patients. So apart from this factor, if the formation of a preemptive fistula perceives a risk factor of heart failure, to answer this question, the Gallardo et al., they prospectively observed around 562 patients in which the fistula was created in around 160 patients. The main outcome of their study is that development of acute heart failure, dialysis initiation, planned or unplanned, or death. And in their study, they found around 17% patients develop at least one episode of acute heart failure in their follow-up. Using the multivariate logistic regression model, they found apart from the classical risk factor like age, female sex, obesity, diabetes, creation of a successful AV fistula was significantly increased the risk of heart failure, odds ratio around 9 times. So they conclude that the preemptive placement was strongly associated with the development of heart failure in these patients. And the most convincing piece of evidence is coming from the closer studies in the transplanted patient. Shire et al. In their cohort of 113 transplant patients, 29 patients underwent the fistula closure because of the symptom of heart failure, which was greatly improved by the closure of AV fistula. And when they compared the flow rate of intervention or intervention group, they found that the patient in which the fistula closure was needed, they have a high flow, around 2 liters per minute. So it has established that creation of high flow fistula is not always so innocuous for the patient, although initiation of dialysis help in patients in left ventricle remodeling and better volume control, but somehow it's also increased the cardiac output of the patient, and some patient with the poor cardiac reserve can lead to the high output heart failure. So what are the risk factors related to the access-related heart failure? Basis of various trials, it was found that these are the variable right ventricle dilatation, left atrial dilatation, development of atrial fibrillation, male sex, prior vascular access surgery, or high hemodialysis AV access flow rate, and the upper arm fistula. The most important is the AV access flow rate. Another thing which can be used to see the flow rate is the ratio of flow rate to the cardiac output, which is proposed by the Pandey and Litse et al., and they term it at the cardiopulmonary recirculation. And they said that if it is more than 20%, it is a high risk of high output heart failure is quite high. So it is obvious that the access flow and the cardiac output are somehow interrelated. As there is no cardiac output, there is no access flow. And we have seen right now that increasing the flow of the fistula can lead to the increase in the output. So what is the relation between these two? The Basile and et al., what they have done is that they chosen the 96 patient and in which the fistula was there, and they classified these patients according to the ACC-AHA criteria of the heart failure. And they also measure the access flow and the cardiac output on this patient by the means of ultrasound dilution technique. And they found that the relationship between the access flow and the cardiac output is not linear. They show a third order polynomial regression equation in which initially there is a little slope, but then there is a plateau. And after a value of 4 liters per minute, there is a steep rise in the cardiac output of the patient. Cause of this slow rise till the 2 liters is not clear, but there are two hypotheses for that. One is that some sort of myocardial reserve is there, or there is a myocardial adaptation is there. That's why the incidence of heart failure is relatively less in a hemodialysis population, as we can expect with the high flow fistulas. And secondly, at some point of time, there is systemic steal has happened. That's lead to the sudden deterioration. In their study, around 10 patients has in the stage C heart failure symptoms and signs. In these patients, the majority of these patients is shown in this slide as in the ellipse. These patients usually have the high output heart failure because their cardiac output is average output is around 8 liters and index is around 4 liters per meter square. Using the receiver operating characteristic curve analysis, they show that access flow rate more than 2 liters per minute predicted the occurrence of high output heart failure more accurately. Similarly, cardiopulmonary recirculation, that is the ratio of access flow to the cardiac output, is more than 20% predicted the occurrence of high output heart failure more accurately. So whenever we see a dialysis patient with symptoms of heart failure, we should try to evaluate it comprehensively and also consider in our mind the effect of fistula in these patients. We should go for a comprehensive electrocardiogram and also the non-invasive measurement of the excess blood flow. Echo finding which can point out towards the cause of this high output heart failure because of a fistula is that dilatation of vena cava, right ventricle enlargement or dysfunction, elevation of pulmonary artery pressure, left ventricle enlargement, although ejection fraction may or may not be poor in this patient. One has to try to identify the value of excess flow and the cardiopulmonary recirculation by means of non-invasive method, or if it is possible through the ultrasound dilution technique. And the convincing piece coming from the transient occlusion studies. It was first described by Niccolodeni and Branham named by their name, because the transient occlusion of the fistula, proximality to the fistula, can lead to the decrease in heart rate and the raise of arterial pressure, and also decrease in the cardiac output. And various studies have shown that after the ligation, the benefit of in the left ventricle hypertrophy more in those patients, in those patients with the cardiac output decrement is significant after the transient occlusion. Regarding management, Dr. Mehta has beautifully shown in his slides that we can go for the precision bending or surgical bending. Sometimes, if there is a refractory heart failure, we have to close the AV fistula. So, what should be the access in a cardiac patient? It is sometimes challenging. So, the choice of access should be individualized and based upon the patient cardiac status. Remember, always try to avoid catheter first approach. Why it is so? Even various registry data has shown that the usually cardiac patients various data like DOP studies also show that the heart failure patient is about 30% less likely to use an AV fistula for hemodialysis compared to the patient who are not having the heart failure. Similarly, Gruss et al. Has also showed that the similar finding regarding the use of catheter as a first line of heart failure patient. Various data has shown that the mortality rate, crude mortality rate, cardiovascular mortality rate, or infection rate at death is quite high in those patients in which the dialysis was initiated by the means of central venous catheter compared to the AV fistula, especially in the first year. Like Gruss et al., they have shown that the all-cause mortality rate is of 1.86 times higher. Similar finding by the Scottish renal registry data, Bray et al. Has shown the similar finding. And in this study, which I have shown, this is by the Roca Tay et al., this is a Spanish group who analyzed the registry data of the Catalan province of Spain in around 10,000 dialysis patients. And they found that in compared to the fistula as a reference, the adjusted hazard ratio of death was 1.55 for tunneted catheter, 1.43 for non-tunneted catheter, and 1.08 for the graft. As for the all-cause mortality curve, for catheter is always higher than the mortality curve of the fistula or the graft. And compared to the fistula as a reference, the adjusted odds ratio for all-cause mortality of these patients who started dialysis through non-tunneted catheter and tunneted catheter was 2.18 and 1.94 respectively. Similarly, finding with the all-cause method, the cardiovascular mortality and the infection mortality as well is similar and higher for the catheter-related initiation or dialysis. So why there is a increased mortality with the catheter even for the heart failure patient? Some can assume that because of the increased infection rate, but what about the cardiovascular mortality? It was postulated that this catheter act as a foreign body by means of the foreign body effect or the biofilm around it, which may be in absence of bacteremia act as a thing which can increase the heightened inflammatory state. And this heightened inflammatory state increase the cardiovascular mortality itself by the means of increased atherosclerosis and other things. An effect of which is very remarkable in this study that all-cause mortality of the patient switching from catheter to fistula during the first year decreased the mortality by half. Similarly, the patient who switched from fistula to the catheter during the first year, their mortality again remains sixfold compared to the patient who remain on the fistula. So this is the most convincing that in a heart patient, the catheter first approach should not be as a blind approach that if this patient is the heart failure patient, we have to start from catheter only. So ultimately, coming back to the original question, what access for which patient? To start with, first you have to do a thorough examination of the patient, including the a good 2D echogram. As the cardiovascular state is a major determinant of the patient's survival, it has shown various studies like Chua et al. They have shown that around a device separation model for the first day mortality on the basis of around 983 patients, and they've showed that the ejection fraction less than 45% has an independent predictor of both 90 days and first day mortality, and higher odds for the ejection fraction lower than 30%. Similar finding in the Yamada et al. Study. So first, examine the patient sign a symptom, try to classify on the basis of symptom, NYHA class 1 to 4, or on the basis of ACC-AHS heart failure stages. These stages help as a clinical tool to decide what access we have to use for any particular patient. So this is a proposed scheme for selection of vascular access type on the basis of cardiac state of the patient. These are the patients when the PD is contraindicated. So if the patient has a life-threatening heart failure, or patient with the ejection fraction less than 30%, or patient NYHA class 4, or ACC-AHX stage D, they propose that dialysis initiation should be done with the catheter. The stable patient, NYHA class 1 and 2, and ACC-AHX stage A to B, in these patients, a radiocephalic distal fistula, anatomical snub box fistula is the preferred approach to start with. So the tricky part with the patient, ACC-AHA class C or the NYHA class 3. In these patients, individualized decision according to the patient cardiac status should be taken depending upon patient's systolic and diastolic dysfunction. One approach may be that the start dialysis in these patients is try to stabilize this patient first with the catheter for some time, then reassess after some time. And if you see there is an improvement because the initial presentation of the cardiac state of the patient, maybe because of the effect of uremia, because of poor volume control. And when all these things improve after some time, we reassess the patient and then decide if the patient is suitable for the fistula or graft or not. Since the risk of heart failure is maximum with the fistula during the maturation period, the cardiac mortality is higher in the first year, especially if 120 days. The observation is very important. If the fistula is formed preemptively before the dialysis, we have to assess within 2 weeks for the patient, see non-invasively the fistula flow, see the echographic studies in this patient. If the fistula has been matured and dialysis initiated, first 120 days, it is proposed ideally fortnightly patient is evaluated. If it is possible, by the means of the ultrasound dilation technique, we have to see the flow. And if we have used the catheter, then I have said earlier, if there is an improvement, we can decide whether the patient can switch over to fistula or not. Remember, PD is always better to heart failure patient. because it allow there is no complication related to the access, and second, there's a better control of volume status because of daily ultrafiltration. But PD selection depend upon various variables: patient willingness, cost factors. Sometimes this cardiac patient is so frail it doesn't find any help in their family to help them to do this PD. So majority of time, these patients land up into the in-center dialysis only. So remember that wrong access choice in the heart failure patient can endanger their life. And the future is that predictive models are there. They are computerized program. There is a prediction is made that the what flow and what type of vessels characteristic one can assume what will be the future outcome of the fistula. This model has been validated in various population. Maybe in the future, they can guide us better in deciding what access should be for what patient. Thank you.
Well, thank you, Dr. Tejendra ji, for a very nice presentation. You have very well covered all the aspects of this presentation, along with the evidences that you can provide from the literature. And you have very well mentioned that for life-threatening heart failure, the patient should be first stabilized on catheter. However, once the patient is stabilized, further putting him on catheter creates another problem and decreases the life expectancy.
Definitely.
So now the house is open for discussion. The chairpersons are invited to take over. Dr. Lalit, are you there?
Yes, sir, I am there. Dr. Tejendra, a nice presentation. Just two questions, and first question is open to all. And first question is open to all. So what is your standard practice of advising a fistula for a CKD5 ND patient? When do you advise fistula creation in your patients first? And is there any data related to it, since making fistula preemptively increases the risk of heart failure in these patients? And third question would be, what is your practice for patients, since these cardiac patients, we are not talking about heart failure, patients with pacemakers, ICDs, how do you proceed for tunnel catheter insertion in these patients?
I will like to start from the second question. First of all, as far as the pacemakers are concerned, mostly I use the other side for the tunnel catheter insertion. If the pacemaker is there from the left subclavian, I use the right jugular, and we have almost safely placed 10 to 15 catheters by this means, without any accident or any other thing. When I tried to discuss with this thing with my cardiologist, he said if the pacemaker.
Dr. Mahendra, you are not audible properly.
Hello, sir, am I audible, sir?
Yes, now you are audible.
So when I tried to discuss this thing with my cardiologist, he said if the hello.
There is some connectivity problem, I think so.
Okay, sir. You take over, sir. You take over. I will answer it later.
Dr. Lalit, your question can be divided into three parts. The first part is that when to start plan for fistula in a CKD5 non-dialysis patient. So the guideline is very clear that when the patient approaches stage 4 or 5, we have to plan vascular access of this patient. Regarding the cardiac patient, this answer is not always very clear always, because these patients, majority of time, these patients will land up into the emergency with the volume overload status, and or not on the basis of GFR sometimes. We all agree in our observation that sometimes in these patients, when the GFR is less than, there's a CKD stage 4 even, when the GFR is around 15 to 20, because of their poor status, they land up into the volume overload very easily. So there cannot be a clear-cut cutoff for this patient that at what time we can think of starting the formation of a access of this patient. Regarding your second question, your second part is that which for the patient who are using the pacemaker and other things, So what is the approach? See, there are two things. The first thing is that theoretically what access is better for this patient. The second part is that how to create that access. So when we decided that this patient has to put on central venous catheter, this is the first part. This is, I think, more important part, that what access should be. Then there is a second part, is that how to do it. So you definitely, you have to choose that vein which doesn't have some wires put by the means of pacemaker and all that. See, as Dr. Mahendra said, that if the patient has a pacemaker in some side, you can do the other side for that. And sometimes you got the femoral permacath as well.
In fact, we have used the similar situation, and around we have inserted 10 to 15 permacaths in patients with pacemaker without any difficulty. When we discussed with this with our cardiologist, he told us that if the lead which is there inside, it fixes itself in some way. So if there is a chronic pacemaker is there, your guide wire or your catheter is most likely not going to dislodge that lead.
Okay, sir. And no, I was just asking from the house, what is their standard practice? I'm not discussing about heart failure patients at present. I said, what is your standard practice of prescribing an AV fistula to a CKD5 non-dialysis patients? What is your time creation for AV fistula?
Earlier the better.
And
less than 30 GFR, if you can create, it's the best. Earlier the better.
Sir, earlier the better. That means, you, as per the norm, some people say anticipated time of 6 months prior to dialysis. But is there any evidence, since we are already talking about fistula and cardiac failure, is there any data available that says that you create fistula 6 months before actually starting dialysis, and some percentage of these patients land up in heart failure later on because of the AV fistula? So should we change the practice from 6 months rather than anticipated should be around 2 months?
Yeah, very nice question, Dr. Lalit, very thought-provoking question as well. In my presentation as well, this question has been raised by other authorities as well, like Richard Everling et al. They also said that we have made the fistula as a standard of care without any long-term data with that. And the various other studies which I have shown in my presentation that clearly show that the formation of fistula found to be independent risk factor sometimes, preemptive fistula. Regarding the time initiation frame, so this is the tricky part. See, we need a large data to come up a clear-cut time frame to be, to be established, whether from 6 months or 2 months. So that it is the tricky part. It needs more data, more evidence in favor of that.
But Dr. Tejinder, initially, I think 5-10 years back, there was a paper which suggested that if you make fistula early, which Dr. Hemant Singh also endorsed, the chances of getting progression of CKD is going to be slowed down. And what you have just now, the data which you have shown the literature wise, that if you go for AV fistula creation, the chances of getting heart failure is more in these patients. So now we are in a fix. Should we go for AV fistula early creation when the GFR is more than 30 ml per minute per 1.73 meter square? Or what Dr. Lalit has asked, that how to deal with those patients who are in stage 4, stage 5 of CKD, and you have to, they are not still on dialysis, but you have to make vascular access in these patients. That we have to reach a practical solution for these things, because almost everybody.
Dr. Sinha also wants to say something.
Yes,
Sinha,
let Dr. Sinha come forward and answer.
Yeah. I think really it's a very tricky question, because few years back the fistula first policy was promoted by even all American organizations. So yes. Fistula first. Once the patient's eGFR is below 30, you always start discussing with the patient. When to create it, never asked. Never talked about it. Yeah. So at what GFR we should tell the patient or his or her relative that you should go for AV fistula. What's happening in the clinical practice that today EGFR, so you know the variation in the EGFR also, what we are calculating, the MDRD formula or whatever, even the EPI formula. So tomorrow morning, the patient is developing some
Keeps
infection
on
or so.
changing.
So you can't rely on that. So what patient profiles should be considered prior to advising for go for fistula early? What I'm seeing in the even the best hospital of this country, or even 5, 6, 7 creatinine, they are telling you no need to go for fistula, wait for some days, wait for some time. But how they are assessing patients, it's very difficult to, I think, understand. Another question to Dr. Chauhan. Do you have any literature regarding the effect of AV fistula on heart failure with preserved ejection fraction? Because whatever you discussed for the reduced ejection fraction, do you have any literature for preserved ejection fraction? What are the effect of those?
Definitely literature, there's a plethora of literature for that. The majority of heart failure in our patient is with the preserved ejection fraction. More than 75% of the patient of heart failure had the preserved ejection fraction. And I was shown in one study with the Colorado et al., they clearly shown that the formation of preemptive fistula has an independent risk factor regarding of the patient cardiac status as well. So see, the debate point is that should we delay or should we not? Definite answer will come by a large study randomized trial, which sometimes not practical, sometimes not ethical even to give this answer. This can only answer this question when to fistula has to be made. All this data depending upon the retrospective study, observational study, that somebody has done something and then we see the result of that. Till then, I can say, sir, your approach is the best. We have to be individualized, taking the individual patient consideration and think what best for that patient and what should do according to that only.
Ultimately, we have to make your own clinical decision based on the patient profile.
Until we have very definite data in the favor of that. Even fistula first has a low quality of evidence.
Thank you.
So very excellent presentation, Dr. Tejinder. And if there are no more questions, I would like to go to our President, Dr. P.K. Rai, sir, to consider giving vote of thanks after the rigorous exercise of this whole day. And when most of us are not well, and in fact, some are so unwell that they were unable to attend the session. So over to you, sir.
Thanks, Dr. Mehender. At the end of the day, I am very much thankful to everyone who really joined, and we had a good attendance as far as this WinCon 2022 is concerned. And I'm grateful to all these speakers and chairpersons, especially Professor Ramesh Tripathi, Dr. Hemant Mehta, Dr. Sampath, and Dr. Tejinder, and for joining the post-lunch session. And in the pre-lunch, despite being having infection with corona and recovering phase, Dr. Himanshu has really done a wonderful job. And as the Achint was also was interested, and we were part of our faculty team, but he could not join because of his father's illness. He took over and he nicely did all help to the topics which were assigned to him. And I'm thankful to Dr. Himanshu, and I'm thankful to all the organizing committee members, especially taking all efforts by Dr. Mehender, who has really tirelessly done a lot of work, homework for last 1 to 2 months for making this conference a grand success. And with the associated help of Dr. D.K. Sinha and Professor Sivendra Singh and Dr. Nitin Agrawal, this event would not have been possible despite having all the adverse situations during the corona pandemic, the third wave. And at the same time, I feel highly obliged to pharma people who have really come up forward and helped us by giving their generous support, as well as in wherever we have been in need, they have come forward and supported us, especially the Satyajit has really done very nice support to us, and I'm thankful to them for the support for this conference. And lastly, I'm thankful to Mr. Risk, really done a very nice work for this advertising as well as making this conference feasible on the virtual platform. And with all these words, if I'm thankful, if I do not name them, all the delegates who have participated and interacted with the surgeon and the speakers, learned speakers, and it has been a very, very interactive session and interactive conference. And chairpersons have also made it a very lively discussion. Thanks to everyone for making us obliged and making us our conference a successful one. And without participation of everyone, it would not have happened. Thanks again.
Thank you,
I
sir.
think if there are no, Dr. Mahendra, if we do not have any activities.
Sir, actually, we have noticed that the voice of Dr. Sinha sir has changed. So why not to
Yes.
listen something from him with a
Yes,
changed voice?
I will certainly, if he is feeling good and he has really also joined us, we will like to hear few words from him as well for this conference.
Yeah, thanks.
Good
I
to
think
see
I
you in this shape. I heard that you
Yeah.
were not feeling well, and it's really
No,
good
just
that you're seeing
I'm
you.
in the fourth
Gives us
day of
a
COVID.
lot of energy.
I'm fourth day of COVID. Perfectly okay, except my voice is not.
Still, we force you to speak few
No, it's okay.
words
It's
for
okay.
this because you
So,
are
I think-
part of the organizing committee, and we have taken all help from your side.
So I thanks a lot each and every person who contributed some or other way. But definitely I thanks Dr. Mahendra for his tremendous work, and Himanshu has done a great job. All these speakers, they have done their job so wonderful. All the presentation are very interactive, very informative, and very lucid. So I really congratulate each and everybody and to making this event very successful event. From core of my heart, I thank the organizers, the organizing committee, the team behind this organizing committee, the all pharma companies, all the speakers, all the delegates. Thanks a lot, and have a great day. Be safe, and hopefully we will meet soon in person in near future. Thank you.
Thank you, sir. Thank you.
And we never forget Dr. P.K. Rai sir, and we never forget that who has made this Varanasi Nephrology Society and brought us all in one platform.
Definitely.
I think no need to name him,
Yes.
because without him you cannot think anything.
We cannot.
We are all part of it, and I always feel that
that person left for America, and my energy just went down to 50%.
that was really very much needed from family side, family front satisfaction, and but somehow despite having all the adverse situations coming in on our way, we could do it nicely, and I'm thankful to God, because lastly we must thank God for all this, giving his and showering his blessings for making it a successful, because I can say Dr. Mahendra was quite worried about it, that how things are going to move. We cannot go for the live session. One second, he was worried that Achintya also has got infected with this, and his father is sick, so much so that he is admitted. I said that the show must go on, and we should keep this effort going for the conference on, and successfully, by the grace of God, we could do it. At the end, we can say that we could do it. And it has all happened because of the cooperation from each and every person of the organizing committee. And
yeah, great job. Great job.
It's really great.
Thank you, Dr. Jitendra. Thank you.
Thank you.
I'm not seeing Dr. Swinder because he always works as a backbone for us, not seen in front.
No, boss, I'm there.
Oh, you are here?
Yeah. I attended the conference.
Dr. Swinder is the real Bhole Baba.
No, boss, thank you.
Yes.
चलिए सर, यहाँ से लॉग आउट कर रहे हैं सर.
Yes, yes.
Okay, thank
Hello.
you.
They are
Thanks a
in
lot.
hurry for winding up everything.
Yeah.
We have created this war room in Oriana Hospital.
Yes.
Okay. Congrats.
Their internet and everything has been utilized properly. And now
And you may be in a hurry to leave Goriana now to go back home
maybe,
and
sir.
take rest.
Okay, sir. Thank you, sir.
Okay,
Have a
thanks,
great
thanks
day.
everyone.
Bye. 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 Bye.
Yes, bye.
Which one?